where you have glycosuria and yet you do not have fungal infections. There are people who have a mutation in the SGLT2. These people have glycosuria since birth, but they do not present with fungal infections. So fungal infection is probably a function of the hyperglycemia, not just the glycosuria.
Yeah, it's not a side effect, but the effect of the way it works.
Sir, of DEPA and EMPA, which one you prefer in this combination? Efficacy wise and side effects wise?
I wish I could answer properly, but I'll be honest because most of the pharmaceutical company have both of them now. Please sit, please take your seat. So these all the trials are dapacitamate because the trials were done, then DAPA was only loss of exclusivity was there. Now obviously we will be having trial with EMPA as well. After EMPA, whenever there is a cardiac smell, my pen goes towards EMPA. But whenever a bit of a kidney smell is there, my pen goes toward DAPA. But I think fighting EMPA with the DAPA probably not a big difference will be there. So most of the benefits are the class effect.
Yes, thank you.
Yes, please, sir.
Actually, we have been using DAPA the moment it came into the market. And sometimes it was being said like this, that DAPA is equivalent to glimepiride. Sometimes it was said like this, efficacy-wise. People, the clinicians thought of like this. The one big issue that I am having in my practice, that the female patients, most of them are having genital infection, and they don't disclose it. Unless you ask them, supposing many patients of mine, they're coming to my clinic with controlled blood sugar. So one day I thought, let me ask them, do you have any genital itch and anything? Yes, we are having some. And why didn't you tell me?
I'm sorry, you will need to shorten your question because we are running a little late.
The genital infection in the ladies, most of them don't disclose. What is your opinion regarding this?
Yeah, definitely. We always ask nowadays actually. This is like an ED. Whenever we are taking history, unless you ask specifically for ED, people will not come out. Okay. Thank you. I think time.
If there are no further questions, we'll move to the topic. Thank you, sir. And the next speaker is Dr. Lakshmi Nalini Kopalli, a good friend from my hometown. She is going to talk about why we no more call it a fatty liver. Why is fatty a bad word? I'm sure she will touch on that. The nomenclature has changed, but the disease is a fairly old disease. And let's first have the question, and then we can have questions.
Thank you so much for the kind words, sir. Good morning, everyone.
Sorry, you have a huge CV. So
cut it short.
Yeah. So Dr. Lakshmi Nalini Kopalli is from Hyderabad. She is one of the rising stars of Hyderabad in endocrinology. And she has a 1.5-page CV, which I don't think I'll read through. Do you have a slide so that people can just read the slide?
So this is...
No, that's the topic. Your CV? All right, yeah. Those two lines are important. Thank you. I've done my job. Take it away.
Thank you so much, Prasun, sir. Right. Good morning, everyone. Today, we would be talking about dapagliflozin. One of our colleagues here has said that he's been using almost since the start. That's May of 2015, a decade that we are using dapagliflozin. But then there is a step-sisterly treatment always to the liver disease in metabolic diseases, especially like diabetes and obesity. So today, we are going to talk about the combination of these two, decade of dapagliflozin, how is it impacting MASLD and how it should be impacting and how we should be looking at it, and how it has been now in 2025 finally incorporated in the complications of diabetes alongside other comorbidities. So today my talk is on decade of dapagliflozin, and this is my disclosure. This is a talk sponsored by USV, and this is only for scientific exchange, and the content is shared is based on the public scientific evidence and current clinical guidelines. So why this topic are we talking about? Why is hepatic health so important? There are no symptoms in many of our patients. So why are we talking about it? Because metabolism and dysmetabolism impacts liver. Liver is one factory that we have, and this factory gets impacted with metabolic diseases like diabetes and obesity. So when we were calling it non-alcoholic fatty liver disease, we are doing it a gross injustice. It's not just alcohol which impacts it. Not everyone is alcoholic or takes alcohol, but metabolic dysfunction, most of us, unfortunately in this room also we have. So metabolism associated steatotic liver disease was the correct nomenclature which does it the right, and it stopped being given that step-sisterly treatment when we are talking about comorbidities or complications of diabetes. As you can see, finally ADA 2025, it has been incorporated as one of the equal comorbidities. In fact, it causes much more harm than anything, and we've always called metabolic syndrome as cardiorenal syndrome or anything, but it is actually cardio-reno-hepatic syndrome, and how it impacts us, let us see in the following few slides. If you're with me here, start with that abnormal junk food that is being taken in. Up there on the slide, nobody will miss a burger or a pizza. So, right? So there we are taking a lot of fatty food in our diet, and that goes into the liver, and the fatty acids released from that, they go into lipid synthesis. When this lipid synthesis happens, always body prevents breakdown and synthesis happening at once. So what happens? Beta oxidation or breakdown of the lipids is being stopped. So beta oxidation is stopped, lipid synthesis is occurring. Neutral lipid is always an irritant. As you can very commonly see in the OPD also, the neutral lipid in the acne lesions of the patient also causes a lot of inflammation. Likewise, the neutral lipid deposited in liver activates the pro-inflammatory cytokine pathway, and that inflammation subsequently leads to fibrosis and liver failure. So why is it important? This complicated metabolism and mechanism in the liver, why is it important? Because the burden is huge. Trust me, my friends, in the Asia Pacific region, every third person is having a liver disease. The hepatic health is compromised. And when we talk about diabetes, we have crossed the 100 million mark. There are 10 crore plus people who are having diabetes. And every second person, more than every second person is having a liver disease. MASLD is present in every second person. And obesity, 350 million people in our country. And the picture is grim because 2 out of 3 people with obesity have liver affliction. And what are we doing about it? Ignoring. Are we asking in the screening of complications that when a patient presents with de novo diabetes? No, we're not doing it. So it's very important to understand that the burden is huge, especially so in us Indians. Why? Because we Indians are a little different. The way we metabolize our fats is different, and then our visceral fat storage percentage is different in comparison to the Western population. So there are a lot of drugs which are approved for treatment of diabetes, which is a major causative factor for MASLD. So when we look at all these drugs, we see that they are offering a lot of benefit to our diabetes. Resmetirom alone is one drug which is approved by US FDA, and it is not used for diabetes but for MASH and MASLD. So where is dapagliflozin? What have we understood? Dapagliflozin was first approved by ADA way back in 2014, and 1 year later we have approved it as well. So today, in 2025, when we stand here and we are writing prescriptions of dapagliflozin, we are talking about the hepatic benefit. Dr. Arpan previously has showed us very clearly how useful it is in decreasing the cardiac failure and deaths related to cardiac failure, renal diseases and renal events. This has decreased, and we know it very well. Then what about the liver? The important question that we need to ask about dapagliflozin and how we've used it. Till 2022, all the studies, DICLETIMI, DAPA-HF, DAPA-CKD, DELIVER, all of them, they have talked about the CKD events, they've talked about heart failure, and then in 2025, finally, Dean study has emphasized that there is a significant decrease in MASLD and progression to fibrosis and fibrosis improvement in those individuals in whom dapagliflozin was given as against those who were not. The improvement is to the staggering 23% difference is there, and Dean showed us that. So many of these things, studies have given us a lot of information which says there is benefit. But then when we are talking about benefit, are we doing justice by catching it early? That is the question that we all need to ask. So the evidence and the guideline from the ADA MASLD guidelines to Indian studies, including the MAP study and all these things, they just said one particular point. They all were in unison when they said, we need to screen for hepatic health and MASLD early, and early intervention in type 2 diabetes is essential to prevent fibrosis. So when we see this dangerously difficult slide, let me simplify it. Dapagliflozin plays a major role. How does it do that? By reducing hyperglycemia, definitely, reducing insulin resistance, and subsequently decreasing oxidative stress, ER stress, in pro-inflammatory cytokine production and inflammation, and subsequent fibrosis is reduced. And it increases beta cell functioning, it decreases insulin resistance. So all these mechanisms directly, hopefully, and then indirectly, we definitely have a proof that dapagliflozin has and exerts a hepatoprotective action. So what is our evidence to say hepatoprotective action is there? How is it changing the metabolism? Is it just simply causing glycosuria, weight reduction and causing it? Maybe yes, because weight reduction is primary and it is central to the improvement of hepatic health. So dapagliflozin usage and control of glycemia and weight reduction, they have seen that liver lipid deposition has decreased. When liver lipid deposition is decreased, what is happening? That liver deposition which has happened is one of the reasons for causing inflammation. So that inflammation is also coming down. Subsequently, fibrosis is coming down. Hepatic enzymes which were elevated earlier are now better. So this study, which was done earlier in the global platform, was now replicated, though in a small percentage, by our own colleague, Dr. Sambit. And they have clearly shown that dapagliflozin, there is a benefit with steatosis and also enzyme reduction. But the numbers are far too less to comment on fibrosis and progression of fibrosis. And the study by Mohopatra's group also said that it's an effective alternative to the gold standard insulin. So we are dealing with a drug which has potential benefit, which not just reduces glycemia, it improves, we know it very well, that it improves heart failure, it decreases the CV events, it decreases the CKD events, and it also protects the liver now. So similarly, a study done by Amartya Ghosh and his team also said that the steatosis decreased, fibrosis decreased, enzymes improved. All this is because of hepatic lipogenesis decreasing, beta oxidation improving, and subsequently anti-inflammatory and anti-fibrotic effects coming out. So the study was, again, the same results were found by Dr. Das and his team, that there is improvement in MASLD. So my friends, dapagliflozin is a very, very good drug, not just for heart failure, not just for the individual in CKDs, but it is also important for liver health. Hepatic health is important. That is the first thing that we have to notice. We have to give it its due importance. We cannot call hepatic health someday later when there are liver enzymes elevated. For every patient who walks in, I would urge all of you to calculate a FIB score, which is FIB4 score is very, very easy to calculate, and you will know what the risk is that we are dealing with. So what is our evidence about the outcomes when there is combination? Okay, right, dapagliflozin has benefit. When we are combining it, what is happening? Let's go about and see that. When we are combining, the meaning of this entire slide is this was combined with pioglitazone and individual effects of dapagliflozin, SGLT2 inhibitor, dapagliflozin here, and pioglitazone were compared individually and also together. It was found that the combination effect was synergistic, especially so for blood pressure reduction, HbA1c reduction, insulin sensitivity, beta cell function, as well as renal disease. So the synergistic effect complements dapagliflozin's action, and it's very important for us to understand that. So a study done by Dr. Sheshadri and his team was the first Indian study, and they again reiterated that the combination treatment was better and had an impact on decrease in the FIB4 score as well, and dual approach is beneficial than singular dapagliflozin. So consider combining it. Do not get worried about pioglitazone, because pioglitazone has fluid retention effects. But then dapagliflozin cuts down that fluid retention effect, and then it offers benefit. One second. Yeah. So this is another study with FibroScan. FibroScans, though they were out of 300 plus, about 200 plus patients, only 44 of them had stiffness. That stiffness also came down at 3 months. Within 12 weeks, 86% people showed favorable response with a decrease in the hepatic stiffness. So this is something telling us about something very important. When a combination of dapagliflozin with pioglitazone was given, fibrosis, grade 1 initial fibrosis is coming down. So SGLT2 and now was combined with GLP-1. See, SGLT2 has a very good, SGLT2 inhibitor has a very good impact on the weight loss. Now this is being coupled with a GLP-1 receptor. So you obviously expect a very greater amount of weight loss which is present. It is linked to improvement in liver enzymes and in insulin sensitivity subsequently improved, fat mobilization improved, visceral fat percentage decreased, weight loss was much, much higher. So all these were the benefits that we got. So a combination of SGLT2 with other drugs gave us a lot of improvement, not just in hepatic benefits, but in this hepatic benefit spilled over. And this spilling over of the hepatic benefit of the benefits of dapagliflozin were in the form of improved insulin sensitivity. So improved glycemic levels were there. So what do the guidelines say? See, this is all scientific evidence. So ultimately what came into the guideline? What came into the guideline was lifestyle measures along with proper medication use helped individuals with diabetes with MASLD. So weight loss is primary. Be it dapagliflozin, be it any drug, weight loss is primary. Lifestyle is very important. Nutrition and physical activity play a role. Moderation of alcohol is very important, and behavioral health. If you do it for a short time, it doesn't work. It is not a band-aid that we are giving. We are giving a new path for the patient to live in. So it's very essential to continue these things, and for that behavioral health needs to change. So MASLD treatment with type 2 diabetes, ADA 2025 places SGLT2 inhibitors at the top. When an individual has diabetes, the pharmacotherapy for MASLD with F0, F1 level is one of the important drugs is SGLT2 inhibitors. So what are the future opportunities? What are we going to do? We need to firstly identify that this is a major risk. We need to put liver health important and not give it a step-sisterly treatment. Comorbidities include this. So instead of saying metabolic syndrome, instead of saying cardiorenal metabolic syndrome, say it cardioreno-hepatic metabolic syndrome, which is the correct one, incorporating most of the complications which are killers. So let us include MASLD in the initial screening. Then explore the therapeutic pathways. Combine it with other drugs, combine it with pioglitazone, combine it with GLP-1 receptor agonists, combine it with fixed drug combinations, as Dr. Arpan was saying, and then we'll get more benefit. And then we need to collaborate. We need to understand when to refer, when we need not refer, because we are dealing with patients of about 100 million cases in our country. So the burden is high. Let's work together towards the health of the patients. And then we need to generate more research. We need to do more of liver studies. We need to do a biopsy-driven registry. We need to have more data to understand our population, which is different, in which liver is taking the maximum brunt of the disease. So the key messages are: burden is high, take care, dapagliflozin helps, real-world data is there to show us. We need more of Indian data, especially with regards to MASLD. Specialty integrated care is essential, and hepatometabolic integration as a standard should be our voice together so that we treat all our patients and give them a healthy life. Thank you so much.
Thank you, Dr. Lakshmi, for excellent deliberation. Here is some criticism of FIB-4 score. It is not, most of the cases you will see platelets are normal, SGOT, SGPT are normal. And therefore, one Indian version of FIB-4 score has been done by Dr. Neelratan Sarkar Medical College student, Dr. Rajat, who is practicing in my place. But it can be a population scoring, as NHS has done it in the population. But individual clinic, most of the time the platelet counts and SGLT will be normal. So it is not a very good score, as I suppose. Second thing is, the FibroScan is very much important. Most of the sonography is telling that grade 1, grade 2 problem of steatosis. But we cannot put all those patients on fibroscan. It was expensive, costing around 4,000 to 5,000 rupees. So that is a limitation. But our eyes should be open, as Dr. Nalini said, that all the patients should be investigated on the liver line. Second is, we have forgotten use of pioglitazone. We endocrinologists are doing it, but it is more important to use more frequently pioglitazone, which is nearly forgotten in our clinical practice.
Yeah, I agree. The FIB4 is, it has its limitations. The primary thing is that you include age in the calculation. And so for the very young and the very old, the sensitivity and the specificity is on the either end of the spectrum. So I'm sure there is going to be some other calculations later on, but at this point of time, I'm sure the speaker will agree. Right now we are using the FIB4 as the first grading this thing. When the patient comes, you do the FIB4 because it's a very easy thing to do. Once you have a score which is high, then you can do the elastoscan and the subsequent things. As Sir says, that elastoscan is not something that you can offer to all your patients, but FIB4 is, you can do that. So, do you do that in your practice also?
FIB score is mandatory for all my patients,
Right.
because it offers a very easy method of at least identifying those individuals who are going to deteriorate very fast.
Correct.
We may not
Correct.
identify everyone.
Yeah.
Point
Yeah.
is very well taken actually. But we need to do that to identify that particular patient who's going to go into fibrosis. If you don't do it, nobody else is going to do it. You are the person to whom the patient has come. Patient is not going to go everywhere. You are the one who's going to identify. So at least do a FIB4 score, and if you have an issue out there, then refer the patient for elastoscan, and that is how we protect the liver of this particular patient.
But the only problem is when the fibrosis of liver is there, so SGOT, SGPT will not be on higher side. And in most of the cases, you will see in very advanced child score of C, platelet count deteriorates.
Yes.
So that is the problem with FIB score,
Yes.
that you should remember. Any questions?
I was thinking of, see the lab, when we get the PFT, we automatically now get EGFR. I think whenever it's matching, it's somewhere maybe before delivery.
That's a very good thought actually. With simple elevations of AST and ALT also, sometimes the FIB4 score goes off, and that is when the seemingly innocuous values also tell us something. So those cases we probably miss them, and we can, yes. Maybe we need to put this thought into all the diagnostic centers where they automatically give the FIB4 score. Maybe we are at an easy place.
In a non-diabetic patient with MASLD, which is the drug approved in addition to saroglitazar in India?
Resmetirom is
Pioglitazone
one.
is not a drug which should be given.
Yeah, it is.
Pioglitazone is the only drug, and it is the only drug.
In non-diabetic, sir.
Resmetirom can be used, sir. Resmetirom is
It
approved.
is very expensive, and
Expensive.
really cannot afford it.
Recently been approved, sir. It's not DCGI, sir. Yes, sir. Only DCGI approved, only saroglitazar. Semaglutide is also not DCGI approved for this indication. Not yet, sir. Yes, sir. Yes, sir. Yes, sir.
But I believe all GLP-1 are effective.
It's effective, sir, but the recommendation has been for 2.4 milligram.
Hello. Sir, we see lot of patients with central obesity. And these patients supposed to have a visceral fat all along. So in most of them, they have a liver fat as well. So if the enzymes are well in control, not elevated, and the echogenicity is also normal, so enlarged liver, should you go for the any drug apart from the lifestyle modification or not? Because it's a precursor for, a lot of comorbidities. So if the liver is enlarged on ultrasonography, and the enzymes are okay, and the visceral fat, the central obesity is there, so should we go for any pharmacotherapy apart from lifestyle medication?
So we have to do the risk assessment. First and foremost is always a lifestyle assessment. Lifestyle intervention is essential. Bringing down weight is very important because this is a time bomb which is waiting to explode. Why do you want to wait and clean up later? We need to act proactively and then treat this particular patient.
can we add vitamin E or pioglitazone in those patients empirically?
Diabetes, if it is present, we can use pioglitazone. Vitamin E, there is no concrete evidence that it will provide
Right.
any benefit.
So there is no chance of empirical treatment of this pharmacotherapy?
We can use semaglutide for this particular patient. We need to emphasize on importance of weight loss.
Yes.
We can even use resmetirom, though it is very, very expensive. We can use even that, but though it is not approved in India, other places it is.
Okay,
approved.
thank you.
But
Thank you.
pioglitazone can be used for prevention of diabetes also.
Yes,
trial
obese
issues, right?
patient having a large BMI and central obesity and pre-diabetic condition is there. So in those cases, can we use pioglitazone empirically or not? Because IFG or IGT patients are there, they have central obesity and the overweight is also there. They don't have a good lifestyle, I think. So in those cases, though we have a IFG or IGT status, pre-diabetic status, can we use pioglitazone in those patients?
We can use, but I would like to take this question in two formats. Firstly, giving a medication as the first choice falsely lulls the patient into a situation that everything is handled. Numbers getting normal is not normal always. We need to emphasize on reduction in weight. We need to emphasize the requirement of lifestyle modifications, and these need to go for a long, long time, and the way of life needs to change. That has to be emphasized. When we do that, most of the patients actually do not require any pharmacological intervention, and it is very easy to control weight and eating habits, provided the behavior of such eating habits is changed and non-exercising behavior is changed. So putting a pharmaceutical therapy foremost at IFG phase itself, I would refrain from doing it, because the lifestyle measure has to be emphasized, and then pharmacological therapy. That would offer a long-term benefit for the patient rather than just normalizing the numbers.
Thank you, Dr. Lakshmi, for excellent discussing with the people, and thank you very much.
Thank you so much.
Next speaker is Dr. Rakesh Sahai. He is Professor of Endocrinology in Osmania Medical College since 2009. Today is Teachers' Day, so it is important to notice that Dr. Sahai was awarded Best Teachers in Medicine by Government of Telangana for 2018. Happy Teachers' Day. So he will discuss on eye starch, a decade of follow-up, developing practice, changing evidence of diabetes care. Eye starch is not a approved short form of any problem. Basically, it is when we treat a diabetic patient as a specific individual, individualization of treatment is important, but eye starch is Indian study to assess real-world carbohydrate consumption. And the point of care is towards the complications of diabetes. So there are few studies in India by Dr. Mohan and Kerala Diabetes Prevention Study. These two studies are the best studies in which we can see that when intervention of lifestyle changes, there is some positive effect. Dr. Rakesh.
Thank you, sir. Thank you for the kind words of introduction. Happy Teachers' Day to all the teachers in the audience. Everybody is a teacher, in fact. So I would like to say that, we are just changing gears. We were discussing about dapagliflozin, a lot about how it should be combined and how it can be used in hepatic dysfunction or MASLD. Now we are discussing, eye starch is not an intervention, but it was just a assessment of the dietary pattern of people in India, because we say that diet has an important role. Nalini was highlighting the need for lifestyle changes and not not jumping to medication and discussing about lifestyle, emphasizing lifestyle. So this is again in that direction. So this is it's called eye starch because it's sort of taken as an extension to the starch study earlier. So there was we had done one earlier study where we called it as the starch study. So I was not a part of this, but this is the steering committee here lists out the names here, and I think some of them might be in the audience. I think Nitin Kapoor was supposed to present this, but he's not here, so I'm given the task today. And So what I'll do is so basically, we know that we are going through this epidemic of diabetes and metabolic dysfunction. Nalini brought out about the importance of that every third person who is obese has metabolic MASLD. And we are seeing the numbers here of all the problems that we are all very familiar with. So I don't need to speak about all these numbers, but just to remind you that we are seeing a large burden of these metabolic problems, and we are different from the rest of the world in terms of having these problems at a lower BMI, with more of abdominal deposition of fat, with ectopic fat deposition also becoming very prominent, and that is contributing towards this increased metabolic burden. And what we are saying is that because of this we have this unique phenotype. All of you are aware of the fact that we develop diabetes at a lower age. We are more insulin resistant. We also have a rapid loss of beta cell function, again shown by several elegant studies where there was a comparison between Indians living in India versus Indians in other parts of the world, and also Indians compared to other populations. So all these studies have shown that we have a rapid decline in beta cell function, and the major factor contributing towards that may be the rapid urbanization and the rapid urban migration, rapidly changing lifestyle is probably contributing, because what we are saying is that genetics could be a factor, but on top of that has to be the lifestyle change, because what is seen in several studies is that there is a additional increase in risk caused by dietary changes that happen. So I just wanted to also highlight the fact that in various surveys we have, like this one which was done recently, we saw that there is a very high prevalence of diabetes at a younger age. So this is a known fact, but we have reiterated the fact that there is a huge burden of diabetes at a younger age happening in the third and fourth decades of life, and that also with a very even in those individuals with no family history of diabetes also tend to have a high prevalence of diabetes. As you can see here, a 9% prevalence even amongst those who do not have a family history. So that underscores the need for looking out for diabetes, and also understanding the fact that it's not just the genetics, it's the environmental changes or the lifestyle changes, the changes in the dietary patterns which are contributing. So if you look at various data from various studies, what has been suggested is that there's at least a poor diet, irrespective of genetic risk factors, is associated with 30% increased risk of diabetes. Even, there's one elegant study which looked at the polygenic risk score and tried to look out at dissect out the impact of diet on that in different genetic risk scores. And that study also showed that at every level of genetic risk, there's probably a 30% increase in the risk for developing diabetes caused by diet alone. So this highlights the importance of diet, that is probably an important driver of the epidemic, and there are many factors in the diet that have to be looked at: the cultural preferences, the individual needs of the individual, and also long-term sustainability is another important factor which has to be kept in mind. And we all understand that our Indian diets are rich in carbohydrates, high in carbohydrates. This is a typical diet. It's not the traditional diet. If you look at the traditional diets, probably they are not bad. Even though they had high carbohydrate content, they were not bad. But the current diets are probably high in carbohydrate, low in protein, and inadequate fiber content is all contributing towards towards this growing epidemic. So this is referring to the START study, which we had published about a decade back, 2014 specifically. So what was seen in that study was a simple study done across the country, where it looked at the dietary recall of patients with diabetes, and also patients with, also people without diabetes also. And what we found in that was that across because the assumption was that there are certain parts of the country the carbohydrate intake is high, maybe in South India it is high, North India it's not as high, and this study showed that irrespective of where you're coming from, the carbohydrate intake is to the tune of about 64% in 64 and 67% in patients with diabetes and those without diabetes. So showing that that is a significant proportion of the diet is from coming as proportion of the energy intake in the diet is coming from the carbohydrate content in the diet. So that led to a lot of awareness about carbohydrate content of the diet, and we spoke about this, heard about this in several meetings, and that has been the focus of attention. And so what has happened in this decade? So the idea of this study was to look at did this awareness make a change in the 11 years since that initial data was presented. So this is what was the premise of doing this iStart study. So that this study provided, was probably widening the scope of evaluation, looking at the other parameters, like looking at even the laboratory parameters, biochemical parameters, and also going about looking at how the person, what is the dietary composition of the individual, looking at a 3-day dietary recall, and also adding on other parameters like assessing the meal frequency, the daily water intake, and also looking at some of the lab parameters. So what was seen, this study included about 1100 participants across the country, and the mean age was 50 years, and they were more of not so young participants. The gender distribution was nearly equal, with greater representation from east and south zones, 30%, and the rest being from north, west, and central India. The type 2 prevalence amongst the participants was 62%, saying that about 37.5% to be precise, were non-diabetics who were in part of the survey. And what you see is that only about 50% of them are regularly exercising, and only 50% of them are following dietary restrictions also. Understanding the fact that we would advise dietary, we would give them a dietary advice to all our patients. In spite of that, we see that only 50% of them are actually following the advice, 50% of them are exercising. Alcohol consumption is not very high, to the tune of about 16%, and the other important questions that we asked was frequency of taking meals outside the home. That's to understand how the constitution of the diet is, whether there is more of processed food and all that. So we see that about 21%, almost about 1/5 of patients were eating out 2 to 3 times, more than 2 to 3 times a week, and about small percent, about 10%, were eating more frequently, eating out more frequently, and water intake was about 2 liters per day. And when you look at the macronutrient distribution, what we see is that there was, when you compare them in the type 2 diabetes versus the non-diabetic ones, what we see is that there is higher protein, fat, and fiber intake in type 2 group, lower carbohydrate and sugar intake, particularly amongst the type 2 diabetes, but average is still about 60%. So it has not come down much. It has come down slightly from what we saw in that survey. Because this is we cannot really say that it has come down significantly, because that was a different population, this is a different population, but around those 60s only, it is numbers around those 60s. But important point is that the diabetics tend to have lower carbohydrate intake as compared to their non-diabetic counterparts, and probably that's the impact of the education that we're giving them. And if you look at but important part is to understand between the distribution between the complex carbohydrates and the simple carbohydrates. About 50% out of that 60%, 50% of the energy intake was coming from complex carbohydrates. A significant 12% was coming from the simple sugars. So that is something which is not that is significantly high. And when you look at the fiber intake, it was only about 15 grams per day. And as against what we ideally wanted to be about 25 grams per day. And so those are the issues that we're seeing. And when you look at the distribution across different zones of the country, east, west, north, and south, you see that this difference is there across similar pattern is seen across different parts of the country, but east zone, the differences are probably lesser, probably saying that people here are more fond of the sweets, and they continue to so they have more of carbohydrate intake, even in spite of the diabetes that they develop. So I think that's the summary. And when you look at the distribution across different age groups also, you continue to see a similar trend of findings about the carbohydrate intake, the fiber intake, and the protein intake. And when you look at the gender across the two genders also, you find that it's almost similar, consistent pattern is seen, and there's probably no difference in terms of the use of macronutrients between the two genders. And when you look at the BMI categories, what we see is that the type 2 diabetic participants consume fewer calories, carbohydrates, and more proteins than fats than non-diabetes. Again, the BMI also did not have a significant impact on this. When you look at the waist-hip ratio, you see that waist-hip categories, you see that again there are significant number of people who are in the zone of more than 0.6 waist height ratio, and the distribution of macronutrients again is similar to what is seen in the other groups. And yeah, one interesting point that I would like to highlight here is that when you look at the frequency of eating out and the amount of the distribution of calories, the fat content in the diet is increasing in people who are eating out more frequently, and this is more of the unhealthy fat, processed foods, which are contributing towards the saturated fats and more of the trans fats, which add to the problem. And then when you look at the exercise status, and so it was the non-exercisers who consumed fewer. Type 2 diabetic participants consume fewer carbs and more fat with no change in the protein intake. Even amongst the exercise and non-exercise, it didn't change much. But important issues that I would like to say is that when you look at this comparison between these 10 years, probably there's an improvement in terms of reduction in the carbohydrate intake in the population, but it is not accompanied by an increase in the protein intake. And also the fiber intake has not significantly improved. So those are the disturbing trends that we are seeing. And what we are saying is that when you're looking at the calorie difference, I mean, in terms of the last 10 years, the calorie intake amongst even the type 2 diabetics has increased, and the male-female difference in terms of the calorie intake is reducing. So those are small observations that have come out of this this trial, this study, which could have implications. And so finally, what I would say is that there is consistent decline in the carbohydrate intake, which has modestly decreased, with the largest drop in the north and south zones. East zone has not shown much of a change, and fat intake has increased across all zones, more prominently in the type 2 participants, offsetting the carb reduction. Protein intake has not increased significantly, and there is a gap in terms of the fiber intake has not increased. And so these differences have been shown to be more in type 2 diabetic patients as compared to the non-diabetics. Now, if you look at various diets that have been recommended by different groups, you have you can say that this was a systematic review and meta-analysis done across different studies and different RCTs, and they looked at, particularly found that there are 4 dietary patterns which are commonly prescribed: low carbohydrate, Mediterranean diet, plant-based diet, and low glycemic index diets. And when you look at the efficacy of these diets, they're almost similar in terms of glycemic efficacy, and if you look at the improvement in cardiovascular risk factors, also more or less similar. They're not much different, much to choose between these diets. And so what we can say is that most of these diets are effective in terms of providing some glycemic benefit and also reduction in the cardiovascular risk factors. And these plant-based foods, but with unsaturated oils and reduced animal-based and processed foods are the way to go in terms of reducing the risk for cardiovascular disease. Do low carbohydrate diets always provide a benefit? Do they lead to cardiometabolic benefits? Again, this was a study looking at that, and what was an important observation here is that there is a probably U-shaped mortality with very high risk with very high carbohydrate intake, and also with a low carbohydrate intake also. Less than 40% also, you tend to see this problem with very low carbohydrate diets also. it's the quality of the carbohydrate that matters more. So it's whole grains, pulses, and fruits, and these things. The carbohydrate coming from the complex carbohydrates and in terms are better than the more processed foods. And so therefore we should also focus on the carbohydrate quality and not just reduction in the carbohydrate content. High quality carbohydrates provide cardiometabolic protection. Now this was another interesting study where they looked at Indianizing the Mediterranean diet, because we know that Mediterranean diet has anti-inflammatory effects. So they have proposed a schema for Indianizing the Mediterranean diet. From in our Indian diet itself, we could bring about changes to provide the benefits of a Mediterranean diet, and that is shown in this illustration. So culturally tailored Mediterranean style diets can significantly reduce the dietary inflammation in Indian patients with, this was particularly done in patients with cardiovascular disease. When you look at how the carbohydrate versus fat manipulation affects the metabolome, studies like this have shown that the different macronutrient manipulations can improve the insulin resistance. The low carbohydrate, high fat diets may confer additional metabolic flexibility as compared to the high carbohydrate, low fat diets. Now, if you look at data from our INDIAB study with a data-driven optimization model, what was projected is that diabetes remission can be achieved in newly detected diabetics with a carbohydrate intake of recommended carbohydrate intake of 49 to 54%, protein intake of 19 to 20%, and fat intake of 21 to 26%. Similarly, they have shown with this data-driven approach improvement. I mean, how you could prevent the progression from pre-diabetes to diabetes, and also seeing the prevention of non-diabetes to normal glucose tolerance to pre-diabetes can be prevented by these dietary interventions. So reduction in carbohydrate and increase in protein for both type 2 diabetes remission and prevention of progression of type 2 diabetes in pre-diabetes and normal glucose tolerance groups was shown with this data-driven approach. But this is something which has to be validated with a long-term intervention which does that. So finally, I would try to conclude in the next 1 or 2 slides by saying that the problem that we still see today is that there is a low protein intake. Because of this, there's reduced satiety, loss of muscle with sarcopenia, which is a common problem in our patients. So we need to prioritize and promote the use of plant and dairy proteins. Aim for about 0.8 grams of protein per kg body weight. Fiber gap has to be addressed. The fiber gap is responsible for the persistent postprandial glucose spikes, and they also have an effect on the gut health. So we need to integrate fruits, vegetables, whole grains, and target for a fiber intake of more than 25 grams per day. The fat quality imbalance needs to be looked at, and we need to encourage the use of MUFA and PUFA and limit the saturated fatty acids, particularly the trans fatty acids. Carbohydrate quantity is important, but quality is also important, and we should look at the complex carbohydrates coming from grains. So the key messages from this study is that carbohydrate heavy diets are shifting, but protein and fiber gap is still persisting, which is threatening the satiety, muscle health, and glycemic control. And type 2 diabetes, the counseling that we're doing to our patients is probably giving them a benefit in terms of their reducing the carbohydrate intake in the diet, but we still need to do more, and we see that these interventions are working, but we need to work harder towards increasing the protein intake and also improving the fiber intake. Thank you all.
Thank you, Dr. Sai, that was excellent. I was just drawn to one of the graphics. The difference between diabetics and non-diabetics was significantly small. It was almost as if diabetics were eating just like the non-diabetics. In the graphs, there was hardly any difference between the two groups. You think we are not doing our job properly?
Yeah, I think that's what we need to learn from that we are doing our job, but it's not enough. What we're doing is not enough.
And protein, the best thing is, of course, increase your protein diet, but you know how difficult that is from the social aspect. If you tell your patients to go home and eat mutton, he's probably going to change his doctor. So it's open to questions. Yeah.
So one question is that in a sedentary patient, I mean, though who doesn't have a lot more exercise or anything, what you recommend, a complex carbohydrate or protein? What should we include in a patient with a sedentary lifestyle? A complex carbohydrate or the protein?
No, it's not one thing that we need to recommend. It's both the things that we need to recommend. We need to ask them to have more of complex carbohydrates, increase the protein intake, and reduce the overall carbohydrate content.
Yes, that I want to say that it's a complex carbohydrate. No doubt about that. We must replace the simple sugar with a complex carbohydrate. But in terms of protein, a lot of sarcopenia and all these things are not dependent, I think, on the protein intake, because the physical exercise and all these, which are very important for, preserve the muscle strength and the sarcopenia and all this. So, including only the protein part in your diet, will it change the effect as well? If there is no physical activity or the lifestyle.
Absolutely. The point that you have brought out, the very important point, that all this is not useful unless it is accompanied by adequate physical.
Yes, that's why I asking.
Increasing physical.
Yes, sir. That's why I'm asking. Then in a sedentary lifestyle, or the patient
and also encouraging some amount of resistance exercise also.
Yes.
So that is something which has to be done without.
Sure, sir. That's what I wanted to come out. Absolutely. Is that the sarcopenia is not directly related with the protein intake. It's related with the physical activity as well. So in a patient with more age, I mean above the age of 60, so just inclusion of protein will not make that of a change if we don't go for the physical activity and all this.
Absolutely.
So in those cases, I think the complex carbohydrate is a better choice than the protein intake itself. So
yeah, I think that point is well taken.
Okay, thank you, sir. Thank you.
Two quick comments. First, I would appreciate the thought process. 10 years later, you thought that what has changed. And the second thing, a small comment. I was talking to Dr. C.S. Yagnik, Pune. The genetic contribution versus the lifestyle and the environmental. So if we stick to lifestyle, I think the genetic is only 5, 7 or 8%. 80-90% contribution is of lifestyle.
Yeah, so that's what I was just trying to highlight that point by saying that, there was one elegant study which looked at the polygenic risk score and looked at, the impact of lifestyle on each of these risks. There you have the low risk, high risk and the medium risk, and there you see that each of these categories, when the lifestyle is bad, that is adding on about almost 30% increase in the risk beyond what is coming from the genetics.
So very good study and talk. I'd like to ask you, with your experience and your perspective of why protein intake is lesser and how can we bridge the gaps?
Well, I think one of the things is that traditionally we are tuned towards more of carbohydrates, we have less of proteins, and that's one thing which is ingrained in our diet itself, and it's difficult to change that in terms of increasing the protein, because we know the sources of protein, and vegetarian sources of protein are again a little challenge in terms of increasing the protein in vegetarian diets.
Most important thing is
Yeah.
no, this no, this is
Source of protein. Yeah.
But still, carb consumption is same, whatever and wherever we are.
the most important thing is the poverty is associated with low protein intake. That we have to understand. And the people and government supplies are only rice or wheat and not pulses. That's the.
I wouldn't agree, sir, because at this point of time, the cheap fish is actually cheaper than vegetables. If you go and buy vegetables, it's more expensive than buying an egg or a small amount of
vegetarianism is very strong in many in our country.
Yeah.
That is a difficult.
So I see Dr. Sanjay Kalra, one of the steering committee members here. I would request his comments also.
my voice to say that the thought process is very good, and thanks to the organizers of ESICON for highlighting nutrition. A few messages that come across. First of all, nutrition is an essential part of endocrinology and metabolism. We should have nutritionists on board, but we should also understand the nitty-gritty of nutrition. We should understand macronutrition, how many calories, how much of protein, fat there are in whatever we are eating. We should understand mesonutrition, simple versus complex carbohydrates, essential versus non-essential amino acids, MUFA, PUFA, SUFA. All this, all of us should understand, and we should begin with ourselves. Eye starch is a good beginning. It reminds us that we have to do these calculations day in and day out in our patients. So that is the first thing. Thank you to ESICON for highlighting this, and thanks Dr. Rakesh for bringing this on board. The second thing is, apart from macro and mesonutrition, we also need to focus on micronutrition. That's the vitamins and minerals. And then coming to the question, it is cost first of all. Protein is expensive. Culture is another thing. We have taboos. Some people are vegetarian, others are vegan. The kind of fish that you would take for granted in West Bengal, by the time it reaches Punjab, Haryana, there's nothing left of it. And then when you make Amritsari fish, you get this much amount of fish, 50 grams, and then you put it in 100 grams of mustard oil. Where is the fish oil left? So it is a culture specific thing. But we need to raise the voice. Thanks, Dr. Rakesh, for that. So one is cost, I think. Second is culture. And the second is culinary taste, what we have grown up with, like Dr. Rakesh said, it's just ingrained. But each and every step, whether it is moving towards complex carbs or increasing protein, we need to take one step at a time, and we need to do it all together. Diet, exercise, each and every aspect is important. And we have had, I think, maybe Team USV is here, we have had culinary workshops in the past. That would be another sort of a good activity for future ESICONs, where we all sit and we learn how to cook. We learn how to increase protein and increase complex carbs in our diet. So Dr. Nalini, thanks for raising those questions as well.
Thank you, Dr. Rakesh. Thank you very much.
A very big thank you to all our speakers to making this session so enriching one, and a special thank you to all our moderators to conduct this session so smoothly with the initial glitches. Thank you. The next session is the oration program that is going to take place in the Subhas Mukherjee Hall. I request all of you to visit Dr. Subhas Mukherjee Hall, and we will resume at 11:15 a.m.
We are moving on to our next session that is sponsored by Novonautics, and I would like to call upon stage Dr. K.M. Surjanarayan sir from Bangalore and Dr. S.K. Sharma from Jaipur, who will chair the session. Thank you, sir. I request Dr. S.K. Sharma sir from Jaipur to come on stage.
He was in the other hall.
Oh, okay.
You can call him. Good morning to all of you. I thank the organizing committee to give an opportunity to chair this session. And there are 4 topics and 4 eminent speakers. And Dr. Unikrishnan is the first speaker. Dr. Unikrishnan, I know him for a long time, from the time he was in Cochin. He is an eminent endocrinologist, presently at CEO of Chalaram Hospital Institute, Pune. He oversees clinical care, Chalaram Diabetes Research Center. He has published many articles, more than 230, and he's on editorial roles of many journals. Dr. Unikrishnan, a good friend of mine, I please request him to join and give his talk on the standard of care with the newer insulins, how we are going to improve upon that. Over to Dr. Unikrishnan.
Friends, it's a pleasure to be here, and I thank Dr. Suryanarayan for the kind introduction. And I'm going to talk about how insulins have evolved over the years from human to analogs and then beyond. These are my disclosures. And if you look at the origin of insulin, it was many years ago from Banting and Best. And this was the dog Marjorie, who was critical to the discovery and delivery of insulin for the first time. From then on, focus has been on better and better insulins. And today, the focus is on lowering hypoglycemia and giving more flexibility, and also on weekly insulin. So this is the focus has been changing. And I'm sure that if Banting and Best were to see the direction in which insulin has moved today, I mean, they would be very happily smiling in their graves. So on that note, let me go on to my next slide. So this is the agenda for today. I'll talk about the standard co-formulation insulins, talk about basal, talk about boluses, and then some clinical pearls. So this is going to be just a journey, a high-level journey through insulin without focusing on small specific things. So if you see, premix insulin we were using for so many years. Today, endocrinologists are purists who don't prescribe premix insulin. And that's because premix insulin is like a ready-made dress. You'll have to fit into it. Either it's too tight for you, you'll have to lose weight, or it's too loose for you, you'll have to gain weight. So to give a very precise insulin dosing, it's always basal bolus insulin. Having said that, the various limitations of premix insulin, which is variability, many of them don't give 24-hour coverage, some need to be resuspended, and some have the so-called shoulder effect. The shoulder effect refers to the mixing between the rapid acting and the long acting, so that there is no definite border between the two. They are continuous with each other. So there's no position at which the rapid acting effect goes away and the basal effects come in, and it is a sort of a potpourri. But that has now changed with better and better insulins. Till for now we look at the Rhizodec or Ideg-Asp, which is 30% aspart and 70% degludec. To some extent that is, it's not the best among the insulins, The best among the insulin is probably degludec, but if you look at the combination, it is probably the best thing to happen to a combination insulin or a co-formulation insulin since the discovery of a premix or co-formulation. And that's also because this idagasp lowers the A1C, and many people feel that idagasp is only for insulin naive patients. There is data now that even for insulin treated patients, there is a robust lowering of HbA1c. Hypoglycemia is only there in the initial part. It's not that it's not there, it's always there, but if you see, it's only at the initial visit hypoglycemias are there, and over time from 28 to 17 to 14, it really comes down, and severe hypoglycemia is not there. The advantage of an insulin without much hypoglycemia is that you can titrate the dose without worrying about hypoglycemia and reach targets. So if you see, the quality of life improves, many people find it comfortable, and we use it. There's a lot of mealtime flexibility. You can give it with the most carbohydrate heavy meal of the day once a day as well. And that brings us to the standard of care in basal insulins today. And if you look at glargine U100, it has a lot of limitations like detimia, which is now not, of course, available. You can see that there's no 24-hour coverage. There is high variability because there are peaks and troughs. Fixed time of dosing is there, so you will not get that flexibility, and it's not truly peakless. If you see the peak of glargine, it's about 8 to 12 hours, whereas degludec has a minimum peak, and the duration of action of degludec is more than 42 hours, suggesting that among the insulins, probably degludec is now the future among the basal insulins. If you look at the efficacy of degludec, again you will see the A1C coming down by 1.8, and also you will see the fasting coming down by 64. When you compare degludec versus glargine, you will see that overall hypoglycemia is less, and sometimes in real world studies you can see almost a 90 to 92% reduction in hypoglycemia. So that is a very dramatic reduction. Degludec also has got lots of flexibility. You can tell your patients to inject it anywhere between 8 to 40 hours, and that has been, I think in recent times, that has been a very big success, because our patients can now inject it anytime. For example, if the patient has forgotten to inject it at say 10 p.m., the patient can inject it at 8 a.m. the next day and still take that day's 10 p.m. injection. And that brings us, so after the premix insulin or co-formulation, the best among which is idagasp, and basal insulin, the best among which is degludec, now we look at the standard of care in bolus insulins. So if you look at regular human insulins, they are stars, but they are not enough in today's world because they have a slow absorption rate. People have to inject it half an hour before meals, 15 minutes before meals. It's not really very practical. The action is slow, and this 30 to 60 minutes before a meal is very difficult when people don't know when they are going to eat. We cannot live like machines that we are going to eat at 1 p.m. today and I'll take my injection at 12:30, because at 1 p.m. may become later, it could become earlier. There are hunger hormones, so on and so forth. And the slow offset, because of the slow and prolonged action, let's assume the patient takes insulin at 12:30, the regular insulin, has lunch at 1 o'clock. Because of the 6 to 8 hour window, at 3 o'clock or 4 o'clock, the effect of food has gone and the patient's insulin is still there. That leads to snacking, and that delayed snacking can lead to hypoglycemia, making it very important that we look beyond human insulins, because human insulins are not that human paradoxically, and we need to shift to analogs because cost is not a big concern today. Analog insulin prices are coming down and they will come down. So therefore, if you look at regular human insulins, then you have aspart, and if you look at 5-asp, it is ultra fast acting analog. It's more physiological, which means if you take it at 12:30, you can have your meal at 12:32 or 12:35, and the insulin will be out of your system at 3 o'clock, and there's no need to snack at 4 o'clock. It has very early glucose lowering effect. A larger amount of insulin kicks in very early, and that gives you, that means less delayed hypoglycemia. and as you can see, can be injected 2 minutes before to 20 minutes after. This is very important in some settings. For example, at the Chalaram Hospital for the dialysis patients, they go into hypoglycemia. We can decide to give them even after their meal. We can decide to give them how much insulin to give. Children, the mother can decide when to give it. So pregnancy, when there's a lot of nausea, the pregnant mother can actually take it after their meals up to 20 minutes. So it has got a lot of clinical advantages in day-to-day practice, but because of the very short half-life, it has got greater efficacy. So I want to summarize by saying that Idagasp, Degludec, and Faster Asp are some of the innovations with insulin that have come when you look at regular insulins to analog insulins to these super analog insulins, and you can see greater A1C reduction and good target achievement. Nocturnal hypoglycemia is lower, variability is less, it will allow you to titrate the dose better, and of course Degludec is approved in pregnancy, so that is an important consideration. There's a wider window of dosing and people can take it even earlier or later, though I tell my patients please take it at 10 p.m. every night. There is some flexibility out there. And the pen device of course makes it convenient. The flex pen is very good. There are many other insulins, but if you see Degludec, Fiasp and Idagasp, they are excellent insulins. Of course there is ultra rapid acting Lispro insulin, which is also a very good insulin, and there is Glargine U100 and Glargine U300, but the best basal insulin continues to be Degludec. Now the other problem is suboptimal titration, because if you can't titrate the dose, you are going to not get to target, because if you keep on increasing the dose, at one point the HbA1c is 8 and your patient is getting hypoglycemia, you really can't push up the dose further. And most patients do not recall the titration discussion. You will tell the patient, 2 unit zyada kar do, sugar dekh lo. You may give a paper also, but the patients will lose the paper, they cannot titrate the dose, they will not do it. For that, now there are digital technologies that can be leveraged to optimize these, and some of these technologies are now available. This is the Dose Check app, which is a digital therapeutic. What it can do is, it can, based on the fasting glucose input, the previous insulin dose input, it can bring your patients to target, and Dose Check can achieve better titration. You can even set the target on your own. If you think the patient's target should be 140, you can set that target plan, treatment plan, and you can start with Degludec, target the fasting blood glucose, and you can set your own targets for hypoglycemia, hyperglycemia. So I think this is something that will really help patients to do so. In future, the future of diabetes and injectables and orals look very bright. We have of course semaglutide, tirzepatide, retatrutide, CagriSema, Icosema, so many injections are coming up. But the once weekly injections, the once weekly therapies are probably the future, because you have to inject it only once a week. And if you see, the other insulin that may come is a physiologically distributed insulin. Less weight gain and hypo benefit will be there. Oral insulins may come, will give you convenience, and glucose sensitive smart insulins will deliver insulin according to the glucose level. If you look at Icodec insulin, which is going to come maybe in a couple of years, weekly Icodec can reduce the number of insulins from 365 to 52. For that matter, even GLP-1. GLP-1 is a weekly injection, and that can reduce the number of injections from say liraglutide daily to semaglutide just 52 days per year. And that reducing the number of injections will improve the adherence, improve the convenience, improve patient satisfaction, and therefore that will lead to better outcomes. Friends, I think that these are exciting days for diabetes. This is a recent paper published. I was also an author in this paper in the Lancet Diabetes Endocrinology. Looked at Icosema versus basal bolus therapy in type 2 diabetes. Showed that Icosema was non-inferior with less hypos, less weight gain, less insulin dose compared to basal bolus therapy. So once a week, instead of 4 times a day, it's just once a week Icodec semaglutide combination. And this is the Icodec insulin, once weekly insulin. And of course, you know that injection semaglutide is already available in type 2 diabetes as well as obesity, and which is really changing the way we look at diabetes and obesity management. So we've come a long way. And as I mentioned, if Banting and Best were to be alive now, they'll be really startled, surprised, and smiling in their graves at what the patent which they gave away for just $1, they gave the patent for insulin, and that insulin has today developed into such a huge therapeutic armamentarium which has got some insulin for everybody, a bouquet that gives insulin according to patients' needs and keeps on giving in different forms and in different ways. Thank you so much for listening to me. It's a pleasure talking to you.
Thank you, Dr. Krishnan, for very lucidly telling how the insulin has changed over the last 100 years, and it has become more patient-friendly, the devices, and the quality of life will be better, the frequency of injections will be less, the flexibility is there, hypoglycemia is there. More than that, it can maintain within the time in range. That is very important. And we can take up some few questions. Doctors, anybody? Yes, sir.
We are using a lot of GLP-1 analog, which is delaying gastric emptying, or long-standing patient may have diabetic gastroparesis. So in such situation, the short-acting analog, will you change from short-acting analog to human insulin, or timing of short-acting insulin analog? Because gastric emptying is very much delayed for 5 hours. So what should be?
I agree with you. Now if the patient is having a delayed gastric emptying and that's going to delay the absorption and you're finding a delayed peak, then you can give a short-acting analog and see. But remember, if the food intake is very little, that is going to cause hypoglycemia because of the gastric symptoms. So here there may be a role of giving your rapid-acting analog after meal also and deciding. You can give it little later also. So another problem with long-standing diabetes is that all their skin under the abdomen gets fibrosed. So the insulin will take even more time to act. So if you give it regular insulin, that may take even more time. So the crux of the matter is you will have to assess your person's glycemic profiles after the meal. Maybe you can tell the patient to do it after 1 hour, 2 hour, 3 hour, or put a CGM and then decide which one to take. But I agree that it's a good idea to use regular insulin if there is gastric emptying time and peak is delayed, but you have to individualize. One size doesn't fit all.
Yes, sir.
No, nowadays it is very common to have a search in the Google. If I go for degludec, it is a straightforward eating, it is not FDA approved for pregnancy. And at the same time in India, it should be used with caution. Many patients, sir, I have seen that it is not FDA approved, so you are using it. What is to do in this?
Well, in pregnancy, if you need a basal insulin, the 2 insulins you can use are degludec and glargine. Degludec is also can be used in pregnancy if required, and glargine can also be used in pregnancy if required, and you have to use for good control. If you want to choose an insulin based on the availability, we are not talking about US FDA, we'll talk about India. If you want to choose an insulin based on the availability of a randomized controlled trial plus real world evidence, it is degludec. If you want to choose an insulin, basal insulin, depending only on a real world evidence, it can be glargine. So if you want to use it for pregnancy, it should be degludec. US FDA is a different matter, but in India, it can be prescribed.
No chance of litigation, I think.
Sorry, sir?
Chance of litigation, that is the problem.
No, sir.
No, DCJ has approved degludec.
Okay, thank
Glargine, somebody is already on, you continue, but may not start. Wise thing is you don't start glargine per se, but if somebody already on, you continue. That's what they advise.
Detamir is not available also. If the sugar goes high, that has got higher chance of litigation if we allow the sugar to go, because these are good basal insulins.
Any other questions? Hospitalized patient.
So there are studies of, there is a study of degludec in versus glargine, if I'm not mistaken. It's even an RCT showing that you can use degludec or glargine. Glargine probably easier to titrate on a short-term basis, but degludec, it is also shown as equally good to use, especially if your patient is on Degludec. Instead of switching to Glargine and dealing with the problem, you can continue it. Second is, you expect this patient at discharge to be on Degludec, it's better to put on Degludec and see. But I agree with you, you can individualize and choose better, because Glargine is short acting, but you may require to give it 2 times a day also sometimes. Yes.
Yes, sir.
Yeah, so please come to the mic. There's some
please,
gentleman
sir.
waiting.
Yeah.
I don't know if time is over also.
Yeah,
Tell
I
me.
think the last.
At the outset, today is 5th September, so I pay my respect to all the teachers in the hall and the Happy Teachers Day. And just one query. So this Degludec's duration of action is 42 hours, and if we push every day administer, sometimes we have to give twice a day also. So how the cumulative effect is managed?
So Degludec has a very unique form of kinetics where there is no stacking. That's because if you inject 10 units, 5 units will be under the subcutaneous tissue and 5 will enter the blood if you inject 10 units. Second day it will be little more, third day it will be little more. By the fourth day you give a particular dose, 10 units will be getting in. Almost 10 units will be getting into the blood. So whatever you give is there, will get into the blood the same time. Which means, number one, there is no stacking. Number two, it means that you are getting a physiological constant basal flow throughout the 24 hours. Because of these factors, that is the reason why Degludec can be used and with minimum variability, even if it is to be used twice a day, beyond 8 hours, of course.
Yeah, last question, sir.
Sorry? Detimir is an excellent insulin in pregnancy, but now I believe it is not going to be available, or it's available but it is going slowly away from the market because of 2 reasons. Because of the lesser need to manufacture it and the availability of an RCT in pregnancy with Degludec. Because of those reasons you may not get Detimir. Even some of my pregnant patients who are on Detimir, I'm telling them we don't know how long you'll get it, so please accumulate the stock, because Degludec is available. So better now to shift to Degludec.
Degludec may not act for 24 hours. Sometimes you may have to give one twice, like Insulatard or...
Detimir.
Sorry, Detimir. Sorry, Detimir.
You'll have to give it twice a day in many cases.
Yeah. I think I thank Dr. Unikrishnan for that excellent talk. And
thank you. Thank you, everybody.
Dr. Shashank Joshi has come. Yeah, sir. Yeah, our next speaker, Dr. Shashank Joshi, he doesn't need any introduction to this August gathering. I think we can straight away listen to him. His biodata is quite vast. I may require 2 hours to read his biodata. Thank you, Dr. Shashank Joshi. Over to you. He's speaking on the this GLP-1 agonist. And over to you, Dr. Shashank.
So I think, thank you, Doctor, and I should thank Sujay and his entire team, Kaushik, and everybody from ESICON 2025. And semaglutide is a very hot topic, and your next 3 talks are all on semaglutide, and there's a lot of global interest in this. People think the semaglutide as a molecule has some unique features which are distinguishing it from other GLP-1 analogs, and it's highly evidence-based. So my talk is a Novo talk, and I'm going to talk about the soulful perspective of it. So that's my duality and conflict of interest. So we always need data, and we know that after the Rossi controversies, CV outcomes became a standard of care. And oral semaglutide had its first data on established CV safety in type 2 diabetes with Pioneer 6 results. And if you see that, though it was non-inferior, there was a 21% MACE reduction, 51% reduction in CV deaths, and 49% reduction in all-cause deaths. So clearly you could see that oral semaglutide, which is 3, 7, and 14, is here to stay. But the FDA mandated SOUL, a trial which was a large randomized double-blind placebo-controlled study with more than 9,650 patients, to assess CV safety and potential benefits of oral semaglutide in type 2 diabetes at high cardiovascular risks. And therefore they were randomized in a very typical way, and they were looking at whether it can lower the risk of 3-point MACE versus placebo. That was the intent. The key features were, they were gender neutral above 50, with type 2 diabetes with a A1C between 6.5 and 10, with at least one of those 4 conditions, CKD, symptomatic peripheral artery disease, cerebral vascular disease or coronary artery disease. And the key exclusions were 60 days prior to that, if there was an event, they were excluded. If there was a revascularization, they were excluded. If there was a prior history of treatment with a GLP-1 analog, they were excluded 30 days before. Or if there was a class 4 heart failure, they were excluded. And clearly, if you see from a demographic standpoint, there was definitely a little male preponderance. Mean age was 66, A1C was around 8, BMI was around 31, duration of type 2 diabetes was 15.4 years. And if you see, Europe and Asia had a population. So if you see worldwide, there was a distribution between Europe, Asia, North America, because many of the outcome data which is done worldwide not necessarily includes Asia and India. And therefore, if you see the ethnicities, you could clearly see that a large population was hypertensive, had 2/3 had at least coronary artery disease, 1/3 had cerebrovascular disease, 23% had chronic heart failure, 15.7% had peripheral artery disease, 42% had CKD, and the mean eGFR was 73. The concomitant medications were RAS blockers in 80%, beta blockers in 64%, lipid lowering drugs in 88%, antiplatelets in 77%, diuretics in 42%, with metformin, insulin, sulfonylureas, DPP-4 and SGLT2 inhibitors in a small percentage of patients. But very, very clearly, there was a compelling outcome. And that compelling outcome was that there was a clear-cut, statistically significant decreased risk of MACE by 14% versus placebo, with a hazard ratio of 0.86 for superiority on O-sided. And you could see that the number needed to treat was 50, and clearly you could see a very early and a sustained separation of curve. That early separation of curve is very compelling data, and that is something which is consistent with probably the molecule, and that is something which we need to see as the other GLP-1 analogs unfold. If you look at all the components contributed to the results of the primary outcome, with non-fatal MI being the greatest driver of superior outcomes. So if you look at CV death, non-fatal MI, non-fatal stroke, 26% was non-fatal MI. That was a primary driver, but all the 3 contributed to the MACE. Very clearly you could see that oral semaglutide from the SOUL data shows the greatest reduction in non-fatal MI of the 3-point MACE with people living with diabetes from the available agents of GLP-1 receptor analogs. Whether you take Excel, Leader, Elixa, Rewind, Harmony Outcomes, Amplitude, Flow, Sustain 6, Pioneer 6, Freedom CVD, you can see very clearly this is the most compelling data set, which is very, very clear cut. Even if you look at the reduction of risk, it is consistent across all subgroups. And clearly you can see that across every subgroup, you could see whether it is gender, duration, age, A1C, baseline, regions, you could see compelling statistics again. So the largest reduction of MACE was observed in people whose A1C was above 8% and those who are from the Asian geography. And India was no exception. This is very similar to the EMPIRE outcome, again, which had a very similar outcome data from the Asian and Indian geography. So this is very clear that you can see 2 large trials almost separated by a decade, which is very clear. So SOUL reinforces the evidence for cardiovascular benefits with GLP-1 receptor agents. And when you look at the secondary outcomes also, the data is pretty compelling. For example, oral semaglutide clearly decreased the cardiovascular death by 7%. And very clearly you can see that the events are far lesser. If you look at the composite outcome for hospitalizations for acute and chronic limb ischemia, which is the male component, clearly you can see that even in this group, you can see that oral semaglutide decreased the risk of male composite outcome by 29%. And when it came to the renal outcomes, again you can see the 5-point major kidney disease events of the composite outcome of CV related death, kidney related death, persistent more than 50% reduction from baseline from EGFR, persistent EGFR less than 15, initiation of chronic kidney replacement therapy. You could see that very clearly oral semaglutide decreased the 5-point major kidney disease risk event by a composite outcome of 9%. And you can see the mean EGFR decline by minus 32% at 4 years, and the consistent reduction in the annual GFR decline across all subgroups. And if you look at the renal, which was presented at the ENDO 2025, a real-world sub-study, again you could see that the oral semaglutide led to a meaningful reduction in albuminuria without affecting the GFR slope in people living with type 2 diabetes. So across the CKD severity, again you could see very compelling data from semaglutide oral. And if you look at the sole CV outcomes by SGLT2 inhibitor use, oral semaglutide appears to reduce the risk of MACE regardless of the use of SGLT2 inhibitors, because SGLT2 inhibitors were around 26%. So people would say that, would that alter the data? The data is very clear cut. Independent of the baseline SGLT2 inhibitors, there was a reduction in the risk of MACE. And you could see here the data reduction is to the tune of 11%. If you look at non-fatal MI, the data is even more compelling. 32% reduction if there's a baseline SGLT2 inhibitor, and that data is also pretty compelling. And when it comes to non-fatal MI reduction risk, that data is there. The final data is non-fatal stroke. Again, you can see a 19% reduction on the non-fatal stroke, and that's something which we recognize. So if you look at the secondary analysis of the CV outcomes by SGLT2 inhibitor use with oral semaglutide reduced the risk of MACE independently of the baseline use of SGLT2 inhibitors, and it suggests similar benefits whether you use SGLT2 inhibitors or you don't use SGLT2 inhibitors. So that's a very compelling data. A similar safety profile of oral semaglutide was observed in participants whether you use SGLT2 inhibitors or you don't use SGLT2 inhibitors. And overall, this analysis may provide clinicians confidence to combine GLP-1 receptor agents with SGLT2 inhibitors in people with high compelling CV risks. So clearly, if you see, the safety profile of oral semaglutide was already established before SOUL. But when you look at the adverse event profiling, the severe adverse events were reported in fewer participants in the semaglutide group. The differences were mainly driven by infections and infestations or cardiac disorders, and the adverse events leading to permanent discontinuation were a little more common with semaglutide compared to placebo. The difference was mainly driven by the GI, pre-existing GI disorders. So that's the only probable caveat there. So finally, to conclude, it's a very hot topic because oral semaglutide will maintain its lifeline. It has a special snack, and it will maintain its lifeline for a period of time. And it is available, and also in diabetes it has very compelling data. But 25 and 50 milligram oral semaglutide is also being developed for obesity, which will be available in times to come. But from this SOUL data, very clearly you can see that oral semaglutide reduces the risk of MACE by 14% with people with type 2 diabetes, with an additional impact on cardiovascular disease or CKD on top of standard of care. The CV benefits of oral semaglutide are across all groups. The largest and the best effect was seen in the SOUL trial in people of Asian and Indian geography and people whose A1C levels were above 8%. And the overall safety profile of oral semaglutide in the SOUL trial was similar to that observed in previous clinical trials. One thing is very clear, that oral semaglutide is the first and the only oral GLP-1 receptor agent with proven cardiovascular benefits. Of course, there was some data presented this week in Madrid of the competitor molecules, but that's something which I'm parking out because when this slide was made, it was probably earlier than that. But the compelling data of SOUL is difficult to replicate across the entire comprehensive CV risk management spectrum. Thank you so much for a patient hearing.
Thank you, Dr. Shashank, and we can have some questions. Now we have got injection semaglutide and oral semaglutide. So do you have any particular patients where we can use injection oral, or anything is okay, which is patient acceptable?
So in the diabetes space, I think we have option of oral and injectable both. Cost is the only differentiator currently, and of course the ease of use. My next two speakers are going to talk on the injectable, and it is manufactured by the same manufacturer. But at the same time, if you look at the data generation, SOUL is a very compelling data across all endpoints, so that if you look at pure data, and we have used oral semaglutide for the last 2.5, 3 years successfully. There were challenges, we have to start slow, go low, but we have used it in the diabetic population, and we have also observed a reasonable weight loss with it. Tolerance has been an issue, but if we start slow, go slow, I think it has been quite reasonable. But injectable agents will have more compelling data, and I'm sure Sanjay and Krishna, who are the next two speakers, will definitely educate more on the injectable, so I don't want to steal their thunder, and they will probably in a better position. But if we are not here to debate the two molecules, we are here to show the data of SOUL.
In diabetic kidney disease, patient is on ARB, SGLT2 inhibitor and finerenone. Will oral semaglutide will further reduce the decline in eGFR or and above all these three molecules?
So it will have to be individualized, because if you are already having all these three agents on board and you are still looking at a compelling agent in diabetes space or weight loss space, and if there's a need to give oral semaglutide, one can use it. At best, it will, the eGFR from the SOUL data, all I can say is it will remain flat. But in a particular case, because here you have added finerenone, that changes the entire equation completely, because that also has compelling data, if you ask me. So therefore, I am not so sure whether addition of semaglutide will make a difference, but from SOUL data clearly, if you had just semaglutide on board and didn't have the finerenone on board, you would still have compelling data. That's what it indicates.
And all the cardiovascular benefit, they started long before weight loss.
Which is why probably, as I told you right in the onset of my talk, semaglutide has something more in the molecule compared to the other GLP-1 receptor agents. There is something in the pharmaceutical moiety of semaglutide, not in the snack, but in the semaglutide, because you will see a similar data which will be presented by the next two speakers, which is also very compelling. And it is across the entire comprehensive spectrum of kidney, heart, peripheral vascular disease, brain and liver. So if you look at the organ protection of this molecule, probably has something to do with it, and the early separation of the curve, and that also early separation of the curve is consistent with oral and injectable. So it is definitely something beyond just a GLP-1 class effect. It's definitely got to do with the molecule.
Thank you.
Thank you, Dr. Shashank. And Dr. Shashank will be there. Any more questions, you can always clarify by Dr. Shashank. Thank you. So from oral semaglutide, the next is injection semaglutide, which is available to us, the step 2 trial. And we have Dr. Sanjay Kalra, a good friend of mine, who is a very great orator, very fine, humble person. He is a past president of the Endocrine Society of India, and he has got a lot of achievements in his life. Past president, Indian Professional Association for Transgender Health, very important today. And more so, vice president, South Asian Obesity Forum. And I request Sanjay to speak on this STEP trial, how it can modify the management of obesity and also patients of diabetes with obesity, how it can help us. Over to Sanjay.
Thank you, sir. And my topic is one step ahead. Thanks to everyone who is here today. But may I request the people at the back to take one step ahead. We have 7 or 8 chairs here in the front. So all the lovely ladies, if you could come in front. We can easily have 9 people. I will not start until you do that. So all the lovely ladies. Sir, that is the secret that we are not supposed to tell anybody. But all those at the back, we have 9 chairs here and then 3 in the beginning. Mr. Shibu, please come up. Yeah. No, please come up. Otherwise, I will not start. It doesn't look nice. And then we have a lot of space at that wall and this. At least you'll feel more comfortable. Yeah. But see, the 2 ladies whom I am looking at, देखो आंखों में आंखें डाल के देख रहा हूँ. आ जाओ, please come in front. और तुम्हारे पीछे पीछे पता है क्या होगा? 8 handsome men will also come behind you. आ जाओ. And this is one step ahead. Thank you, Dr. Bandhu, sir. Thank you so much. But देखो और seats खाली हो गई हैं, अच्छा नहीं लगता, and we still have the entire day to go. Please come in front. All those who are at this gate, आप आ जाओ ना, there is so much of space. Oh, madam. We are still waiting for the lovely ladies. हाँ. Thank you so much. ये बिल्कुल front ये white वाला मैम, ये इधर आ जाओ. ना फंस गया ना, मैंने बोला था फ्रंट में आ जाओ, कहना नहीं माना तुमने मेरा, अब मानना ही पड़ेगा. एंड यू कैन कॉल अ फ्रेंड, सो एटलीस्ट 3-4 more people and then people here. यहाँ भी तो चेयर्स हैं तुम्हारे पास ना, either you sit or you get someone else to sit. हाँ. देखो मेरे 15 में से 5 मिनट तो निकल ही गए. But this is what one step ahead means. And what this means is, what it shows us is, we have so much of resources. We just need to be a little bit resourceful. We feel that we are opposed by obstacles, but there are so many opportunities. And even after this, we still have opportunities for more. So I tried my luck with the lovely ladies. Now let's try with the handsome men. And here we have Dr. Krishna, the handsomest of them all. Sir, a chair in front, specially for you. Clapping Dr. Krishna के लिए. And ये बहुत important है, because he is the next speaker. If he doesn't get a place in front, who will he speak to? So this is what one step ahead means. The same challenge we are facing in endocrinology today, in medicine today. The diseases that we confront are changing. Earlier we had smallpox, we had polio, then we had diabetes, then maybe an epidemic of hypothyroidism in our country. We fought COVID successfully. Dr. Ashok, you've been a great fighter against COVID. There's a seat in front right for you. And 3 chairs for Dr. Ashok, DM from Kolkata, so he is coming back home. And the only way we were able to enter the hall was, we stood outside, Dr. Manoj Kumar, another Kolkata alumni, Ashok Kumar and myself, and said, "Hum Haryana se hain." And then they let us enter. So the Red Sea parted for us. So, sir, anytime you're in trouble, you just say, "Hum Haryana se hain," and then the roads will open. This is actually what has happened now in obesity. Mankind is changing. We talk of the Anthropocene era. Anthropocene means that anthropology, man is changing environment, man is changing the world. Within the Anthropocene era, we now have the Barocene era, B-A-R-O, scene era. And Baro or bariatrics or weight is changing our hospitals, our healthcare system. For example, we now need bigger cuffs for blood pressure. In my hospital, around 10 years ago, we had to revamp the entire labor room and gynae system, because 25 years ago, the average lady who would come for a cesarean or a normal delivery was weighing 55 kg. Now it is 100 kg, 90 kg. So that is Barocene era. Obesity is a global health priority, we know that. We all know the numbers. And I like being behind the podium so that no one can see my waist or my weight. But then the people in the ESICON organizing committee, they said, "Who are you to speak on obesity? We need lean and thin people like Dr. Shashank to speak." So, but Dr. Krishna and I, we gave her a joinder. We said, "Dr. Shashank, he knows only the theory of obesity. Dr. Krishna and I, we have the lived experience." अंदर से feeling आती है lived experience की. तो वो तो chairperson sir को भी नहीं है. So that way we have the feeling. And actually that is true, because we have the feeling of the physician, of the endocrinologist. We also have the feeling of the person living with obesity. That feeling we bring to the table for you. Obesity is associated with so many complications from head to toe. Lancet people, they created 18 diseases for clinical obesity in adults and 13 in adolescents. But actually the number is far beyond that. If you look at it carefully, you have upwards of 200 diseases and disease states that may be associated with obesity. Whether it is the common things like type 2 diabetes or hypertension, the ones that you may or may not think of, like GERD, esophagitis, or even other things like anxiety, like depression, all these are associated with obesity. Even cancer. We have to work, and we have to work at the root cause. The root cause is adiposity. Now, this slide is quite complex. How we explain in simple words, in simple Bangla or Hindi to our patients is that the adipose tissue is a reservoir. It is an endocrine gland, so it secretes harmful hormones. It also secretes happy hormones like adiponectin. And then it secretes houseful hormones, the bulk. So if you have a lot of, let us say, adipose tissue in the retropharynx, you get obstructive sleep apnea. That is houseful.
helpful adiponectin. It keeps everybody happy throughout the body. But supposing adiponectin goes down, then you become less happy as a body. And then the harmful hormones, the poisons like the cytokines, they are also secreted from the adipose tissue. So on one hand, the adipose tissue is a source of hormones. On the other hand, it is a target of hormones as well. So the entire paraphernalia, the entire machinery of the body, right from hypothalamus, pituitary, all the way up till gonads, is engaged in taking care of the adipose tissue. And the adipose tissue is a very Goldilocks kind of a feeling. So just think of Goldilocks, neither too much nor too little. You want it to be right in the middle. If you are too thin and skinny, then also you are malnourished. If you are too obese, too overweight, then also you are malnourished. But another complication, apart from the body weight or the central weight that we look at, we also look at something called hidden hunger. So many of us, so I may look anabolic, but actually I'm maladaptively anabolic. But inside me, I may be catabolic. I may have vitamin or mineral or micronutrient deficiency. That's called hidden hunger. So much complexity. But now let's try to put this all together. Let's try to make it simple for all of us. The subject is called barocrinology. So baro and endocrinology put together. If you understand all the hormonal systems, the endocrine systems that contribute to weight homeostasis in physiology, then you will be able to understand the dysfunction of these endocrine systems that contributes to pathology. And we have geriatric physicians amongst us. A shout out for Dr. Vinod Gupta here, the first geriatric physician of Himachal Pradesh. 3 cheers, Dr. Gupta. If you stand up, we'll all clap for you. Or we clap for you before standing up. So the first, and it's not easy to be the first. So going to Himachal Pradesh, and we wish you all the best, the floods and the rains that are going on. But starting geriatric endocrinology means that you want to improve life expectancy. Earlier, it was smallpox vaccine, polio vaccine, which contributed to improving life expectancy. But today, if we want to create meaningful life, meaningful years, it is going to be weight management. If you are able to maintain weight, if you are able to improve weight, you will be able to improve function throughout the body. The best part is we have targets. If I am able to achieve 5% weight loss, I will be able to improve insulin sensitivity. I will be able to improve insulin secretion, and I will be able to improve lipid profile. If I am able to achieve more than 10% weight loss, I will do all of the above, plus I will also be able to have an impact on epigenetics. It is quite easy to explain epigenetics. All you explain is that adipose tissue might act like a film on top of your genes. So when you are explaining methylation of genes, you just explain adipocytation or fat deposition on the genes. If we are able to reduce fat by 10-11%, our genes become healthier, they become happier. And if I can go a bit further and get 15% weight loss, then I can do much better than that. I can reduce morbidity and mortality both. So this is the target. But what are the techniques available? Earlier we had only diet and exercise. Then we kept on getting drugs, like for example, recently we had lorcaserin, before that we had rimonabant, we had sibutramine. All of them were associated with various side effects. Our colleagues on the other side of the table in surgery, they had bariatric surgery. And there was a lot of difference. There was a divide between the impact that we would see with MNT and behavioral therapy and that between bariatric surgery. But the limitation is ours. Recently, I attended a talk in New Delhi, and that talk was given by Dr. Anupam Biswas. I wonder if Dr. Biswas is here. Dr. Biswas, you have to come in front and sit here, please. Sir, with permission. Yeah, please. Bhag ke aana hai. So after my talk, we will request Dr. Anupam to speak about how to improve the impact of physical activity, how to improve the impact of medical nutrition therapy, and how to actually create behavioral therapy through your words. We will let Dr. Anupam speak for himself. But now, apart from all these techniques, we have other tools and we have pharmacotherapy. And the fact that so much of discussion is going on around this in ESICON means that this is important for all of us. A tool is only as strong, as effective as the hands that hold it. And if we are able to strengthen our hands as endocrinologists, we will be able to strengthen the help of our fellow citizens. Dr. Shashank spoke about oral semaglutide. We have injectable semaglutide as well. There is a slight difference. When you are giving oral semaglutide, you give 3, 7, 14 milligrams per day because the bioavailability is a big issue. When you are giving injection, you can start with 0.25 milligram per week. And if you want, you can go up to 2.4 milligram per week. So the milligrams is much less. Semaglutide injectable has been studied in phase 1, 2 and 3 programs. And the phase 3 program is known as a step program. So one step leads to another. And what we found is that you can get up till nearly 20% weight loss with semaglutide. 1/3 of your patients will get more than 20% actually. And the effect will last for 200 weeks. So there is data for that, and even beyond that, but we don't have published data. So 20% weight loss, more than 20% weight loss in 1/3, and 200 weeks is the data. Other drugs are also available. Semaglutide has been compared with some of them, and we see that the efficacy, the efficiency is unparalleled. Persons achieving 5, 10 and 15% weight loss are significant. So in general, you will be able to get 5% weight loss in 92% of your patients. 10% weight loss in 3/4, 75%, and 15% in 55%. Even 20% weight loss, which until a few years ago was considered unimaginable with any other method except for bariatric surgery, that also you can get in 33%. The key is to choose the right drug in the right manner for the right patient. And step 1 through 7 have shown that you can use it in different types of people with obesity, with type 2 diabetes, with obesity, without type 2 diabetes, in specific countries and specific ethnic groups. The higher the dose, you get more weight loss. Up till 7.2 milligram has been tried, but in India, we have approval only for 2.4 milligram. It's not just about reducing hunger. It's not just about reducing weight and waste. It is also about prolonging life, prolonging meaningful life. So you get reduction in waist circumference, more than 6 inches. You get reduction in blood pressure, both diastolic and systolic. In HbA1c, nearly 2%. And the inflammation, those angry hormones, those harmful hormones that were coming from the adipose tissue, they go down by about 63%. Triglycerides, which is part of the Indian nutri-phenotype, that we see reducing by 22%. And here we introduce another term, nutri-phenotype. We all talk about the South Asian phenotype and we criticize our genes. But those genes are actually impacted by our nutrition. So when you use the word Indian nutri-phenotype, it means you are taking some of the blame on yourself, some of the responsibility on yourself. So whether it is improving vitamin D level, or whether it is reducing your carbohydrates, like we discussed in ice starch an hour ago here, or whether it is reducing your body weight, all these are part and parcel of a healthy life. Semaglutide is effective not only in weight loss, like we said, but in handling other diseases like steatohepatitis. And recently it has been approved by the FDA for treatment for MASH as well. It's been used in multiple people. So 27,000 people have been studied in studies in RCTs, and more than 33 million people, that is double the population of Kolkata. More than 33 million people have received the drug throughout the world. So that is double the population of Kolkata. That doesn't mean you go and give it to everyone in Kolkata, but still this is a drug that we can use. How to use it? We have talked about targets. We have talked about the techniques that we have available, the tactics, how to use it, the troubleshooting that our next speakers will speak about. But before that, I would like to take permission from the chairperson and from you. Dr. Anupam, how do we add to all this? What extra can we do? What power do your weights, what power and what weightage do your words have?
So, as sir said that obesity is a very complex disease and it requires out-of-the-box solution. So apart from lifestyle, diet, exercise and pharmacotherapy, there is a very interesting concept put forward by Sir himself. It is a concept about hunger games, how you can understand your own hunger, grade your hunger, the cues what are causing the hunger, and how to evaluate and then resolve your hunger. So that is a very interesting concept which is put forward by Sir himself. So I think Sir would be the best person to tell about this, how we can understand the hedonistic pathway, how can we take care about the homeostatic and the hedonistic pathway. Thanks, Sir.
Thanks. So that was hunger awareness therapy, but right now our hunger is for another talk by Dr. Krishna Shashadri.
Yeah, I request Dr. Krishna
Sheshadri to come to the dais. He is going to speak on again on injection semaglutide. Further, what are the cardiovascular benefits, particularly the SELECT trial, which was an eye-opener actually, how by reducing the weight, we can help the heart, decrease the heart failure. So many benefits. Dr. Krishna Sheshadri, a very great personality in endocrinology. He's got very lot of depth in the knowledge, and whenever he speaks, he keeps all the audience so attracted in the talk. He is the American Board Certified Endocrinology Consultant, Chennai Diabetes Endocrine Clinic, and will have the pleasure of our SECON 26 at Chennai under the guidance of Dr. Krishna Sheshadri. Dr. Krishna Sheshadri, over to you.
Thank you very much. I seldom am at loss of words, but here I am, like the Dwadasha Adityas, we've had Unni, Shashank and Sanjay before me. So I'm just hoping for my Atma Tejas to sort of come in front and speak, because I'm sort of a little blinded by the kind of aura that is surrounded this room so far. When you look at obesity itself and cardiovascular outcomes, there are several things that come to our mind that needs to be looked at this. And if I don't stick too much to my slides, no can deduct it from my honorarium. But the important thing to understand is obesity itself is difficult to define. Remember that BMI alone is not obesity. Waist is not alone obesity. Adipocyte dysfunction alone is not obesity. So it's been very difficult, and it's taken many, many years for us to thread these together into one coherent strategy that helps us understand it. And we need to give credit to the bariatric surgeons, because they got it further. Because in 1993, there was a publication that first said, did we know the best treatment for diabetes is surgery? So since then, we have understood that while we keep talking about diabetes, we keep talking about this thing, the important thing is to go backwards or go upstream and understand what is the cause of all of this. In the majority of us, the proximate cause of cellular dysfunction, the proximate cause of organ dysfunction, the proximate cause of complications is the accumulation of fat and its dysfunction. I think that would be a very, very good broad term for us to understand. And if you trace it back, a majority of the mortality that we face, the majority of the morbidity that we face can be attributable to this particular phenomenon. Accumulation of fat and its dysfunction, accumulation of fat at the wrong places and its dysfunction. Now, and many years ago, I first saw this in 1997 first, these graphs by the CDC that showed that diabetes is preceded by a decade by the increase in obesity. The thing is that we didn't connect those dots again well. But really what we know is that if you trace it back, it's obesity that is the cause of the mortality that we are seeing in our patient cares. Right? So naturally the question is, will weight loss improve CV risk factors? And the answer has been given by Sanjay, everyone else, that we know that the moment you lose weight, your pressure increases, your lipids increases, your glucose increases, your insulin resistance increases. Many of our patients, they throw away their glucose medication simply because they have lost a sufficient amount of weight. And remember, it is a continuum. As Sanjay showed out, he pointed out the 5%, the 10%, the 15% weight loss. But remember, it's a continuum, that there's a continuum that the weight loss causes benefits. The question though is, can you close the barn door after the horse has bolted? With glucose control, we can't do that. Once you have hyperglycemia and you cause problems, right? If you try to reduce cardiovascular mortality by bringing the glucose down, it doesn't help you. In fact, it worsens it. But the question is, if you have established heart disease or you already have complications, will weight loss help you? And the answer that we did not know for many years, and that we know now, is yes. That irrespective of the presence of complications, weight loss helps. This is a big divergence from what we already knew. With diabetes, we know that bringing down the glucose after you have complications does not necessarily help you. It does help you,
but not to the extent that you want. It can actually cause harm. On the other hand, what we now know is that one, that CVD is caused by obesity, and the treatment of obesity prevents cardiovascular illness. And lastly, that irrespective of the presence of complications, the management of obesity is going to help you reduce complications. So this is the broad spectrum that we want to remember when we go into all these studies. And you'll find these companies fighting with each other about the studies. But remember this, management of obesity, irrespective of its metabolic complications, reduces outcomes. That's very important. The second thing is, I think about obesity in three buckets. One is obesity. Now you'll find all these guidelines talk about many, many things. Can you turn this off? I think about it's very simple. Is it causing a complication? The complications are metabolic, the complications are mechanical, the complications are psychological, and the complications can be anything else. But very simply, this is the way to think about it. So nowadays, when I see a patient with obesity, I actually write obesity with metabolic complications, obesity with mechanical complications, meaning obstructive sleep apnea or any of these. Make sense? So I'm deviating. So this is really what the guidelines, so the guidelines will say all sorts of things, but the important thing is this particular thing that you want to remember, that obesity causes outcomes, that the management of obesity reduces these outcomes. The management of obesity reduces these outcomes irrespective of the presence of these outcomes. So even if you have arthritis, when you take care of the obesity, it reduces pain. Even after the establishment of obstructive sleep apnea, the reduction of obesity reduces the pain. So it not only prevents obstructive sleep apnea, but treatment of obesity reduces obstructive sleep apnea. In fact, remember, BiPAP will reduce the symptoms and improve the quality of life, but does not reduce the outcomes of obstructive sleep apnea. Reduction of obesity does. So let's take this as an important part and then go into this. Now, so I made some statements, right? But why are we so confused about it? Because in the past, the studies that have looked at pharmacotherapy for obesity have been fraught with problems. You look at the ones that worked on the reward center. Remember, I think Sanjay briefly mentioned this. When you think about eating, there's homeostasis as well as rewards, right? The ones that were working, the endocannabinoid receptor medications, the other medications that were working at the dopamine pathways, they did not show positive outcomes when you subject them to trials. Many of them had to be stopped because there were problems. There was either increased CV risk, there were a whole bunch of other things. Right? On the other hand, with the GLP-1 receptor analogs, things are very different. The GLP-1 receptor analogs seem to have two different things. One is, they do work at the level of the brainstem and the corticolimbic system, where they work at the level of two things. One, they cause, the way I think about it is they cause three things. One, they cause satiety. Second, they may cause aversion to certain kinds of foods. Third, they dissociate the reward from the act of eating. This dissociation is exactly how they work. Right? The second is, there is also another part to this whole thing. Now the GLP-1 receptor, unlike the endocannabinoids and the others, have receptors all over the other parts of the body. And therefore, they have direct effects on the heart. And now we know that they have direct effects on the liver, they have effects on the kidney. So clearly, there is a dissociation between the medications we had in the past and the medication that we had now. But the proof of the pudding is the eating, and the proof of the pudding is the SELECT trial. The SELECT trial is a very interesting trial. The reason you want to know about it is, one is, this looked at patients with obesity. Remember, these are patients. The second thing is, they did not have diabetes, but they had cardiovascular illness. Remember I said that there are two parts to it. One, it should prevent CVD. The second, it should reduce CVD in people who already have established CVD. And that's really what this particular trial showed. So, cut the long story short, you can go into all the numbers. If you look at this, the hazard ratio was 0.8. Remember, these people did not have any metabolic complications of obesity except cardiovascular illness. Upper limit of confidence interval is 0.9. P for superiority is less than 0.01. And I think Novo is going, it is 20-20-20 thing, where there is a 20% reduction in the 4-point MACE. And that has made sure that as soon as you have data, every society, all the bald-headed people in every society meet and say, let's give one consensus statement. And they basically said that this is what it is, right? And the Indian CDSCO has also approved this based on the select CVD. So clearly, we now know at least the GLP-1 RAs demonstrate superiority in terms of CV risk reduction, also in the prevention, but more importantly, it established CVD irrespective of the presence of diabetes. But then, is this obesity alone related? Is this benefit coming because the weight is down? The answer seems to be no. Look at this particular data. This is a secondary analysis of the SELECT trial, and what it shows is, don't get into it. So this is the upper limit of the confidence interval. This is the lower limit of the confidence interval. And you will see that even before maximum weight loss is achieved or a significant amount of weight loss is achieved, there is a reduction in the HR, meaning that the benefit seems to be probably not independent, but certainly on top of the weight gain, by meaning that the benefits of the drug accrue even before you see significant amount of weight loss. Therefore, the GLP-1 RAs are actually demonstrating this particular thing. And this also shows that the MACE is changed. And if you look at this carefully, you will find that the effect of the weight is around 19%. The effect by modifying the existing CV risk factor or maybe an extra thing effect is about 31% of the mediation. Now, this is going to be the big fight for the next few years. Is this with tirzepatide also, or is this with semaglutide also? So the questions are, if you see the STEER study, you will find that there is a benefit of tirzepatide. On the other hand, Lily will come in through the JAMA Internal Medicine article with the thing saying, no, the benefit was seen with the others. But one lesson from the STEER study that you will see is the earlier onset of the benefit with GLP-1 RA. Now the question is there a difference? And can we explain the difference? I'll come to hold that thought for a minute, think about it. I'll show you one more piece of data and then I'll give you my hypothesis about why there can be a difference. This is the STEP-HFpEF and the STEP-HFpEF-DM study showing benefit in heart failure. Remember, in the past there were two things we were worried about. One, that there may not be any benefit in heart failure. The answer is yes, there is benefit in heart failure. Is it as fast as the SGLT2 inhibitors? No. It's a little later, but is the benefit consistent? Absolutely yes. Is the benefit there irrespective of the stage of heart failure? The answer seems to be yes. Previously with the GLP-1 RAs, we were worried that when you have coexisting heart disease, CVD, the benefit in heart failure may not be seen. In the SELECT and the other heart failure studies, in the STEP-HFpEF study, we know that irrespective of where you are, you're able to see the benefit. So this is looking at the heart failure data, this is pooled data, again showing this. Now before I conclude, let me tell you, can there be a difference? Yes, I expect that there may be a difference. Why should there be a difference? The difference could be two reasons, and we don't know which is going to win out on this, right? Because you'll find weight, with the SURMOUNT 5, you'll find weight benefits are greater with tirzepatide. But then again, the CV data, you're seeing this particular story. Now, these are both GLP-1 RAs, right? Why is there a difference? So, I'm going to leave this thought for you and you can go discuss this later. One, what is the role of GIP? I think this is the first question. If you add GIP and maybe later glucagon antagonists, will they affect the cardiovascular outcomes? I don't believe the spin given to SURPASS. I think it's a fantastic trial, so I will leave that there. The second part is this issue, and that is called biased agonism. Now remember, GLP-1 RAs work at two parts. When cyclic AMP is produced, there's another pathway that is taken, which is called the beta-arrestin pathway. The beta-arrestin pathway is responsible for some of the cellular effects of the GLP-1 RAs. When you use drugs like tirzepatide or the newer ones that are coming, the biased agonist drugs, they preferentially stimulate the cyclic AMP pathway. The question is, what is the effect of GIP? What is the effect of biased agonism on these CVOT outcomes? Let the pharma fight it out. I think what we have is two fantastic drugs. The data sits very clearly, but let me reiterate the data from the semaglutide data. One, obesity does cause CV outcomes. Second, treatment of obesity reduces CV outcomes. Treatment of obesity reduces CV outcomes in patients with established CVD. Treatment of obesity reduces heart failure in patients irrespective of the outcome of, irrespective of stage of heart failure. So which means the fifth pillar being GLP-1 RAs is set. Lastly, that there seems to be an extra obesity benefit with these drugs that kicks in very, very early, which means that soon we should start thinking about putting this early after an event. With that, I hope I was a little candle to the suns that the four Adityas here had. Thank you so much.
Thank you, Dr. Krishna. I think we can take up the question. Dr. Sanjay is here. We have got only a few minutes left. Dr. Shashank, you please come.
Sanjay is not here. Shashank?
Yeah, Dr. Sanjay had gone.
Uni?
Uni is left, I think. Sanjay said he will come. Yeah, 4 minutes. We can have some questions. Because both the stalwarts are here. Yeah, please. Sanjay, come.
Sanjay, you have to fly.
Hunger hormones are here. Hunger hormones are waiting for you.
The beautiful ladies are waiting for Sanjay. Please come. You spoke about the brighter side of the drug, the semaglutide. What is the darker side of this drug?
Okay, I think we'll all take over the dark sides. The dark sides are very simple. I think we need to have more clarity on the NAION data. I think this is something that we need to have absolute clarity about. We don't have clarity about this particular bit. Second, I think we also need data a little more. We need to learn a little more about the reward centers and how they actually work. For example, there are two parts. For example, we think that the GLP-1 RAs work because they go through the blood-brain barrier and work at the level of the hypothalamus. We probably know that's not true. In the areas, for example, in the brainstem and where the ventral hypothalamus, where there is a connection, it works. But the effects are actually projected. What are the long-term effects on working on the reward center? This is a question we don't know. Nobody has looked at this carefully enough. So are the Hunger Games going to be killing us? I don't know. But at this point of time, we need to look at the brighter side because these drugs have been not around for just 2 or 3 years. This class of drugs has been around for more than a decade now, and they have beaten every signal we know. Whether we should look at all the crap that goes on Instagram, I don't know, but the data itself seems to be fantastic that we cannot ignore. The darker side is what it does to our viveka.
So I think I'll be very quick and maybe then Sanjay can have the last word. Semaglutide, one thing very clear, nausea, vomiting, occasional diarrhea, constipation. Between 5 to 10%, start slow, go slow, educate the patient, usually self-limiting, mild to moderate. If you have pre-existing acute pancreatitis, chronic pancreatitis, pre-existing gallstone disease, you need to be cautious because there is still a signal of pancreatitis. That clear cut is there. So again, no question asked, that's there for DPP4, that's there for your GLP-1 agent. So that's a generic. Two things. One is this so-called men and medullary thyroid cancer. People actually land up with me with calcitonin levels. I think that's a little far-fetched, but that's not out of space. That's there on the drug insert. So we should be pharmacovigilant. Any new compound needs pharmacovigilance. So there's no two questions about it. The last part, as far as I is concerned, the verdict is not out. There are studies for, there are studies against. So I think it's very simple that the good effects of these drugs are far more compelling. The organ protection effects are far more compelling than the darker side of it. At the same time, if somebody has a family history of a thyroid malignancy like a medullary thyroid cancer,
somebody has active gallstones, somebody has a history of acute pancreatitis 3 months back, somebody is having nausea, vomiting, probably you need to be a little more cautious and probably look at other alternatives. That's my take on it. It's keep it simple and don't let them go on a social media blitzkrieg that somebody has been suing for a couple of $1 billion, etc. I think that's all garbage. I think that's where I would stop, and maybe Sanjay will have his last barycrinology word.
Sanjay, you can add what happens to the sarcopenia, because that's another important aspect.
Yes, lean body mass.
That's
lean
another
body
issue.
mass.
So the question was the darker side. You cannot have dark and bright separately. Both are sides of the same coin.
Goes hand by hand.
So the first thing is we should know the indications for prescribing. At what BMI threshold will you diagnose overweight and obesity? At what BMI threshold will you intervene with diet and exercise? And at what threshold will you give semaglutide or any other anti-obesity medication? We should be aware of that. Second is pharmacovigilance, like both our speakers said. Within pharmacovigilance, sarcopenia, be aware of muscle mass, and it is not that you will use semaglutide alone. You will need behavioral therapy, vocabulary therapeutics, hunger games, and you will also need medical nutrition therapy and exercise. Another issue that we are not aware of is pragmatic prescription or flexible de-escalation. Supposing I am giving once a week semaglutide to somebody has achieved 15% weight loss, and now they say I want to reduce the dose. Can I go down to 1/10, 1/14? Can I go down from 2.4 to 1.7 milligram? These questions are not answered. Perhaps over time we will answer. So these are some other things to chew upon. Dr. Krishna used the word Vivek, so I would like to conclude with that. In Bengali, in Bangla, Bibek. That means common sense, common knowledge. That is the Sanskrit word that he used. Two wings of the same bird to be a good doctor or to be a good endocrinologist. Karuna and Pragya. That means compassion and competence, compassion and wisdom. If we are able to take these two things back from our talks and convert that Karuna and Pragya, compassion and competence, into our clinical care, we will have done our job. Thank you.
Thank you. I thank all the three speakers. I think we have just had the time, and I request all of you stand and give a standing ovation to all the best talks we had on obesity. Thank all the three speakers. Thanks,
sir, and
You
thanks
make
to all
you make the
chairpersons.
session so interesting. The three of you make the session so interesting.
Chairperson sir ka kamal hai. Thank you, sir.
We have finished on time.
Thank you, sir. Now we are moving on to our next session that will be chaired by Dr. Ganapati Bandwal sir from Bangalore. I would like to request Dr. Ganapati Bandwal sir to come on stage, please. So I would like to call upon stage Dr. Rajesh Rajput from Rohtak. Sir will talk about why is obesity a chronic disease. Oh, yeah. So.
Yeah. Good afternoon. I think it's a packed house. I think you just listened to one of the newer anti-obesity medications, and now you will be listening to another one. How does it act? How is it different from the previous one? What are the advantages of this over that? So before that, a brief, just to set the ball rolling. Obesity, as you know, the terminology has been changed, and now we call it as adiposity-based chronic disease. People were always thinking, oh, it's my genes which is contributing. But we say monogenic obesity is just around less than 5% or even lesser than that. Genetic contribution is around 40%, but then 60% is environmental, psychological, social, all these factors contribute to obesity. And you know that it's not a simple condition. There's an epidemic, and it leads to a lot of comorbid conditions, which could be metabolic, mechanical, and also cancers. Lifestyle modification, eating less, increasing exercise is the first step, but then it invariably fails. I think till 3-4 years back, we hardly had any drug to control obesity with medications, but then now we have wonderful molecules, the use of which has actually reduced the bariatric surgery usage by maybe more than 25%. Only thing is, chronically we'll have to use. And over to Lily for the push.
So good morning, good afternoon friends. Well, now this session I do not know in first session whether the basic concept of obesity, which is now actually known as adiposity, has been discussed or not. Can you present my slides?
Why is obesity a chronic disease assessment?
Obesity is a chronic disease.
Obesity is a chronic, my slides.
The first one.
First lecture.
Yes. Yeah, Rajesh. Rajesh, again. Let's come. This is the one.
क्या हो गया?
Okay, yeah. So Dr. Rajesh will speak on adiposity. What is the role of dysfunctional adipose tissue? He is an endocrinologist done from PGI Chandigarh, and presently he is a director of endocrinology at Medanta Hospitals in Gurugram. He's been the past president of the Indian Thyroid Society, past EC member of ESI, reviewer for a lot of...
Thank you, Ganpati.
Yeah, thanks.
Yeah, Ganpati is a good friend of us, and all of you are known, we are known to each of us. My role is very simple. Ganpati has told you, obesity is now renamed as adiposity. And there are many reasons that we are not calling people as obese because it is not taken in a good context. Now, but why obesity happens, why it is important to recognize, that is what I am going to discuss with you, and my role is very simple because I am going to set the stage for Ganpati, for Shaila and for other colleagues to discuss with you the molecule. I am not going to discuss with you the molecule. You have in previous session, you have listened one molecule for obesity. The second molecule is going to be discussed into this session. Now, few years back, I still remember around roughly 20 years back, I have delivered a lecture in National RSSDI on concept of metabolically healthy obesity. And at that time, we used to call those people who are obese, but they does not have any risk factors like diabetes, hypertension, dyslipidemia, they are metabolically healthy, obese. Now, somehow over the years, the research have shown that there is no such thing like metabolically healthy obesity. We have to identify and understand that obesity is a disease state. So the excess adipose tissue is responsible, even in absence of these risk factors, for increased future risk of cardiovascular disease, mechanical complications and mental complication. And that's how in last decade the obesity is now recognized as a disease. So there is no concept of metabolically healthy obesity and metabolically unhealthy obesity as we have learned in past, and there are papers surrounding that. Now, what causes a person to become obese is a very important factor. In simplistic terms, we always say calorie imbalance. Intake is more, expenditure is less, so you are becoming obese. Now the things are not that simple actually. If we see 60 to 70% of contribution of obesity in an individual is because of genetics. It is genetically mediated. It is 20 to 30% which is epigenetics, which may be intrauterine period, environmental factors, psychological stress, behavioral, and so many other factors. And that is why probably obesity is going to be so difficult to treat. What I have told you that recently worldwide different organizations have started recognizing obesity now as a chronic disease, and these are the definitions given by some of the leading organizations worldwide, like American Association of Clinical Endocrinologists. They say it is defined as adipose-based chronic disease or ABCD, and a small change in body fat distribution disrupts your metabolism and put you at a risk of various metabolic complications. I will not read all the definitions line by line, but the gist of all these definitions is that we have to understand obesity is now a disease, and we have to communicate it to our patients that you are suffering from disease. Having simply excess body weight is not a benign condition. Now, if we compare adipocyte of a healthy individual vis-a-vis in an adipose individual, number as well as size of adipose tissue is increased. Remember, our subcutaneous adipose tissue has a capacity to store fat. Now, once this capacity is overwhelmed, the excess fat is spilled over into circulation, and then it gets deposited into various ectopic organs. Traditionally, your epicardial area, pancreas, liver, they are usually free of fat or minimal amount of fat. Now, when fat gets deposited into these ectopic places, it will result in dysfunction of these organs and will cause disease state. Also, as adipose tissue expands and fat increases, its blood supply is compromised. So this sets in a state of low-grade chronic inflammation. And the result is there is release of inflammatory cytokines like IL-6, TNF-alpha, which are responsible and which we are measuring usually in the blood. And large number of corporate hospitals and bigger hospitals are now measuring HSCRP. Their HSCRP is high, 6, 8, and patients are asking why my HSCRP is high. And one of the commonest reasons to have a high HSCRP is that patient is obese. Now, therefore, adipose tissue in presence of obesity become dysfunctional. Now, moving from that, ये चलना बंद हो गया भाई आपका. Slides नहीं चल रही. चल गया? चल, right. So if we see the neural and hormonal control, again I will make the things clear. In our brain, there is a key area which is known as arcuate nucleus. In arcuate nucleus, there is two opposite sets of neuron. One set of neuron is responsible for hunger, and another set of neuron, POMC CART, one set of neurons is agouti related peptide and neuropeptide YY, other is CART POMC, which are responsible for satiety. They receive signals. Now when we want to understand obesity, remember there are immediate cues from the stomach and intestine. When you eat something, from the stomach and intestine, there are immediate signals, and they are transmitted through GLP-1, oxyntomodulin, CCK, peptide YY. For long-term energy storage, from adipose tissue there is secretion of leptin, and from pancreas secretion of insulin. Now all these signals are going to the brain arcuate nucleus, where they are interacting and the signals are given. Now this is classical concept of metabolic control, which means we should eat only when we should have hungry, and metabolic obesity. But there is another center in the brain which is hedonic obesity, which means all of you have a wonderful breakfast. You are feeling full. But now when the lunch break will happen, you will see a wonderful food. So despite that you are not feeling hungry, you will eat something because you are getting pleasure out of it. That is known as hedonic obesity, mesolimbic system mediated by dopamine and cannabinoid receptors. And then there is a third center which is execution center, which means behavioral therapy. You have metabolic center, you have hedonic center, but then execute. मेरे सामने food पड़ा है, I have food in presence of me, but I will stop myself. No, I will not eat. मुझे भूख नहीं लग रहा, I am not feeling hungry, I will not eat. So that is behavioral therapy execution center. Now when all these get disturbed, a person develops obesity. Now, but one has to understand, and over the years it has been shown, number of studies that, and some of us may argue that by doing simple diet and lifestyle change and doing exercise, why we should not lose weight? Answer is yes. Once patient adopt diet, lifestyle, exercise changes, it is possible to bring down the body weight. But then there is a plateau to it, beyond which weight does not decreases. And even after reaching that plateau, there are changes in our internal milieu where there is increase in hunger hormones, there is decrease in satiety hormones, which will promote weight gain in long term. And it is not only a theoretical concept. If we see literature, at least there are more than 15 different studies which have shown that a person who have taken diet and lifestyle measures, by 5 years, they will regain more than 80% of the weight which they have lost initially through diet and lifestyle. And some of us who have done this in our own life cycle might have experienced the same. So therefore the efforts needs to be persistent, they needs to be increased, and even after that, sometime it is not possible to maintain and to do that weight loss. So therefore the lost weight is regained over fast over some time, and then we need drugs which actually promotes and maintain that weight loss. Now moving from that, the next important concept is that now we know obesity is a disease. Probably we can argue, some of us still may not agree, but worldwide it is recognized that obesity is now a disease. But if we are saying this is a disease, what actually it is causing to our overall health? What is the data available to us? So if obesity, excess adipose tissue is compromising our health, then only we should agree that this is a disease state. So if we see, these are some of the pathways. If an individual is having excess of body weight, it will result in increased insulin resistance, in long-term beta cell dysfunction, result in diabetes, increased inflammation, which I have explained to you, will cause cardiovascular disease, increased blood pressure, hypertension, because of increased body fat, fat depositing around your parapharyngeal pathways, obstructive sleep apnea, your knees has to take more body weight, early development of osteoarthritis, increased chances of gallstone, cholesterol disease, and number of cancers like breast cancer, endometrial cancer. The studies have shown if an individual reduces body fat by 7%, all type of obesity related cancers are roughly reduced by more than 15%. So number of disease states which justifies that obesity, which is now known as adiposity, should be recognized as a disease state. Now based on that, Edmonton system of classification, which is now we are using for treatment of obesity, has given 3 M's, which is classify complications of obesity according to 3M, which are mental, like your anxiety, mood change, attention behavior, mechanical complications, osteoarthritis, esophageal reflux, urinary incontinence, and so on, and metabolic complications, presence of diabetes, hypertension, dyslipidemia, PCOD. So therefore, whenever you see your patient, try to identify where in these 3 M's patient is falling: mental, mechanical and metabolic. Patient may have more than one M problems also, which means this patient need more aggressive intervention. Now, the next question is, if person loses weight, is it going to be advantageous? Now, it has been shown the benefit depends on degree of body weight a person loses. Now, simple loss of 5 to 10% of the body weight also give remarkable benefit in terms of improvement in fasting plasma glucose, reduction in HbA1c, improvement in lipid profile, improvement in PCOD profile, and improvement in MASALD. But as the degree of weight loss increases, as you see here, more than 15% weight loss associated with reversal of diabetes, which is now a quite common burning topic. Even patients themselves comes and ask, मेरी diabetes का reversal हो सकता है क्या? So these are the things which are possible in today's era, and I hope some of the slides which they are going to project is going to show you the data that where by losing weight, reversal from pre-diabetes to euglycemia and even from diabetes to pre-diabetes and euglycemia is possible. Now the last important is diagnosis and management, which means we should actually now start writing over our prescriptions that patient is having adiposity based complications, because in this study which has been shown here, in those individuals where this problem has been highlighted, the patient has attempted significantly, which has resulted in weight loss, rather than not stressing about this complication to the patient. Now, treat to target is an old algorithm. For obesity, I do not know, but this is a good way to understand. Like for diabetes, we have HbA1c. For hypertension, we measure systolic and diastolic blood pressure, and then we have complication. For cardiovascular disease reduction, we target lipid profile, LDL, HDL, and the result is MI, stroke, and an amputation. Now, for obesity, our cardiometabolic targets are weight and waist circumference. So if we are reducing our body weight, if we are reducing our waist circumference, the benefit will be in terms of diabetes, hypertension, MASALD, and so on, which I have described to you. So friends, to conclude with, we have to understand that obesity is a chronic, multifactorial, lifelong problem. It is driven largely by genetics, and then there are epigenetic, environmental, and other factors. We have to stress to the patients that if you have excess of body weight, your adipose tissue is dysfunctional. Even if you does not have risk factors, you are at increased cardiovascular and other risk as compared to a healthy, normal weight individual. Losing as low as 5 to 7% of the body weight has important health related benefits, and if patient is going to lose 10% or 15%, which is now reality with the availability of the drugs, then it is going to be beneficial. Thank you very much.
Yeah, hi. So the next will be by myself, exploring GIP, GLP-1 co-agonism with tirzepatide.
Hello, can I ask you one question to him?
We'll have it later. We'll have a discussion, discussion later on. Yes. So I'll speak on exploring GIP, GLP co-agonism with tirzepatide. Yes. Some physiology, I know you must be knowing this, these are GIP and GLP are the incretin hormones, the main one. In fact, it was GIP which was discovered first, and then GLP was discovered. What happened with GIP? It actually produced adipogenesis. Though it increased insulin sensitivity, all these things, it produces adipogenesis. If you see postprandial blood glucose regulation, the contribution by GLP-1, even this is physiological, which was found previously itself. The contribution by GLP-1 is 22% to postprandial glucose reduction. insulin is 33%, and the highest contribution is actually 44% by GIP. So for insulin secretion, normal physiology, this is how it is. If you give GLP infusions, what happens? It increases insulin secretion, it reduces glucagon secretion, importantly, delayed gastric emptying, and central nervous system reduced food intake. If you give GIP infusions, what happens? Central nervous system also probably reduced food intake. It increases insulin secretion, which is an incretin, naturally so. In addition, it increases glucagon secretion, and it increases insulin sensitivity, but then it also produces lipogenesis, adipogenesis. Now, how is this? You give separately, it's acting like that, and now you are giving it as a combination. It's actually producing weight reduction, and in fact, it is working better than giving GLP and GIP separately. So this function is actually known as biased agonism. So if you give separately, it's not acting that well. But if you combine, you're changing the molecular structure. Now it is activating a different set of receptors, which are acting synergistically or even more than that, and bringing about this effect. So that is how actually it works. So what is tirzepatide? It's a multifunctional peptide based on the native GIP peptide sequence. The GIP sequence is the same, but the GLP-1, its function is around 5-fold lesser. It's a 39 amino acid peptide, all these things. Half-life is 5 days. Plasma concentration in people with renal and hepatic impairment do not change. So I told some of the effects. I will tell some which are not been covered. What is the action of GIP? It can reduce hyperglycemia, dietary triglycerides, and the skeletal muscle increases insulin sensitivity, metabolic flexibility, and ectopic fat accumulation. The GLP-1 additional activity in the liver decreases hepatic glucose production and also ectopic lipid production, and that's the reason it can be used in MASH and all. So if you see its action via both GLP and GIP receptors in human, I told you 5-fold lesser effect on the GLP, predominant action GIP. So what do you find here? GLP receptor agonism alone failed to reduce insulin secretion significantly. GIP antagonism, blockade, reduced insulin significantly. So both GIP and GLP antagonism produce similar effects that of GIP receptor agonism, telling that GIP played a role. Now we'll go into the action of tirzepatide on these 4 things: glycemic control, weight reduction, lipid metabolism, and cardiovascular effect. Now coming to glycemic control. All the surpassed trials, whether it was with a comparator or whether it was with a placebo, significant reduction in HbA1c, so to the tune of roughly around 2% with the highest dose, which is 15 milligrams of tirzepatide. So including when you compare it with the comparator like semaglutide, where in fact the 5 milligram did even better than the 1 milligram of semaglutide. It improved the tirzepatide improved beta cell functions compared to placebo in patients with diabetes. This is the GPGT study. So you can see it. The blue one is tirzepatide. The middle one is actually the semaglutide. So you can see that the first phase insulin response, the insulin secretory capacity, highest with tirzepatide, then with the semaglutide. And if you go, this is in the using the hyperglycemic euglycemic camp. Hyperinsulinemic euglycemic camp. Okay. You can see on the right-hand side, the second phase insulin response was also better with the tirzepatide compared to that of placebo. So here you can see the glucose infusion rate and the M value. So this was actually the hyperinsulinemic euglycemic clamp multi-center trial done in Germany. So you can see you require a higher glucose infusion rate, which was highest with tirzepatide. So what they did here was it was hyperinsulinemic. So insulin levels were high. Now you have to maintain a euglycemia. So how much amount of glucose infusion you can give to make euglycemia. And that was highest with tirzepatide, telling that it produces the highest insulin secretions. And if you see on the right-hand side, the insulin sensitivity once again was best with the tirzepatide compared to that of semaglutide. And now coming to the mixed meal tolerance test, compared to placebo, sema, and tirzepatide, you can see once again, it showed the best changes in insulin and glucagon secretion. So when you use it as a combination, it's actually reducing glucagon also. So this combination, yes, combination. You give separately, I told you, physiologically it increases. But as a combination, highest reduction of glucagon happened with tirzepatide and then with the semaglutide. What about hypoglycemia? You are reducing, you told, glucagon. Now, if hypoglycemia happens, the first counter-regulatory hormone to increase is glucagon. What happens? Appropriate release of glucagon happens with hypoglycemia. And as you know, these incretin hormones are glucose-dependent insulin release. The moment the glucose increases, only then they release. Glucose comes down, they don't release, but appropriate release of glucagon happens. And you can see here, appropriate release is happening. So, to summarize the first part, when you use tirzepatide in patients with type 2 diabetes, there's an improved beta cell function and insulin sensitivity, weight independent component compared to placebo or sema, greater reduction in glucagon area under the curve than sema, intact glucagon response to hypoglycemia in patients with diabetes. Now coming to weight reduction. So you have seen these studies. So you can see 5 mg, 10 or 21, and with the 15 mg you can see highest reduction, 21% reduction of weight happened compared to that of placebo. And this weight reduction is predominantly fat mass. Some amount of lean mass also happens, but if you say compare the ratios, it's actually better than when you lose just weight reduction. Say you do dieting, you lose weight. Whenever you lose weight, actually they did studies in women in the 1980s by one person by name Webster. So all the age groups of women. So whenever you lost weight, they used to lose around 22% of lean body mass. It's a fact that whenever you lose fat, you also lose lean body mass. And then they extrapolated it to males, and they told in males up to 25% lean body mass is okay. So here it's almost similar to that, maybe it's around 28%, but if you do weight loss happens with just dieting and exercise, it's still more actually. So that's the reason you'll have to do exercises to build up the muscles. And also you can see the fat mass also decreased significantly, the visceral fat. So that's the bad fat that also decreased significantly. So tirzepatide, so you can see it lowered overall appetite scores compared to placebo in patients with obesity. So in the left-hand side, you have the hunger visual analog score significantly reduced, and then food consumptive visual analog score significantly reduced. But then satiety was not significant, though there was a trend, and fullness once again significantly reduced. And during mixed meal tolerance test also similar effects were seen. So it improved appetite measured by lowered appetite measured by an increase in overall visual analog score. It reduced hunger and prospective food consumption and increased fullness, but did not change satiety, did not reach significance. It also reduced cravings for sweets, carbs, starches, fast foods, but not for high fat and fruits and vegetables. It showed greater body weight reduction compared to sema, mainly derived by fat mass loss. I think Dr. Shaila will speak more on that, so I won't go into that. And what is the important thing is the graph is continuing to show a downward trend. It continues to show a downward trend. So to summarize this part, in participants with the obesity, greater weight reduction and significant changes in body composition, total fat mass, lean mass appropriately, visceral fat mass compared to placebo, reduced ad libitum food intake, overall appetite, food cravings compared to placebo. There was no reduction in sleep metabolic rate nor 24-hour sedentary energy expenditure compared to placebo with calorie restriction for weight loss. We can talk on that later. And in patients with diabetes, it showed greater weight reduction, predominantly attributed to fat mass versus sema or placebo, reduced appetite and ad libitum energy intake that was similar to sema and greater than placebo, and greater reduction in liver fat compared to that of degludec. Now coming to lipid changes and pulse rate changes. So overall it was similar to that of semaglutide in terms of pulse rate. It is said that they can increase by 2 to 4 pulse beat per, there's an increase. Suppose somebody had a baseline of 76, it could become 80. Systolic blood pressure reduced significantly compared to that of sema or placebo, semaglutide, and diastolic once again, tirzepatide did better compared to that of sema. So it did not increase the risk of MACE in patients with type 2 diabetes. This is from the SURPASS 1 to 5. Overall, the hazard ratio was 0.8. This is from the phase 2 and phase 3 studies. So telling that it is neutral as of now. I think the CVOT outcome trials has come. It will be published. It will be released in the EASD this month rather. So overall, what does it do? Decrease systolic blood pressure by 7 to 8.2 millimeters, diastolic 4.6 to 5.5, reduction in triglycerides up to 31%, HDL increase up to 8.5%, LDL decrease by 8.5%. So coming to key takeaways, at the level of the CNS, reduced appetite, reduced feeding behavior, liver fat content reduced. At the level of the pancreas, insulin secretion increased, glucagon regulation appropriate, cardiovascular repeat regulation, lowering blood pressure, and the GI tract delayed gastric emptying. So thank you for patient hearing. Now we'll go to the next topic. It will be presented by Dr. Sheila Sheikh. Surmounting obesity with tirzepatide. Over to Dr. Sheila. Yes. So introduce Dr. Sheila. She is an endocrinologist from Bombay, vice president of CEPHIS. Lot of clinical trials.
Hello. Just
member
a small
of
announcement.
ESI 21 to 24. Over to Dr. Sheila.
A small announcement about the lunch. Lunch is being served. It will be open to all. And for faculty, lunch will be served in the upper lobby, brass room.
And to add to that, nobody goes for lunch. So everybody stays where they are. The lunch is after the session is over. Okay, good afternoon, everybody. We just heard some fantastic speakers talking about the complexity of obesity. You know, something which we conventionally thought was so simple. I mean, a decade back, to be honest, my conversation was always about intake and output. It was supposed to be very simple. There's nothing more than that. I mean, how could anything? And my conversations were equally horrible, to be very honest with you. And I think as far as obesity goes, we are now still, I would say still, and we still have a long way to go as far as obesity goes, because we are on the learning curve. So there are a lot of questions which are answered, and there are a lot of questions which we still don't have answers to. And I'm going to try to talk a little about the data that we have. I'm sure many of you have already heard about the data, but it doesn't hurt to again talk about something which we need to reconnect with, re-understand all the time, because still I think our thought process when we look at a person living with obesity, still I think has not evolved or reached the point of the empathic way in which we are supposed to treat them, and that's where surmounting obesity comes in. I like the word surmounting, to be honest. I like the word surmounting because it sounds like, okay, you have a solution. Do we have a solution? Do we really have a solution as far as obesity concerns? These are my disclaimers, these are my disclosures, and this is where we'll talk about our tirzepatide. As far as approved indications are concerned, actually what is surprising is that is, somewhere on this entire bandwagon of, just talking about tirzepatide with obesity, we seem to have somewhere forgotten that tirzepatide actually is a molecule which was approved for diabetes before it was approved for obesity. But I think the entire social media storm and the fact that actually we also were so excited about the fact that now we can actually offer our people living with obesity some kind of medication to help them deal with this problem that they face at all points of time when they are regaining their weight, where they are feeling so demotivated, where they're just not able to reach targets, because actually when a person tries to lose weight, we all know, we heard sir talking about the fact there's going to be increase in the satiety hormones, there's going to be reduction as far as the metabolic rate is concerned. But the fact remains that actually tirzepatide is a drug which was approved for diabetes. It is also approved as the initial drug with metformin when it is not tolerated or patient is intolerant to metformin, or but mind you, all this is as an adjunct to diet and exercise. So when any one of us are talking about people living with obesity, we need to reiterate that lifestyle stays and will always stay a cornerstone of management. And of course, then you continue using the drug along with your other anti-diabetic medications, anti-hyperglycemic medications that you have. As far as obesity is concerned, the indications are very clear. BMI more than 27, one more additional risk factor. It could be related to obesity. It could be, sir had just shown you, it could be hypertension, it could be dyslipidemia, it could be MASH, it could be osteoarthritis, it could be any of those comorbidities which are associated with obesity, or even obesity that is, though we are no longer, again, the definition says a BMI more than 30, but this could soon change because we are now increasingly talking about body composition. We all know a body fat mass of more than 30% in women and more than 25% in men is going to be labeled as overweight or obesity. The Surmount program actually is a fantastic program because if you look at the various, you look at Surmount 1 to 4, what you would see is it covers people that you and me are seeing in the clinic. Surmount 1 talks about people who are living with obesity, come to you with a problem. I am living with obesity, what do I do? Surmount 2 talks about people who have diabetes and are living with obesity. And we've always known that when you are treating your obese diabetic patients, it's much more difficult for them to reach targets as far as weight loss is concerned. We are talking about just a 5% weight loss, but not easily attainable. The other group who comes to you are people who tell you, ma'am, I've been trying to lose weight, I've tried whatever I can, I do whatever I can, and when you look at everything, everything seems to be just right. But I just don't seem to be where I want to be. I just don't seem to be losing weight. And to add to that, it is the fourth group who says, okay, I did this a few years back, and now I've just gained it back. What do I do? Do I have to do this all the time? Do I just have to sort of, and people perceive, honestly, a healthy lifestyle as being an unhappy lifestyle. We still have this awful, prejudice saying that, okay, high-calorie food, when we spoke about the hedonic center, high-calorie food makes me feel happy. I mean, when I think about that lunch which was just announced, okay, I'm going to wonder what was the dessert, what is the dessert which is going to be given to me in Kolkata, more than anything else, to be honest. So that is the kind of pleasure you derive from food, and that is the reason why we need to keep all this in mind when we are treating our people living with obesity. Coming to Surmount 1, which Sir just spoke to you about, I think it took the world by storm when Surmount 1 data was announced, because finally we were excited. We had, okay, I can offer my patients something. We all know we start with an initial dose of 2.5. You will go, after a month, you'll go to 5. After another month, you'll go to 7.5, and then 10 and 15. That is a routine protocol which was followed even in this group. And what was seen was a percentage change in body weight from randomization till week 72. Along with that, what was seen, the percentage of population with weight reduction, mind you, we've been talking about this figure of 5%. It's not a magical figure. It's a figure which gives some amount of metabolic benefit, and that's the reason we say 5%. If you give me more, I'll be more than happy, and that's what this trial gave me. What it showed was that if you look at this, 5 milligram of tirzepatide, mind you, gives you a 16% average weight reduction at 72 weeks. Okay, 5 milligram. So if 5 milligram is giving me this, what does 15 milligram, which is supposed to be the maximum dose which I can use? 15 milligram, friends, is giving me 22.5% reduction as far as body weight is concerned. I wanted 5. I got 16 with 5 milligram. I got 22.5% with 15 milligram. And that definitely makes me feel much, much happier, because I am actually able to offer 2/3 of the patients. 2/3 of the patients, mind you, with 15 milligram get approximately more than 20% weight loss. My sleeve gastrectomy patients, I work in a unit with a lot of bariatric work. My sleeve gastrectomy patients get around 20 to 25% weight loss at 72 weeks. So coming back to what Ganpati sir's statement was when he introduced the topic, are we somewhere going to be talking in terms of our patients not going in for surgery and rather trying medical line of therapy, is something we all need to now think about. Sir spoke about body composition. He spoke about the fact that yes, with any weight loss modality, across the board there is going to be loss of muscle mass. But in spite of that loss of muscle mass, see, loss of muscle mass we associate with loss of strength. We say, okay, my muscle is going to go, so my strength is going to go, I'm going to not be able to do what I want to do. That's what our association is. But we need to understand, most of our patients, when you talk to them who've lost weight, they feel better. They're able to do their activities better. So was it the weight which was actually causing this muscle mass to be better? When you lose weight, irrespective there's going to be loss of muscle mass, up to 25% is what sir has already said. We can make a difference to that loss of muscle mass with resistance exercises, with increasing the protein, with individualized therapy, and of course we are now going to have increased drugs. We have our Bimagra coming up, so maybe we'll be able to then do something about it. You've seen this slide, I won't get into details of this, and I'll go directly to Surmount 2. I have around 6 minutes left, and when I talk about Surmount 2, what do I really want to put across to this audience? What I want to put across to this audience, the final dose in this trial was 10 and 15 milligram. These were patients who were again obese, living with diabetes, diabetic, and already on medication except DPP-4 GLP-1 receptor agonists. Again, we said right in the beginning, patients with diabetes, difficult to lose weight. Number of explanations, we really don't know why. But the fact remains that patients with diabetes do have difficulty losing weight, and that could be because of other medications, maybe they're on insulin, maybe the gut microbiome, lots of theories, we really don't know why. But in these patients, what happened again, if you look at this 10 milligram percentage, red 10 milligram dose, red bar, 12.8% body weight change. 15 milligram purple bar, 14.7% body weight change. So that is what you saw with these. Not only these are diabetic patients. I'm not only interested in body weight, I'm definitely interested in what's happening to the glycemic control. And this is what I have over here. 2% HbA1c reduction, I mentally expect only with insulin. When I look at an HbA1c of maybe 9.5 and the patient is already on some oral hyperglycemic agents, I, by default, think about insulin. Am I wrong in that? Do I think about, when I talk about first injectable, should I now be thinking about a once-weekly GLP-1 receptor agonist, a once-weekly GIP GLP-1 receptor agonist, a dual agonist, rather than talking in terms of insulin? Think about it. I think that would make very, very interesting thought process. Now, discontinue. You decide you stop Mounjaro. Okay, the patient says, I want to now stop, ma'am. I don't want to take a weekly injection any longer. What do I expect? What's really going to happen, ma'am, if I do that? This is what the data says. 36 weeks, patients randomized were on open label tirzepatide. What happened after they stopped? This is what happened after they stopped. Patients who continued from 38 weeks till 88 weeks, 36 weeks from 88 weeks, they had a further reduction as far as their body weight was concerned. And patients who did not continue with the tirzepatide had a 9.5% increase as far as body weight is concerned. That means there is going to be some increase, and this is seen across the board. Whichever weight reduction trial you see, you will see this kind of picture. So what was seen from 0 to 88 weeks was an almost 26% reduction as far as body weight is concerned. AEs are very interesting because adverse events always make us more I mean, we become much more, when there are new molecules which we are using, they create a high index of suspicion. We need to be vigilant at all points of time when we are prescribing a molecule to a patient, because I won't want to say by the book, by our conscience, we definitely do not want to harm our patients in any way. And if I say that, when you look at all the trial-related data, the main side effect is GI-related. Maybe in the discussion we'll talk further, but the main side effect is GI-related, especially when you increase doses. When you increase doses, there is more GI-related effects. What was interesting, friends, is, in the SURMOUNT-3 data, the data which was done in patients after intensive lifestyle modification, in those patients also the GI-related side effects were a little higher, whether it was because there were some changes which already occurred in the GIP, GLP-1 as a result of weight loss modification before they went on the trial, is a very, very interesting thought process. If you look at this, you would see nausea, vomiting, diarrhea, constipation. These are the most common side effects. What really helps is educating your patient. If your patient knows what to expect, it makes the patient's life much more easier. It makes your life much more easier as a clinician, because you are then not troubled by patients saying, oh my God, I'm having some amount of nausea. But understand, it's a change for the patient also. Oh my God, suddenly I'm not going to eat my favorite food. Suddenly my spouse is not going to the kitchen any longer. It sometimes troubles people also. And on top of it, this person is having nausea, maybe diarrhea. Some of my patients are really hassled by the constipation. All these problems can further worsen the situation, but these are temporary, seen mainly when you increase the dose, and can be managed very, very effectively with very, very simple therapy. And that is what our aim should be. As I said, all the data shows the same thing. And if I summarize what I set out to talk about, think about dual agonism. Molecules which work fantastically together. A single molecule with dual receptor agonism, which is giving you increased additional benefit, which is influencing your adipose tissue, which is influencing your ectopic fat, which is actually helping your adipose tissue behave better, helping your storage behave better. And when that happens, that is going to translate into definitely good metabolic health. Any kind of reduction of your body weight, be it 5%, be it 15%, is going to translate into benefit, and that's what we want. With an improvement in key parameters across the board, you look at it, you have improvement in blood pressure, you have improvement in waist circumference, lipids, and of course the most common adverse events were GI in nature. Thank you very, very much for your patient listening.
Is the million-dollar question, which is better, whether it is SEMA or whether it is tirzepatide. And to speak on that, we have Dr. Beena Bansal, who's the director, founder, Door to Care Endocrine and Diabetes Clinic, Gurgaon. Over to her.
Hi, good afternoon, everyone. I wish just speaking about GLP-1 would somehow act on our receptors, but I know I'm in between the food and the so I'll be quick. A lot has been discussed about semaglutide and tirzepatide and obesity. So my job is done. We routinely have people coming to our clinics. This is one of those cases, not uncommon at all. When we measure BMI, it is 35.5. I'll not go into the controversy whether that is a good parameter or not. But how do you usually diagnose obesity in clinics? I mean, we have been discussing so much about obesity, and we are seeing that people are talking that obesity is this and obesity is that. But in our minds, what is obesity? Or how do people see obesity? How do doctors see obesity? We still talk about weight. We still talk about body mass index with all its fallacies. We understand that a BMI of 30 can be a person with high fat, but if you had watched Paris Olympics, there were people with really strong bodies, very fit bodies, very muscular bodies, but they were not probably having obesity. I'll not use the word obese, having obesity. Again, there is a difference there. So one glitch here, and the problem is it is so easy to measure. We have to just ask them to get on the scale and we know the weight. we do not have better measures, and therefore we are still sticking to weight as a measure of obesity. So, I mean, with that fallacy, but at least one more measure should be done. At least do a waist circumference, because maybe that person doesn't have a high waist circumference. Maybe it's muscular. Maybe the fat distribution is somewhere else. So weight alone doesn't define obesity. Whether that weight is muscle, whether that weight is fat, and where the fat is, all of it is important. So getting back to this case, now she has, we'll say, obesity and dyslipidemia, and like any other person, when they land up with you, they say, we have tried everything. I'm just not eating anything. And have you heard this conversation often? And what is the first reaction we usually give? No, 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 there must be something wrong in the diet. Let's evaluate that. Let's send you to the nutritionists, because it's so difficult, because we know that that person may be right, that she's not eating anything. And when you take a diet recall, you don't know where to reduce what. So despite all the lifestyle interventions, people have tried hard, and they find that it is so difficult to lose weight, because biologically we are designed to gain weight. We are not designed to lose weight. The bodies are really miserly. It wants to store calories. It doesn't want to lose it, because anthropologically there were benefits. Now we have a maladaptive environment. We have food all the time, everywhere, and the store just keeps on increasing. So we are now resorting to other ways of kind of tackling it. The problem is, with so much of body fat at wrong places, there is a time. So adipose tissue or fat tissue is not just the fat cells we used to draw during histology, some clear cells. Now the anatomy of adipose tissue is, there is something in between the fat cells which is creating problem. It is sending signals for inflammation. It is inviting white blood cell. And therefore we see hsCRP going high. We see inflammation in the liver. So all that inflammation starts, which then starts leading to other problems like diabetes, because then that will spill over the pancreas, etc. So what we are trying to do is to reduce this dysfunctional adipose tissue, where apart from GLP-1, GIP helps. GIP has an additional action that it helps in adipogenesis, we say. So if the number of fat cells can increase, we'll have more area to store the fat. It doesn't have to then spill over to the ectopic tissue. When the number of fat cells cannot increase, that is when the problems actually escalate. So GLP plus GIP, the dual agonism, mechanistically has some advantage there. She also has some effect on me. So as we already saw, there are metabolic effects in her, and there are mechanical effects on her. And if we speak with her, I don't know why this is specifically a female problem. They are usually being told by so many people to lose weight that adds to another level of problem, which is emotional, mental. So it's a whole psychosocial thing which starts with that. So what will you do when a person comes with this? Do we send her to diet and exercise counseling again? We do. Why? Because she may or may not lose weight, but she may still become fitter when she goes for exercise. Maybe she develops more muscle mass, and she would help. The fat mass may go down, however, that may not persist. So we will advise her to work on the food distribution, eat more healthy food. Never say do not eat that. As soon as you tell someone not to do something, because the brain doesn't understand no. If I tell you do not eat dessert, I don't know if that works on anyone's brain. It doesn't work on mine at all, as Dr. Shaila just said. Coming to Kolkata and not having sweets, and then speaking about telling other person, please do not have sweets, is so not okay. So apart from exercise and dietary advice, because that is still required, it is still important to eat healthy, because there are advantages just by eating healthy and just by exercising, even if the weight doesn't come down. However, now we can go further and advise her, maybe pharmacotherapy, maybe bariatric surgery. So what everyone else, like, I think this is a poll question, but there are no ways to, so maybe you can just speak out. Will you advise pharmacotherapy for her? How many of you usually advise at this stage? Someone who has a BMI of 35.5, almost all of us, and how do you counsel patients? Do they resist that? What is the most important resistance we are facing nowadays? Yeah. So So there will be a lot of discussion required around that. What will be the long-term cost economics of it, etc. And so communication helps, and which one to choose is the next question. If suppose we are choosing pharmacotherapy, should we choose GLP-1 or a dual agonist? So what does the data tell us? This slide has already been discussed, how managing obesity helps with all these other complications. So SURMOUNT, you have seen various trials. What I will be specifically talking about is SURMOUNT 5, which compares weight reduction with tirzepatide as compared to semaglutide, because then that will answer the question, what are we going to advise to this lady? So what does SURMOUNT 5 does? It's a phase 3B trial. 3B means after FDA approval, the trials which are done are 3B trial. And there were 750 participants. It was an open label study. It was not a blinded study. It's a randomized study, active comparator. And the primary endpoint was what was the percentage change in weight after 72 weeks, because that is what we are going to tell the patient, that if you take tirzepatide, that will be the change after 72 weeks if you take semaglutide. Of course, the doses are increased as seen gradually. Every 4 weeks there is a dose escalation to up to the maximum tolerated dose, which may be 10, which may be 15 milligram of tirzepatide, and similarly for semaglutide, up to the maximum tolerable dose. It may not be 2.4 all the time, it may be 1.7 at points. Similarly, it may not be always 15 because it is MTD. What was the mean change at week 72? Now the type of analysis is modified intention. I'll get to that. So this is the difference between semaglutide and tirzepatide. 15% weight loss with semaglutide and 21.6% percentage weight loss with tirzepatide. So there is a clear benefit of one over another. If we see percentage weight loss, more than 25% weight loss was achieved in at least 1/3 of patients. So these has been repeated slides, but this is what we can kind of counsel the patient about. There was reduction in waist circumference. Now that is a better marker of what we are wanting to see. This is the wrong fat we want to remove, and the waist circumference reduction with tirzepatide was 20 centimeters as compared to 14.7 centimeter with semaglutide. Adverse effects, we know most patients may have nausea, usually lasts for 1 or 2 days after the injection, as from the experience, and it's not unmanageable. Usually you have to advise people, stop when you're full. That's the only advice if you give, because that is very tricky, because they may be full with just 2 spoons of rice and they would continue eating, and that causes trouble. So some simple instruction might help with that. Another patient, that patient did not have diabetes and this person has diabetes. So what is the difference? Now we are talking about weight management as well as which one of the two will help in managing HbA1c better. I'm not going to read through all of that, but importantly they have done an ophthalmologic evaluation where there was no evidence of retinopathy. I think that's required at this stage. We do not know what's going to happen. Retinopathy has been an exclusion criteria with most tirzepatide studies, so we will not probably use it in patients who have at least advanced retinopathy. So this person not just has a BMI which is 30.7, but HbA1c which is 9% despite so many medications. So we have all these choices, adding sulfonylurea, basal insulin, GLP-1 receptor agonist or dual agonist or thiazolidinediones. Which one would be preferred? So one of the way we use medication is the effect on weight. Of course, many of these are very fair choices for this patient. We can start insulin as well. We can discuss about sulfonylurea. So we have a platter of choices which we can serve the person there. Suppose we ultimately, because this would be the best choice if the person can afford and if the person is willing, it would be a good idea to start a GLP-1 receptor agonist or a dual agonist. Again, what is the evidence? Which one is better? Amongst the SURPASS trials, which were the trials done for diabetes, SURPASS-2 compared tirzepatide with semaglutide in patients who were already on metformin. It was the second drug. The mean duration of diabetes was 8.6 years, mean age was 56.6 years, and the number of patients studied were 1878. And this is the, sorry, I'll leave that. I'll leave look ahead. Why is the SURPASS? So SURPASS did show improved outcomes. So in between, I think there are slides which in general talks about with increasing BMI, increased prevalence of diabetes. Then we had a look ahead trial which studied the impact of intensive lifestyle intervention. This was 2015. We didn't have all these medications, but it did show improvement in all the cardiovascular risk factors, although it did not show improvement in cardiovascular disease. We know all the things surrounding look ahead, but it showed improvement in cardiovascular disease in patients who lost weight through exercise. So that's an important part of this study, and that's what we like. So SURPASS-2 studied tirzepatide versus semaglutide 1 milligram, because that is the dose approved for diabetes. It's not 1.7 or 2.4. So tirzepatide 5, tirzepatide 10, tirzepatide 15 and semaglutide 1. There are 4 arms. 8.3% was the mean A1C, 8.67 years of diabetes, mean baseline BMI was 34 and patients enrolled 1879. And I just need to show last 2 slides. The A1C reduction, you can identify the colors here. The gray one is semaglutide, which is the A1C reduction was minus 1.9%. Not a bad drug at all. Semaglutide did help in reducing it, but all doses of tirzepatide 5, 10 and 15 had a higher HbA1c reduction, which is minus 2.1, minus 2.4, minus 2.5. These were all significantly better. So significantly more patients achieved A1C targets across all doses of. So what percentage of patients could achieve A1C less than 7%, less than 6.5% and less than 5.7%. Now we are talking about A1C less than 5.7. So diabetes is almost gone into remission, and that also was a significant figure, up to 50% with 15 milligram. Also weight reduction in this group, which is less than people who did not have diabetes. We can see there we saw a higher percentage weight loss. Here it was 12.4 kg with 15, 10.3 kg with 10, 7.8 kg with 5 and 6.2 kg with semaglutide. Superior weight reductions was seen with tirzepatide all doses as compared to semaglutide 1 milligram. I leave with this slide, composite outcome, which is what was the percentage of patients who achieved A1C less than 6.5 plus weight loss more than 10% without hypoglycemia, which is like ideal condition which we want. And again, colors speak for themselves. You can make out 32% if they were on tirzepatide, 60% if they were on tirzepatide 15 milligrams. So that was the result of tirzepatide. So side effects are similar. To summarize, tirzepatide maximum tolerated dose demonstrated superior weight reduction versus semaglutide maximum tolerated dose 21.6% versus 15%. Superior HbA1c reduction with all 3 doses studied of tirzepatide versus semaglutide 1 milligram up to 2.5%. And the most common side effects were gastrointestinal in nature, which were mostly mild to moderate.
Request the other speakers to come to the dais. Any questions? Yeah, please. Yeah, please.
This is basically because with some sort of real life problems, you know. This is about myself. So I'm 50 plus, a consultant physician. My BMI is 29. Okay, fortunately I don't have any complications whatsoever. I don't have hypertension, diabetes. My family is quite good. But still my body fat by DEXA scan is around 27%. I went for that. So now my CG is normal. My TMT, I do exercise regular. I walk on a regular basis. My diets are more or less, you know, okay. So, but BMI still stands at 28.5 to 29 all the time, maybe over the last 4 or 5 years. So what do you think? Should I start off with either semaglutide or tirzepatide or whatsoever?
Yeah, you want to take? What are the problems with taking BMI only as the cutoff for making a diagnosis of obesity?
So, what you are telling is only the metabolic part.
Yes.
We have shown you 3 M's, mechanical part and mental part. Now the mechanical part of the complication, like if you are snoring in the night and the person does not know whether he is or she is snoring in the night, the partner will tell actually.
No, I'm not.
No, I am not telling about you. So it is the other M. So what are the mechanical problems like osteoarthritis, reflux, and then third is the mental part. Personally, mental means anxiety and so many other issues associated.
Yes, looking into the future.
Yes. So if you does not have any of the 3 M's, your BMI is only high, you come in stage 1 of Edmonton classification.
Yes.
Now there, it makes a case for taking lifestyle intervention, not drugs, and do lifestyle intervention. And if with that, you are continuing with that body weight and there are no 3 M's which are coming into your life, I do not see a place for using drug in you.
I'll intervene. I think the current recommendations, as Dr. Rajput had clearly said, but as I discussed, BMI both overdiagnosis and underdiagnosis obesity. As you have clearly, you have checked your body composition, and I hope with time this new knowledge of obesity is taken more into account when we are making these guidelines of whom we can prescribe medicine. So in your case, BMI is probably not giving the whole picture. There is abnormal visceral fat and abnormal body fat. So I'll leave at that. So ideally,
your
it is not
lipids are all
recommended.
fine?
Even if everything is fine.
Everything is fine. Nah? He does not have any
HDL
complication.
stands at 48, LDL around 55. So
Great.
See, I give you further, if we screen our own congress which is going on, and if we see the current criteria of using BMI, probably more than 50% of the people who are attending the congress will fall into that category.
And what
But
about
then that
fatty
does
liver?
not justify the use of that drug, any drug. We are not talking of any particular drug, any drug into that 50% of the entire population.
But you know, the thing that bothers me is persistence, in spite of my wholehearted efforts, cutting down on all the fat items, doing exercise and all these things. That is what we are discussing.
Okay, so that
actually.
comes to the second question. So what factors are leading, why lifestyle modification is very difficult to maintain the weight? Say you would have achieved 5 kg weight loss or 10 kg weight loss, and then you start regaining it. So now what factors produce the
Again,
reversal of
in the first
weight
lecture,
gain?
we have already discussed, as soon as you start losing weight through diet and exercise, your opposing set of hormones, which include your ghrelin hormones, your satiety hormones which are secreted from the gut, their secretion changes. Apart from that, the studies has been done which have shown change in basal metabolic rate, your thermic effect of the food, and non-energy associated energy expenditure. Now all these parameters changes because evolutionary body is naturally has a tendency to conserve energy. So as soon as you start losing weight, these evolutionary protective mechanisms comes into picture and there is a plateau and there is a tendency to gain weight. And that is the place where actually these drugs function.
Yeah, you
So
wanted to ask some
distribution
question.
of fat is very important. When you're talking about body fat, please look at the distribution also. Though the body fat percentage may look like you said 28 or 27, more than 30% is actually increased body fat. But when you look at that analysis, also check whether that, whatever that 28% is, where is it localized? Is it localized mainly in the visceral area? Because then the visceral fat...
Fatty liver is
no fatty liver.
Okay, what was your question? Yeah.
So thank you for the great presentation. I would like to ask 2 questions. One is considering be it GLP or GLP chip, there are multiple adverse events and they are projected to be mild or moderate. But have we considered the frequency of the the adverse events? And it not only comes as a use for us to reduce the body weight, it comes as a package of these complications of adverse events. So how do you see patient compliance in this? My second question would be, we are trying to reverse diabetes and reduce the body weight and try to fight obesity, but which percentage of body weight is considered to be ideal considering the adverse effects and complications?
See, personally, if you ask me, I have no experience with more than 300 patients, right? So percentage of body weight reduction again is subjective, varies from person to person. What are your goals? Now, what are the side effects? I think all the three presentations they have shown that GI side effects are the most common side effects. If somebody is having history of pancreatitis, we are not going to prescribe it. If you have a family history of medullary thyroid carcinoma, we are not going to prescribe it. If somebody is having macular edema, proliferative diabetic retinopathy, or severe non-proliferative diabetic retinopathy, we are not going to prescribe it. That is a job of a doctor as a doctor. Suppose if I answer in another way. Suppose there comes a drug on this earth tomorrow by research which does not have any side effect on this and which only causes benefit, benefit and benefit. Then probably you and me also are not needed. Patient will go on, read on the internet, go to the chemist, purchase it. So the duty of the doctor is to correctly identify the patient based on the medical history, risk factors, and to decide whether this drug is going to benefit the patient or not. The risk versus benefit ratio, that is our job to understand. So if the benefits are more and if the patient is willing, then we should offer those therapies. If the risks are more in a given patient as compared to benefit, we are not going to use the therapy.
Always educate the patient.
Yes.
Educate the patient regarding the
Along
risk
with the
profile.
fat loss, you are also losing muscle loss.
Yes.
And in some patients, there is severe sarcopenia. So how to calculate it and how to combat the sarcopenia along with this?
You should do some degree of resistance exercises plus include high quality protein into your diet. These are the two measures, because remember, whatever type of weight loss you are doing, forget drugs. We somehow focus only on drugs, even by diet and lifestyle, even by bariatric surgeries, even by endoscopic bariatric procedure. In whatever way you are losing body weight, your some degree of muscle mass is also going to be lost. So therefore, whenever patient or anybody who is undertaking weight loss journey, they should incorporate resistance exercises, good quality of protein into their diet so as to preserve the muscle mass. Now there is a new drug which has been recently approved in China. That's a different molecule which is also shown to now preserve muscle mass. So the future is with anti-obesity drugs with additional molecules which are going to preserve muscle mass. That is just 1 month back story. I will not make the name of the drug that is now available in China.
Spermidine.
No. It's anti-myostatin thing.
Yes.
So there's a trial known as the Embrace trial where they've used tirzepatide with that. Actually, bimagrumab, its counterpart, epitegrumab or something like that. So that trial, they found there was an increase in the lean body mass when they used tirzepatide alone versus this combination, phase 2 trial, I think. So now here the lean body mass actually started increasing. So that drug, if it comes, then this can be tackled. I told you, even if you lose weight with diet and exercise, you are still losing lean body mass. And I told you those experiments which they did in women and extrapolated to male. You lose around 22% lean body mass in women and up to 25%. And if you do see the meta-analysis of 25 studies with the GLP-1 and the GIP, they found a 29% decrease in lean body mass. So that's the reason we must focus on more weight strengthening exercises so that they can build up. And another thing is women are more actually prone for this. And one of the reasons they say is when you lose weight, your sex hormone binding globulin increases. And when that increases in a male, what happens? Bioavailable testosterone is still there. And hence, it has an anabolic effect. And hence, they are slightly less prone compared to women where this bioavailable testosterone is not increased. And hence, they are more prone from problems of this.
Thank you.
This drug is approved only for more than 18 years of age, tirzepatide. For semaglutide, in US FDA, approved more than 12 years of age. Higher age, no cutoff. No cutoff age.
they do complain of more weakness clinically, so that has to be, but if they have osteoarthritis and severe debilitating condition, there may be a case to give a small dose. I mean, that is again clinical discrimination.
Cautious.
Yes.
Much more.
Yeah.
GLP-1, GIP suppressing glucagon, but if we add glucagon like liraglutide coming up, so what's your idea? What do you think? And it's shown to be reducing weight much more than this.
The triple agonist is shown to lose 30% of the body weight. So let's hope for the final results and then let the drug comes.
There is a fourth, the G also coming.
Yes.
The 4G is coming, which is the IGF-1, I think, so that one. And in future we'll have 5Gs, 6Gs also. Okay. Right. Any other questions?
Can we de-escalate therapy after having target weight?
Yeah, so see, I have had a few patients. They achieved their target. I told them escalate it. They told, no, I'm okay now with this. Yeah, you can de-escalate and see that you maintain that. Somebody wants to lose just 5 kgs. He says, no, I just want 5 kgs, I don't want more. Just put them on, go up, and then you can come down and maintain at that. Yes, you can do that.
Ganpati, there is a study which has been recently presented at European Society of Obesity Congress. What they have done after reaching to the maximum dose where patient has plateaued the weight, and then they started decreasing the dose and see at what reduced dose patient continues to maintain that lost body weight. So it is possible in real world that once patient loses maximum body weight, then you can take a trial. Suppose for tirzepatide, maximum weight loss is achieved with 10 milligram dose. Now patient is comfortable. We can reduce it, see whether with 5 same weight is maintained, and if patient is able to do, we can de-escalate. That study has recently been presented 2 months back.
Yes. No, you can ask more questions. We have 5 more minutes.
I have told you semaglutide is approved for more than 12 years of age by US FDA. In our country, regulatory approval is still pending. So in our country, both tirzepatide as well as semaglutide is approved only for more than 18 years of age. So 12 to 18 years. In our country, no approval for any drug. US, semaglutide and liraglutide, both are approved. In our country, liraglutide is approved. So till that time, in your teens, you can use liraglutide.
Yeah, and in fact, liraglutide there was a trial done in 6 to 12 years of age also. So that means you can even come down below 12 also. Yeah. Yes, any other questions?
Lifelong.
Yes, that's a very important question, yes.
Lifelong.
The patients always ask, 3 months, 6 months? No, it's usually lifelong. But if suppose somebody is very much determined, you lost weight, and he is able to maintain that, then maybe you can just withdraw and see. If he starts regaining, then we'll have to restart.
But I think Shaila must have shown the studies where if you stop the drug, there is regain of body weight. So that happens even with the drug.
Yes.
If patient is going to stop the drug, weight is going to come back. That is why the answer is ideally lifelong.
Yes.
But then nobody is going to continue it for lifelong.
See, from the look ahead trial only. So what they found here was at the end of 1 year, the fat free mass, there's a lean body mass started coming down. And then what happens at the end of 8 years, they started gaining some weight, and whatever they gained was only the fat mass. They did not gain the lean body mass. So that means to say somebody is yo-yoing, no? Somebody goes on a crash diet, loses some 20 kgs weight, he's happy, and then actually regains weight. He regains only the fat, he's not regaining the muscle mass also. So that's a bad thing which is actually happening. So you have to tell the patient, no, you must continue to do good exercises. So maintenance, you require a little bit more intense exercises. And one of the reasons why it happens is our skeletal muscle efficiency becomes better. And the moment you start losing weight, he told about the resting energy, yes, you gain 300 to 400 calories. And this is because skeletal muscle efficiency improves. Now you are functioning better. Okay, so you are actually functioning better. Same work you are doing more efficiently, and that's the reason you are requiring lesser calories, and that's why you tend to regain the weight. Still okay, right. Okay. We still have 5 minutes, yes.
Yes.
Yeah, we are doing a lot actually. Yes.
We have experience
Yes,
of shifting
300.
from oral semaglutide to injectable semaglutide because with the increasing electronic media, patients are now aware that once a week preparation is also available. So say 14 milligram of injectable oral semaglutide is roughly equivalent to, these are not 100%, 1 milligram of injectable once a week semaglutide. For tirzepatide, there is no oral drug, so we do not have switch experience. From sema to tirzepatide, I have not done any shifting. From tirza to sema, I have not done any shifting, so no experience.
Right.
Brown fat?
Exercise.
Exercise and exercise.
Yes. So exercise increases beach fat. So that's how, so you'll have to do exercise. And theoretically, it stimulates one protein known as PGC1, something like that. Glitazones are known to produce that. Okay. Yeah.
Mike, क्या कह रहे हैं? Proton pump inhibitors.
Proton pump inhibitors to reduce the side effects. Suppose he's having gastritis.
Okay, you are asking proton pump inhibitor to reduce side effect. Prokinetics, okay. So remember, GI side effects are largely central in origin. The drug goes and acts on nucleus of tractor solitarius and area postrema, which are present in our hindbrain. Prokinetic act on your gastrointestinal system in the periphery. So largely these drugs are not going to be much of help, although large number of our colleagues are using. And if you have to reduce nausea associated with the drug, centrally acting antiemetics are more useful. There is a very small study where it has been found giving centrally acting antiemetic is to be more useful as compared to your prokinetic and proton pump inhibitor. Thank you.
Yes. Yeah, please.
Sir, mic पे आके बोलिए.
Mike.
Mic पे आके.
So there's an increased incidence of teenage obesity with a family background of type 2 diabetes. Can we use they may be the pre-diabetic. Can you use this drug?
We already told
अभी बताया था टीनेज में सर अभी 12 to 18 में कोई भी ड्रग इंडिया में DCGI से अप्रूव्ड नहीं है. Liraglutide approved है, आप liraglutide को use करो.
Maybe after that.
हाँ, once approval comes, we can
use.
Even non-diabetic patients.
Yes.
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 Many of the patients will be depressed and obese and all that psychiatric manifestation. How careful we need to be and what kind of dose modification, if at all required, and what are the things we should look for.
Yeah. In psychiatric patients, if they are obese,
patients with schizophrenia and all those things.
If you have psychiatric patient, I do not think any dosage modification is needed
there's nothing like
for
that. You can
any of the
actually use
patient.
it.
But remember, we have to be cautious when we are putting up psychiatric patients on these drugs. This is, I'm not sure, but this is one of the relative contraindications. If somebody who is having a profound degree of psychiatric disorders, these drug needs to be avoided actually, because there are some reports of suicidal ideation and other things in US database with use of these drugs. So remember what type of psychiatric condition we are talking of. Somebody with schizophrenia on so many antipsychotic drug, it is not preferable to use these drugs.
Should not be used. The definite data which show the increased incidence of suicidal ideation, and it's very important that if you're using it, and there's no, when you look at the data, psychiatric disorders are really not evaluated. Exclusion criteria was anybody with a psychiatric issues excluded from the data. So to be very honest, we have very limited information. Though when you look at the Edmonton criteria, we do say mental problems associated with obesity. But when you look at the trial-related data, we really do not have none of the people who were actually recruited for the trial were any people who was on had any kind of psychiatric issue. So please be careful. Be very careful. Be careful, judicious about who you're using it in. It does not have to be used as rampantly as the social media projects it out there.
Yeah, you wanted to ask, yes.
What is the best way to treat the constipation?
Increase bulk forming foods and stool softeners. ये सब goal. husk. Gastroparesis, it will not help. They decreases the GI motility
Yeah.
actually. So in
So let me-
gastroparesis, it will not help. But indirectly, if you are using in a diabetic patient, and if your glucose control improves, that may help you in some degree of improvement in gastroparesis. But always remember, in gastroparesis, patient may have more GI symptoms.
Okay, so regarding the psychiatric thing, see, there was one small study of 244 patients with obesity and mental diagnosis treated with this for 52 weeks. They did lose around 12%, but then as she told, no, there was some worsening of psychopathology noted with certain medications. For example, topiramate worsened depression, like that. So further studies are actually required for that.
First of all, reduce the dose of antidepressants. They themselves are causing weight gain.
Yeah.
And whenever
the
you are...
second thing, you are obese and that's why you are depressed. So I think when Ramona band came, it went off because of the suicidal ideation. A few of the patients told, I was depressed because of my obesity. I'm actually better now. Okay, so if it was because of obesity per se they produced, yes, you stop it. I mean, you can continue, but otherwise...
वैसे आप लोगों ने इतने क्वेश्चन पूछे, एक दवा का नाम मैं आपको बताता हूँ जो हम डायबिटीज प्रैक्टिस में बहुत कॉमनली यूज करते हैं, प्रीगैबेलिन. Now pregabalin is associated with weight gain up to the tune of 8 to 10 kgs. So therefore, until and unless it is clearly indicated, first of all, we should readdress our own prescriptions, how many drugs we are giving which actually is causing weight gain.
Okay, thank you. I think, please, last.
हाँ जी, हाँ जी, बिल्कुल, absolutely.
Next year, and so you'll get actually the
Cheaper
oral
drug.
and the injectable cheaper. So once that comes, we can actually use it for more. After March.
वो पॉलिटिकल और सोशल चीजें हैं, बस साइंटिफिक प्लेटफॉर्म पे कैसे डिस्कस करेंगे.
Yes, yes. And in fact, they'll be starting on a higher dosage and they come with side effects getting admitted. Yes, yes.
Thank you, sir, for this very informative sessions. Now we are moving on to our next session, that is decoding secondary hypertension from assays to algorithm. For that, I would like to chair the session Dr. Sanjay Shah sir from Kolkata and Dr. Shumit Chakraborty sir from Kolkata also.
Well, good afternoon, and I welcome all the delegates to this session, Decoding Secondary Hypertension. Before starting, may I request Dr. Sanjay Shah, my co-chair, are you there? Dr. Sanjay Shah, Dr. Sanjay Shah, if you are there, please come to the stage. Dr. Sanjay, okay. Dr. Nikhil available? Okay, fine. Well, without delay, we are starting this session, decoding secondary hypertension. This is something complex, I tell you. The first speaker is Dr. Nikhil Bhagavat. He is professor and head of the Department of Endocrinology. You can see the Topiola National Medical College at Mumbai. What he will be talking upon is PRA versus DRC. PRA means, Dr. Nikhil, please come to the stage. PRA is, you know, plasma renin activity. It's the measurement of enzymatic activity of renin versus DRC, that is measurement of direct renin concentration in the plasma. So without much fuss, I request Dr. Nikhil to please proceed with his talk.
Thank you, sir, for the kind introduction. The topic that I'm going to talk today on is plasma renin activity versus direct renin concentration assay, variations and clinical utility. So we all know that the assessment of RAS, that is renin-angiotensin-aldosterone system, is crucial in maintaining water and electrolyte homeostasis, and its dysregulation contributes to development of arterial hypertension. Now, approximately 25% of patients affected with arterial hypertension display low renin levels. And one of the commonest causes that we see in endocrinology, one of the commonest causes of secondary hypertension and low renin hypertension is your primary aldosteronism. So to distinguish between the different forms of low renin hypertension, accurate measurement of renin is of paramount importance. Now this is in general your renin-angiotensin-aldosterone system. In response to your hypotension or decrease in blood flow to the kidneys, your prorenin gets converted to renin in your juxtaglomerular apparatus in the kidney. The renin catalyzes the conversion of angiotensinogen to angiotensin 1. And angiotensin 1 gets converted to angiotensin 2 under the influence of angiotensin converting enzyme. And this angiotensin 2 acts on angiotensin 2 receptors and has an important role in blood pressure and volume homeostasis. It causes vasoconstriction and maintains blood arterial pressure. It increases sodium reabsorption in the proximal convoluted tubules, loop of Henle, distal convoluted tubule, such as the majority of the filtered sodium and water is reabsorbed in the proximal nephron prior to distal nephron. It also stimulates the release of vasopressin, which in turn functions as an arterial vasopressor, and via endocrine renal mechanism increases water reabsorption in the distal nephron, and it also stimulates the aldosterone synthesis and secretion. Now this is what happens physiologically when there is hypotension and hypovolemia, that there is a maximum absorption in the distal nephron. There is very little fluid and sodium is delivered to the distal nephron, that is your collecting tubules. So here you have optimal sodium reabsorption and volume expansion, decreased distal sodium delivery to the distal nephron, and here you have minimal potassium excretion. So this is your physiological renin-dependent hypoaldosteronism. But in cons or in primary hyperaldosteronism, there is autonomous secretion of aldosterone. So this aldosterone secretion inhibits your renin and angiotensin 2, and as a result of which there is minimal absorption of fluid and salt in the proximal nephron. So it is delivered distally, where your aldosterone acts through your mineralocorticoid receptors, which are present on the principal cells. So it causes volume expansion, again suppresses your renin and angiotensin 2. Since there is lot of sodium absorption, there is, to maintain electrical neutrality in the tubules, there is lot of potassium excretion. So that is how you get hypokalemia in this situation, and this also causes increase in your cardiovascular and kidney mortality and morbidity. So why do we measure renin? We should be measuring angiotensin 2 or other things, but we end up measuring renin, which is high up in the cascade. So we measure renin because it is very difficult to measure angiotensin 2. The levels are very, very minimal, and the measurement of angiotensin 2 is also very, very difficult. So renin estimation can be done by two types. One is your plasma renin activity, which is expressed as amount of angiotensin 1 generated per unit of time, and it is expressed as nanogram per ml per hour. Now it is dependent on the concentration of both active renin and angiotensinogen. And the second thing is your plasma renin concentration. It is the renin mass. So it is the measurement of concentration of renin molecules, and it is independent of angiotensinogen concentration. So before we move on to this, we need to understand what is prorenin also. So in plasma, renin is found in two forms. One is your active renin, and second is its inactive precursor, which is called as prorenin. Now prorenin has an extra 43 amino acid pro sequence at N terminal, which loops around the active site of the prorenin, and as a result of which it is inert and it is not accessible to your angiotensinogen. Now here is more important thing, that the normal concentration of prorenin is 10 times higher than that of the renin. And the proportion of total renin, that is prorenin, increases when the renin levels are low. So when you are looking at low renin hypertension, you are anyway going to have a high prorenin levels, and the prorenin levels are decreased when the renin levels are high. So under physiological condition, prorenin can only be hydrolyzed to active renin in the kidney. But in certain situation, that is in vitro situation, when you are doing an assay, conditions like cooling, when you expose the sample to -5 to 4 degrees or a low pH, it can stimulate spontaneous unfolding of the pro segment, followed by cleavages by non-specific plasma proteases, which results in renin activation. Now this is called as cryoactivation, and this is very important because this increases the level of renin and it can alter or play around with your renin assays. So hence sampling is very, very important for renin assays. So these are the precautions that we do for renin sampling. You have to withdraw drugs that affect renin secretion. You have to have unrestricted salt intake, because restriction of salt, unrestricted salt intake, the time of the day is also very important because it has a diurnal variation. Your renin secretion is more in the morning than in the evening, and the posture is also very important. When you're sitting or standing, there is a pulling of the blood in the lower limbs, as a result of which there is increase in the renin levels. So the sample needs to be collected in your EDTA tube. It has to be collected mid-morning after the patient has been up, sitting, standing, walking for a minimum of 2 hours, and then seated for about 15 to 20 minutes prior to collection. Very important. The blood should be kept at room temperature during transportation to the lab and before centrifugation. Centrifuge at room temperature, and as soon as the centrifuge and got the plasma should be snap frozen to prevent from activation of the renin, and it should be maintained frozen prior to the testing. So it should be about -80 degrees. So before the assay, thaw rapidly to minimize possible unfolding of prorenin, which may artifactually increase your renin. So these are the list of drugs which can affect. These are the permitted drugs: hydralazine, prazosin, slow release verapamil, and also a special thing inquire about licorice, because licorice can also affect estimation. So measurement of plasma renin is a 2-step procedure. So the first step is the generation of angiotensin 1 from enzymatic action of renin on substrate angiotensinogen. And the second step is the estimation of angiotensin 1. Now you have a lot of options over here. Initially when we did plasma renin activity for one of the project, we did it with RIA. But now you have ELISA kits, you have chemiluminosity kits, and now there are certain newer advances which are happening where it can be done by LC-MS assays also. So here what we do is we take 0.5 ml of EDTA plasma, you add a protease inhibitor and generation buffer is added to prevent angiotensin 1 in the plasma from degradation and maintain your pH around 6. Then this plasma is split into 2 aliquots. One fraction is incubated at 0 to 4 degrees on an ice bath, which is called as a blank, and another one is incubated at 37 degrees for 90 minutes or longer to allow generation of angiotensin 1 by plasma renin at 37 degrees centigrade. Now the measurement of angiotensin 1 is done, that whatever angiotensin you get in the blank is subtracted from the angiotensin 1 that you get at 37 degrees, divided by time is your plasma renin activity, which is expressed as nanogram per ml per hour. So why blank is used? We will be wondering why you want a blank over here. The blank is because there are certain levels of angiotensin 1 which could be present in the sample, which may not be because of your renin action on angiotensin. And this could be because sometimes you use polyclonal antibodies. They may react or cross-react with other substances which are very similar, or the sample may already have a circulating angiotensin 1 which may be present, which may contribute to the final measured amount. And sometimes at a typically low temperature, some renin activity can still occur at cool temperature, which used to prevent spontaneous angiotensin generation, and the blank accounts for this. So subtracting the blank value from the total angiotensin 1 measured provides a more accurate representation of true renin-generated angiotensin 1, reflecting the true enzymatic activity of the sample. Now, there is a twist to that. So this was a study which was done by Seeley and his group, and he found, he tried to look at what can be done to increase the sensitivity of this assay and whether the blank is required or not. So what he did was, he did this experiment with 3 different incubation timings. The first set was incubated at 90 minutes, second was incubated at 3 hours, and third was incubated at 18 hours. So he found that as the time increased with incubation, the angiotensin 1 generation is extended to 2 to 18 hours, the sensitivity of the assay lowers. So if you see over here, at 1.5 the sensitivity is 0.65, at 3 hours it drops down to 0.33, and at 18 hours the sensitivity is 0.06 nanogram per ml per hour. So thus, by incubating the sample for 18 hours, it is possible to have 10-fold increase in renin in low renin range. So just by increasing the incubation, you can increase your angiotensin 1 generation. Then he also looked at the blank. Now blank, what he said was, the error in estimation of blank can be as much as 100%. So if the blank is measured as 5 picogram, it can be 0 picogram or 10 picogram. And if the angiotensin 1 generation is carried out with an incubation of 1.5 hour, this range of error might result in a PRA activity which can range from 0 to 0.65. But if you increase your incubation, the blank has no effect. Your thing varies from 0.06 to 0.03. So what they said is, by increasing your incubation time of the assay, you can increase the sensitivity, you can go away with the blank. So his group, they do not measure blank, but instead generate angiotensin 1 long enough to make blank irrelevant quantitatively. So what are the advantages? So low PRA levels can be easily and accurately measured by extending the incubation time. Incubation at 37 degrees allows time for prorenin, which is opened up, to refold. Plasma renin activity represents the product of plasma concentration of renin and angiotensinogen. Plasma renin activity shows a good correlation with plasma angiotensin 2 levels. And PRA provides a reliable measure of stimulation of aldosterone production by angiotensin 2. But what are the problems? As you said, the problem is it's laborious. So it's going to be time consuming, and the whole procedure is for about 2 days. So it requires meticulous technique, which is beyond some laboratories. It is laborious and time consuming. So laboratories may adopt certain modifications in the method that makes comparison between the laboratories very, very difficult. And there are problems with quality controls because you don't have actual standards over here. So you can't compare a value from A lab to the B lab. So now we go to the next aspect, which is your plasma renin concentration. It quantifies the mass of active renin, and here it is a chemiluminometry assay which is available. It uses antibodies to directly measure the concentration of renin in a sample. So it is a sandwich assay where you use 2 monoclonal antibodies. So one antibody is your capture antibody, which is attached to the solid support such as magnetic bead, and it captures renin from the sample. Then you have a detection antibody, which is a second antibody, often radioactively or chemically labeled, binds to the different site of captured renin molecule. Then you do detection and quantification. So the presence and the amount of labeled detection antibody bound to the captured renin is then measured, usually by detecting the label signal, which could be radioactivity or light emission. And the signal generated is directly proportional to the concentration of active renin in the sample. So the advantage of this assay is that these assays are calibrated against an international reference standard, and this is the reference standard 68/356. So if the assays are calibrated to this and the assays are utilized by different laboratories, the assays can be comparable. So these are the reference ranges for the renin and the plasma renin. So if you can see that, but if you look at that, the sensitivity of PRA, plasma renin concentration, is about 1.6 to 2 microunits per ml, which is equivalent to PRA of 0.2 nanogram per ml per hour. So plasma renin concentration assay seems to be less sensitive than the plasma renin activity assay. So there is an excellent correlation between PRA and PRC, but this correlation is not so good in the normal range or the low normal range where we are concerned when you are making a diagnosis of primary aldosteronism. So PRA assay is different from, plasma renin concentration assay is different from plasma renin activity. It shows poor correlation with PRA in normal range. PRC can be discordant with PRA when angiotensinogen levels are increased. Now, what can increase in your day-to-day practice is estrogens or oral contraceptive pills, which increase your angiotensinogen, which increases your plasma renin activity. But if that happens, there is a negative feedback mechanism which suppresses your renin release. So these are the patients where your direct renin concentration may come low. So in females, anyone who's on oral contraceptive pills, you need to look for plasma renin activity, or the phase of the cycle is important, because in the luteal phase, again, you can get false negative or false positive results. So in menstruating female, when you're looking at it, you should draw a sample in the follicular phase or during the menses. So advantages of plasma renin concentration assay: it is an automated walk-away assay, less demanding on technician time, it is more rapid, you can get results within 1 hour, and it is more readily comparable between the laboratories. But the disadvantage is that if the prorenin unfolds, the antibody will trap the prorenin in an unfolded conformation and can increase the renin mass. Now, to avoid this, what they say is that you incubate the samples at 37 degrees for 1 hour to promote refolding of the prorenin before the addition of the antibody. So the results will not get spiked. It is less sensitive than PRA assay, and sensitivity cannot be increased by increasing duration of incubation. So when I conclude PRC, it is more rapid than PRA assay, more easily standardized. It is susceptible to artificial unfolding of prorenin, reduced precision at low renin level that can occur in primary aldosteronism. It has a poor correlation with plasma renin activity at low renin levels. Plasma renin concentration may be reduced due to high angiotensinogen level, and it can be elevated due to low angiotensinogen level. So I sum up this by this slide that PRA is not well standardized, but renin mass is standardized to a reference standard. So there is a better standardization between assay between different manufacturers. Labor intensive, renin activity is fairly manual, time consuming, can take 2 hours, but renin mass can be automated. Sensitivity for plasma renin activity can incubate for a prolonged period of time to generate a single in low renin sample, providing better sensitivity. But renin mass may not be able to measure renin concentration as low as renin activity assay. Reproducibility, because of the technical processes which are dependent on many variables like pH, incubation time, choice of angiotensinase inhibitor, purity of calibrators, PRA is poorly reproducible, but renin mass is reproducible, and PRA has been used in practice for a longer period of time, so we have a greater amount of supporting literature, but renin mass is available to us for a shorter period of time, and there is a less supporting literature. So thank you for your patient listening.
Thank you very much.
Thank you, sir, for your very nice elaboration. Now, may I request you to please sit over this dais. Now, may I invite our next speaker, Dr. Dinesh Chandra Sharma. And whenever we come across a patient of hypertension with hypokalemia, our brain is straightforward thinking it might be related with aldosterone, but it may not be the case everywhere. So let us hear from Dr. Sharma, who is the Director, Institute of Endocrinology at Strajan Hospital, Udaipur, hypertension with hypokalemia and non-elevated aldosterone. Over to you, sir.
Good afternoon, friends. Thank you, chairpersons, for the introduction and setting the context. And it's a fact that whenever we come across hypertension associated with hypokalemia, there is immediate suspicion of primary aldosteronism. And this is classically associated with primary aldosteronism. But a subset of patients with hypertension and hypokalemia have low renin, low aldosteronism. This is in contrast to low renin, increased aldosterone in primary aldosteronism. So low renin, low aldosterone levels is a distinct entity, and this was initially or now been termed as pseudo-aldosteronism. Condition mimicking aldosterone excess via non-aldosterone dependent pathways. That is, there are features of aldosterone excess by alternate pathways. I'll discuss in detail the mechanisms, but the aldosterone levels are normal. Recognizing these conditions is important given their therapeutic implications, the potential for full reversal for proper diagnosis and specific treatment. So we need to keep in mind whenever we come across patients with hypertension, hypokalemia and low renin, low aldosteronism. I'll discuss with you causes, the presentations, in brief the diagnosis and how to manage the patients. But before that, let us first recapitulate that aldosterone is secreted under the influence of angiotensin II, which in turn is governed under the influence of salt and water and so many influences, potassium levels. Aldosterone leads to salt and water reabsorption, and it also helps secrete or excrete potassium from kidneys. So ultimately there is more salt and water reabsorption and potassium excretion. The overactivity of aldosterone would lead to more salt water, leading to hypertension and hypokalemia. Now this slide is important to understand the aldosterone and the various conditions which are caused by pseudo-aldosteronism. Aldosterone is a steroid hormone, and it acts through mineralocorticoid receptor. MR receptor. So after entering the cell, this complex of mineralocorticoid receptor and aldosterone in the nucleus influences the glucocorticoid responsive elements, and this complex of the things leads to ultimately opening of the ENaC, that is epithelial sodium channels. This is how the sodium enters from the lumen into the cell. At the same time, this complex acts on the renal outer medullary potassium channels, helping potassium to be excreted in the kidneys. So sodium gets absorbed and potassium gets excreted. Now this ENaC is important, or this epithelial sodium channels. If there is a mutation in the ENaC, this may lead to absorption of sodium even without there being hyperaldosteronism. So this is one condition. I'll come to this. So gain mutation of ENaC can lead to more sodium absorption without hyperaldosteronism. So there are several condition associated with adrenal leading to hypertension, adrenocortical hypertension. Classically, primary aldosteronism, where there is low renin, high aldosterone. We are concerned with low renin, low aldosterone. The Cushing syndrome leading to hypertension is well known. So the conditions which are associated with low renin, low hypertension and low potassium, this is hyper deoxycorticosteronism, or the increased amounts of decorticosterone, and these are congenital adrenal hyperplasia and DOC producing tumors, or the deoxycosterone producing tumors, though rare. Then the other conditions are primary cortisol resistance, apparent mineralocorticoid excess syndrome, Liddle syndrome, which is with abnormal renal tubular ionic transport, MR mineralocorticoid receptor gain of function mutation, then subclinical Cushing's and ectopic Cushing syndrome, low renin essential hypertension. We have to keep in mind that some patients are some of the essential hypertension patients are having low renin. Then the consumption of frequent amounts of NSAIDs and COX-2 inhibitors can also produce low renin, low aldosterone hypertension. So I'll discuss one by one in brief. The conditions associated with increased levels of deoxycorticosterone are classically congenital adrenal hyperplasia, which we know very well. They are the autosomal recessive conditions associated with enzymatic defects and the steroid genetic pathways leading to impaired secretion of cortisol. Because of the impaired secretion of cortisol, there is ACTH drive, and this high ACTH drive would lead to further accumulation of the intermediary products, which might lead to hypertension and hyperandrogenemia. Approximately 90% of CH are because of 21 hydroxylase deficiency, but rare conditions like 11 beta hydroxylase and 17 alpha hydroxylase can cause hypertension and hypokalemia because of hypersecretion of the mineralocorticoid deoxycorticosterone, DOC or deoxycorticosterone, with decreased renin and aldosterone. These conditions are typically diagnosed in infancy and in childhood. They are associated with other conditions in addition to hypokalemia and hypertension. They have excess features of androgen in women as well as in girls as well as boys. Rarely the DOC secretion can be because of DOC secreting tumors from adrenal. Now, talking about 11 beta hydroxylase deficiency, which occurs in about 5% cases of all congenital adrenal hyperplasia cases. Because of this enzyme deficiency, the deoxycorticosterone cannot be converted to further down to corticosterone and aldosterone. So there is accumulation of DOC. And this is a mineralocorticoid, potent mineralocorticoid leading to hypertension. There is a defective cortisol secretion, and the substrate accumulation will lead to diversion of these substrate into the androgen pathway. So there is hyperandrogenemia. The girls present in infancy or childhood with hypertension, hypokalemia, and features of excess androgen in the form of acne, hirsutism, or virilization, and the boys present with hypertension, hypokalemia, and precocious pseudo-puberty. Now, the cases are mostly diagnosed in infancy or early childhood. There are higher levels of DOC, 11-deoxycorticosterone, and various androgens like androstenedione, testosterone, and DHEAs are all increased. Cortisol is decreased. The confirmatory test is by germline genetic testing. Another very rare condition, 17-alpha hydroxylase deficiency, and this enzyme is present both in the adrenals as well as in the gonads. So and this enzyme is required for synthesis of estrogen, androgen, as well as cortisol. So the deficiency of this enzyme would lead to defective cortisol synthesis as well as mineralocorticoid synthesis with accumulation of mineralocorticoid substrate like DOC and corticosterone. Again, since there is a defective production of gonadal hormones, so these children have hypogonadism, making this condition difficult to present before puberty. So most of these children present with hypertension, hypokalemia, but the condition goes unrecognized till puberty when they present with hypogonadism, and the girls present with primary amenorrhea. Again, there is a accumulation of aldosterone, testosterone, DHEAs, 17-OHP, and cortisol. The plasma DOC and corticosterone are raised. Confirmatory testing is again with germline genetic testing. Now, DOC producing tumor is very rare. They are usually large and malignant. So a patient who presents in middle age or late age with hypertension, hypokalemia, weight loss, and you find tumor sitting on the adrenals, you can think of this condition. There is a rapid onset of mild hypertension with hypokalemia and low aldosterone and low renin. The diagnosis is by high levels of plasma DOC or urinary tetrahydrodeoxycorticosterone, a metabolite of DOC. Now, another rare condition, primary cortisol resistance. It's a rare familial syndrome. There is increased cortisol secretion and plasma cortisol concentration without clinical evidence of Cushing's. So if you have high cortisol but no features of Cushing's, you can suspect this condition. The genetic defects is in the glucocorticoid receptor and the receptor complex. Presentation mostly in children with hypokalemic hypertension, alkalosis, and increased concentration of DOC and increased adrenal androgen secretion. The initial screening test, for all these parameters. The confirmatory test is again by germline genetic testing. Now this is very interesting condition. The apparent mineralocorticoid excess syndrome, the condition itself suggests, the name itself suggests, there is apparent mineralocorticoid excess while there is no increased mineralocorticoid. So aldosterone levels are normal or low, and there is an impaired activity of the microsomal enzyme 11 beta hydroxysteroid dehydrogenase. This enzyme normally converts cortisol, which is active glucocorticoid, to cortisone in the kidneys. And if there is a defective enzyme, there is an accumulation of cortisol in the kidneys. This leads to hypertension, because more cortisol is available, and these cortisol acts on the mineralocorticoid receptors and act like aldosterone. This is genetic as well as acquired, and this is a autosomal recessive condition when genetically inherited. Very interestingly, the enzyme defect can be acquired secondary to pharmacological inhibition of enzyme activity by metabolites of glyceric acid. The principal component is Glycyrrhizia glabra or the muletti. Now muletti is used by Ayurvedic people for many conditions to boost immunity, and there are case reports from our country with this root of this muletti root has been mixed with the gutka, pan masala for boosting immunity, for formulations to quit smoking, and people presented with hypokalemia and hypertension. Diagnosis: abnormally high ratio of cortisol to cortisone in a 24 hours urinary sample. Now Liddle syndrome is a rare autosomal dominant renal disorder in children, first described by Grant Liddle in 1963. Presentation is similar to primary aldosteronism with hypertension, hypokalemia, and inappropriate caliuresis. However, low renin, low aldosterone. The condition was for this condition the term was pseudoaldosteronism applied. Very rare. There is a gain of function mutation in the ENaC subunits. I showed the diagram, the sodium, the epithelial sodium channels. So there is a gain of function of ENaC subunits. There are 3 subunits, and with this there is a increased absorption of sodium, even though aldosterone is normal. Now differentiating this condition from the previous condition and cortisol resistance syndrome is maybe difficult, but good clinical response to amiloride or trimethoprim. Since ENaC is for the ENaC, the trimethoprim and amiloride blocks ENaC, while aldosterone doesn't work. The spironolactone doesn't work. So spironolactone is not effective in this condition. Only trimethoprim and amiloride, which are ENaC blockers, are effective in this condition. The definitive diagnosis is again genetic. Cushing syndrome, any type of Cushing syndrome, whether exogenous or Cushing disease or Cushing syndrome, because the adrenal region can have hypertension. In these patients, there is also increased levels of aldosterone. But in some subset of Cushing's patient, there can be normal or low aldosterone and low renin. So subclinical Cushing syndrome is one, where you have mild cortisol producing adrenal adenomas and similar presentation without aldosterone levels. When diagnosed, the condition is simple to treat by adrenalectomy. Another interesting condition and not rare condition in clinical practice is ectopic Cushing syndrome. Here, there is a high amount of cortisol secreted by the ectopic source. So very high levels of cortisol, which acts on the mineralocorticoid receptor, and high levels of cortisol would overwhelm the activity of 11 HSD, which converts cortisol to cortisone. So there is accumulation of cortisol, and these cortisol acting on the mineralocorticoid receptor, leading to hypertension. Clinically, most of these patients have malignancy, and unless high index of suspicion is given, this condition remains undiagnosed. So friends, diagnostic approach to patients with low renin hypertension, there are 3 categories. First is high aldosterone. We have primary aldosteronism caused by adenoma, hyperplasia, familial syndromes of hyperaldosteronism. In the middle, low renin and low aldosterone but high potassium. Low renin, low aldosterone, high potassium, and this condition is caused by pseudo hypoaldosteronism. I have not discussed, but just to mention that if low aldosterone, low renin, you have high potassium, this is pseudo hypoaldosteronism. I am discussing the third condition, low aldosterone, low renin, and the conditions are again low renin essential hypertension. In fact, patients with essential hypertension, around 50 to 60% patients with essential hypertension have normal renin. Some 30% patients have high renin, and a subset of 15 to 20% have essential hypertension, have low renin and low aldosterone. And this is a different subtype of essential hypertension patients. How to suspect? They are very salt sensitive, mostly elderly women who are very salt sensitive, reduce the salt intake, their blood pressure is controlled. They have less vascular complications, and there are other phenotypic features. The Liddle syndrome, apparent mineralocorticoid excess, congenital adrenal hyperplasia I have already discussed. So how to approach these patients? Once you have hypertension and hypokalemia, we measure aldosterone and renin level. If both are low, you are dealing with this condition. History, family history suggestive of this condition, maybe autosomal dominant like in Liddle syndrome, or autosomal recessive if there are other features. Then you have to exclude exogenous mineralocorticoid ingestion. Very high salt intake can also lead to suppression of aldosterone as well as renin. The frequent consumption of non-steroidal anti-inflammatory drugs and COX-2 inhibitors can also produce low renin, low aldosterone hypertension. Then history suggestive of licorice ingestion with the suppression of the HSD enzyme and causing acquired this syndrome is important. This is totally reversible. Then evaluate for cortisol excess using dexamethasone suppression test if you are suspecting early Cushing's or ectopic Cushing's. Then functional tests are required in some cases. In HSD, beta HSD defects, urinary cortisol to cortisone ratio would give you an answer, more cortisol than cortisol in the urine. Then treatment response trials. If you are suspecting ENEC or the Liddle syndrome, trying with therapeutic trial with trimethoprim or amiloride, very sensitive to these two drugs, and patient failing to respond to aldosterone or the spironolactone may give you a clue that you may be dealing with ENEC channelopathies. If you are suspecting adrenal tumors or Cushing's caused by adrenal lesions, imaging and surgery would be helpful. The final answer is given by genetic testing for, say, for example, various types of congenital adrenal hyperplasia, for Liddle syndrome, its variants, and for apparent mineralocorticoid excess syndromes. So, friends, to conclude my talk, hypertension and hypokalemia is classically linked to primary aldosteronism. We frequently and we commonly diagnose this condition. But if your patient has hypertension and low renin, low aldosterone, think of these conditions, though they are rare. But if you pick up and diagnose them, you can totally reverse the condition. It should prompt evaluation for CH if there is a clinical suggestion, Liddle syndrome, apparent mineralocorticoid excess, and other non-aldosterone mediated conditions. A structured diagnostic approach with the proper evaluation, history, examination, and targeted therapy can help proper diagnosis and yield excellent outcomes. Thank you very much.
Thank you, Dr. Sharma. So can you please take a seat for a nice presentation. So as part of this first session post kind of lunchtime, if you want to put it that way, we now have Dr. Kalyani Sridharan. Now, we all know that secondary hypertension has the same complications as hypertension has in terms of cardiovascular as well as renal complications. So what happens if you develop renal complications? In this patient, a creatinine of 2.6 in a 24-year-old male with resistant hypertension, how do you proceed to evaluate them to check for hyperaldosteronism and or low renin hypertension. Thank you.
Thank you, ESI, for giving me this opportunity. So this is a case scenario given to me with a 24-year-old male with resistant hypertension and a creatinine of 2.6. So before going into the scenario per se, let me start with what is hypertension. This is the ACC-AHA definition. Any systolic blood pressure of above or equal to 130 and diastolic blood pressure of 80. We define it as hypertension, and the goal to treat is values less than 130 and 80. And when do we call it resistant hypertension? So the typical definition is this: when the BP is above these mentioned targets, despite the patient being on 3 medication. So the caveat here is that the patient should be on maximally tolerated doses of medication, and typically the medication includes those from 3 different mechanism of action. That is a CCB, ASARB, and typically a diuretic is a part of the regimen. Now sometimes when the BP is controlled but is requiring 4 or more medication, even then we call it resistant hypertension. Now what is the prevalence of resistant hypertension? This is Indian data here. This is a slightly older study from JIPMER, which put the prevalence at around 11% of patients presenting to a hypertension clinic. Another study from Jaipur, which put the prevalence at around 20%. So we have a prevalence somewhere around 10% to 20% of patients presenting in the hypertensive clinic. So that's a substantial number. We need to know how to proceed further. So let's look at what are the causes of resistant hypertension. Now, before going into what are the causes, we should understand this term called pseudo-resistance. So when do we, this is very important because the prevalence proportion further management will depend on identifying this. Now, pseudo-resistance is when patients are fulfilling the criteria for resistant hypertension, but you find that this is because of medication non-adherence, or you have a suspicion of white coat hypertension, or the BP measurement is not accurate. So once we have excluded this, then we can say the patient is having something called true resistant hypertension. Now what is the cause of treatment resistance in patients with hypertension? Now predominantly these are some of the important causes. Lifestyle factors like obesity. We see a lot of obese patients. It's a pandemic. It's not uncommon to find patients with treatment resistance in those presenting with obesity, those with physical inactivity, those who have a history of smoking, and like sir was mentioning, dietary sodium is a very important factor, and this contributes to treatment resistance. Then several group of drugs can contribute to treatment resistance. We have NSAIDs, OCPs, sympathomimetics, cocaine, cyclosporin. All of this can contribute to treatment resistance. Sleep disorders like sleep deprivation, obstructive sleep apnea are some of the important causes of treatment resistance. In fact, obstructive sleep apnea could be one of the causal mechanisms of treatment resistance in obesity. So these are some of the causes of treatment resistance. In addition to all this, when there are certain clinical pointers, we should look at secondary causes. When would you suspect a secondary cause of treatment resistance? One is when there is the young age at onset of hypertension, or young age at onset of resistant hypertension, like in our case scenario. When there is true treatment resistance, that is, you have established that there are no pointers to pseudo-resistance. And when you find there is some other associated clinical features of organ involvement in the form of kidney disease, in the form of hypokalemia, in the form of endocrine conditions like Cushing's or pheochromocytoma or thyroid disorders. So this is when you should be thinking of other secondary causes. Now let's come back to listing what could be the secondary causes which causes treatment resistance. So again, kidney disease is one of the foremost group of causes which falls under treatment resistant hypertension. Chronic renal parenchymal disorders, CKD, renovascular hypertension like renal artery stenosis, primary hyperaldosteronism. Lower down you have pheochromocytoma, paraganglioma, Cushing syndrome, coarctation of aorta. All these are some important causes of secondary hypertension. Rarer endocrine causes, hyperthyroidism, hyperpara, CAH, DOCXS, acromegaly. All these also contribute to treatment resistance, but they are presenting as resistant hypertension in the first as a forefront presentation is slightly on the lower side. So let's move on to our case scenario. We have a young male here with resistant hypertension with elevated creatinine to the tune of 2.6. Now based on what we have discussed so far, I would be thinking of definitely a secondary cause of hypertension. Of course, we have to exclude pseudo-resistance here, and considering the elevated creatinine, the first differentials would be to rule out renal causes like chronic kidney disease, then renovascular hypertension like renal artery stenosis. Then moving further down, I would like to also rule out primary aldosteronism because that's an important cause of secondary hypertension. Then we have primary hyperpara. I've put this here because I will show you in slides the link that's recently coming up between PTH and aldosterone. Also because hyperpara, we commonly see hypercalcemia, renal stones that leading to AKI or renal stone related kidney disease, so which can explain the elevated creatinine. So these would be the list of differentials in that order. Less commonly, yes, you have to think of endocrine causes because we are talking about resistant hypertension in a young male. So anything, you can have an AKI presentation which can explain the elevated creatinine. So thyroid disorders, Cushing syndrome, pheochromocytoma, paraganglioma, acromegaly are some of the causes that we should be ruling out. Now let's briefly talk, I'll just concentrate on or focus on resistance in these scenarios. So talking of chronic kidney disease, now CKD can be both a cause and complication of hypertension. The treatment resistance here worsens with the worsening EGFR, mostly because of sodium and fluid retention. This causes blunted response to medication and therefore treatment resistance. So how do we treat the treatment resistance in CKD? So even in CKD, now because CKD itself can result from hypertension, long-standing hypertension. So if you're looking at a young male with resistant hypertension, you should be thinking of other secondary causes if there are such clinical pointers as well, like primary aldo, renal artery stenosis, other endocrine causes, depending upon the clinical features, not in all cases. Management will typically include a dietary sodium restriction. Now again, the treatment resistance in CKD is very sensitive to sodium intake in the diet, and it responds to dietary sodium restriction once you have excluded these secondary causes. Then typically what can happen is we can change the type of diuretic. If the patient is on say hydrochlorothiazide, replacing it with chlorothalidone will help in optimizing or bringing down the hypertension. So then the other secondary cause like I was talking about is renovascular hypertension. Now this can be either atherosclerotic renal artery stenosis, which is typical in older age, or in younger age in a female gender, fibromuscular dysplasia can cause renal artery stenosis. So clinical spectrum, they can present asymptomatically or as accelerated hypertension or as even renal insufficiency in more advanced cases. And the evaluation will include a renal artery Doppler to identify the anatomy of the renal artery, CT or MRI angiography, and if you're planning invasive studies, if you're planning intervention. So this is again a study which typically showed that across the rates of secondary hypertension depended upon the age group in which we are looking at, and renal artery stenosis increased across increasing age group. So age and gender plays an important role in ascertaining the prevalence or proportion of renal artery stenosis. So management, most patients will tolerate ASARBs without adverse effects. CCBs are also an option, and revascularization procedure is usually done for those failing medical therapy or resistant hypertension, which can include endovascular stenting or surgical revascularization. Now moving on to the topic that we are most familiar with, primary hyperaldosteronism. Now this is our own study from India, AIIMS Delhi, very recent study which said the prevalence of primary aldosteronism in their hypertension referral clinic was close to 8%. Now the prevalence in primary aldosteronism depends sharply on which cohort of population you are studying. So if you're looking at primary care centers, the prevalence has ranged from 5 to 8%, like what we have seen. If you're looking at hypertension in young adults, you are getting a proportion of close to 16%. If you're looking at resistant hypertension, you're getting prevalences close from 11 to 30%. So depending on which group you are studying, the prevalences are going to be more. So we are dealing with a resistant hypertension, definitely we should be talking about hyperaldosteronism screening, so which has even moved the focus of the current guidelines to recommend screening for primary aldo in all cases with hypertension. So this will depend of course on presence of resources and the kind of setting we are doing this in. And the screening, like it was extensively discussed, is with a serum plasma aldosterone levels, plasma renal levels, and the ratio, taking all precautions. And further testing and algorithms will depend on what you get on the screening, and then how we are able to lateralize your primary aldosteronism. So if the probability of lateralizing is more, that is if the patient has hypokalemia, very low renin levels and high aldosterone levels, and if you are thinking, so this is considered a high probability of able to lateralize aldosteronism. In this case, we will proceed with adrenal CT. And on adrenal CT, if we are having a patient less than 35 years, if you have severe aldosteronism and you have a more than 1 centimeter adrenal mass, we can proceed directly to surgery. If not, we go ahead with adrenal venous sampling. Adrenal venous sampling, again, is technically demanding to perform, but that is the option to lateralize the disease. And if we are able to lateralize, we go ahead with surgery. If we are not able to lateralize on AVS, we proceed to mineralocorticoid receptor antagonist. So this is in high probability of lateralizing PA. Now suppose we have, on the basis of the initial screening, if we have a patient with borderline aldosterone levels, normokalemia, then the likelihood of lateralizing is less. So the guidelines say do not proceed further and put the patient on MRA. And if it is an intermediate probability of lateralizing, we proceed with confirmation of the initial screening test using an aldosterone suppression testing. And then take it forward from there. If that is positive, go ahead with an adrenal CT and then continue the algorithm. So the ultimate aim is ability to find a lateralizing disease, proceed with surgery. If not, put the patient on mineralocorticoid receptor antagonist. Now, one other cause that I mentioned is primary hyperparathyroidism. Although not typical in the causes for resistant hypertension, the rates of hypertension in primary hyperpara is around 40 to 60%. It's not uncommon. But the opposite, not much data. We don't know what is the rates of resistant hypertension in primary hyperpara. And there are some interesting studies in literature. I'll just show you one case study that I found. So this was a patient who presented with resistant hypertension, was found to have hyperaldosteronism, which could not be lateralized to a single side. So it was bilateral adrenal disease, which showed bilateral adrenal nodules. Interestingly, the patient also had primary hyperpara, had a parathyroid adenoma, and these adrenal nodules showed PTH receptor positivity. So one hypothesis that they came up is that PTH acts on the PTH receptor on the adrenal glomerulosa cells, causing an increased aldosterone, and that in turn causes resistant hypertension. So after this, there came limited case series with 7-8 cases linking PTH to aldosterone, hyperaldosteronism, and one pathway for hypertension in these patients. So this is an interesting link, so which is why I thought I should put it here. In addition to this, we should, like I said, also be looking at other endocrine cause of resistant hypertension, especially Cushing's and FIO can present with resistant hypertension per se. They have their distinct clinical presentations. I'm not going into too many details of it. And screening tests and the management will depend on what the condition is. Now, how do you go about evaluating resistant hypertension? Step 1 is confirm treatment resistance. Like I said, confirm all these 3 things, that patient truly has resistant hypertension. Step 2 is exclude pseudo-resistance. Make sure that the patient has the, confirm the medication adherence from the patient. Make sure the patient has home BPs or ambulatory BP monitoring to exclude white coat hypertension, and the BP is taken under proper BP measurement techniques. Once we have excluded pseudo-resistance, then you assess also the hypertension target organ damage. Perform a fundus examination, cardiac examination, renal and peripheral arterial disease to assess for target organ damage. Once that is done, then we look at the secondary causes. Like in this case, we are looking at these 4 as a primary secondary causes. So you look for the relevant history and examination on patients. Especially important is the carotid and renal bruit, because we are talking about renal artery stenosis. History, evidence of renal artery disease or evidence of CKD, and evidence of endocrine symptoms. Then the initial test will include urine analysis to look at sedimentary infection, kidney function test, ultrasound for kidney size and ecotexture, renal artery Doppler for renal artery stenosis, and PAC-PRA for primary aldosteronism. Then depending on what we get on the initial test, if we are able to reach a diagnosis, we stop there. If we do not get a diagnosis, we proceed further and look at all these secondary causes and do the appropriate screening test for these secondary causes. So management, primarily, it will depend on your initial diagnosis, but certain other steps also help, like ensuring a low sodium diet, except of course in FIO, ensuring a low sodium diet, weight loss, exercise, avoidance of smoking, and optimizing the initial adherence to medication will help in optimizing BP. A second step especially would be to change the diuretic to a thiazide-like diuretic at particularly high doses. If the BP is still not a target, we could consider adding an MRA, especially spironolactone or eplerenone will help in low renin hypertension, even essential hypertension cases. BP is still not a target, we sequentially can add a beta blocker, hydralazine or a minoxidil as per this AHA sequential up titration scheme. So to conclude, we have to establish there is true treatment resistance, exclude pseudo-resistance, take a good history and clinical examination, phenotype the patient clinically, and then that should guide the initial testing. And the further tests will be based on what are the initial test findings, and treatment will depend upon the underlying cause that we are finding. In addition, lifestyle measures, dietary sodium restriction, physical activity and sleep hygiene, these are some of the underutilized measures for the control of resistant hypertension, and especially in elderly patients, simplifying treatment resistance will really help. Thank you all.
Thank you very much. A big hand. Thank you. So that concludes this session. So we're going to have 15 minutes of discussion. Can I ask Dr. Bhagwat to perhaps join us on the stage? And while we wait for people to ask questions, I must thank SECON 2025 Organizing Committee for asking us to stage this session this afternoon. Yes, sir. Please, can you check the mic, please? Yeah.
Okay, my question is to the second speaker, Dr. Kalyani. See, when you have CKD, the number of nephrons is dwindling. So the amount of renin produced is low and also aldosterone produced is low, number one. Number two, hyperkalemia may be a part and parcel of CKD. And third, I expected you to talk about that how a patient of CKD, how the levels of aldosterone, metanephrines will be changed because of CKD, in presence of CKD.
Please.
So yes, sir. Like you said, the levels, the renin is primarily produced from kidneys, so the levels of renin will be altered in CKD, and it might actually be low. And so the primary aldosteronism diagnostic algorithm remains same even for CKD. So the cutoffs are not very different, and the problem can come in management because hyperkalemia can be a problem. So when you're giving a mineralocorticoid receptor antagonist, what the guidelines have mentioned is it's possible to move to a non-hyperkalemic MRA like a finerenone, which can sometimes help if there is troublesome hyperkalemia with eplerenone or with spironolactone. So that is one change in the management that we can do.
So in your case,
if ARB cannot be given due to hyperkalemia in this case, along with this hydralazine and beta blocker, which CCB can be safest? Which kind of CCB? Which one?
Which kind of CCB?
Yes. When ARB cannot be given due to hyperkalemia.
Yes. So CCBs are safe, both long-acting as well as nifedipine, or even rate limiting that diltiazem or verapamil can also be used as a CCB option if ACE-ARB cannot be given because of hyperkalemia. Another thing is we can also use non-potassium sparing, like finerenone is also a good option for ACE, for CKD. The other drugs that I mentioned, hydralazine and minoxidil, have their own adverse effects, but yes, if that is not an option, hydralazine, minoxidil, even prazosin can be a good option for patients with CKD for hypertension control.
Cilnidipine?
Cilnidipine is also CCB, so that is a good option.
That comes in the list, sir. Yeah.
So for your case,
thank you.
Just one more.
Yeah.
So why did you use thiazide diuretics instead of loop diuretics? That's number one. And what percentage of patients do you think, who are falling into the group of resistant hypertension are salt sensitive? 20% or more?
So close to almost 1/4 of all patients with resistant hypertension are salt sensitive, and especially more in the subgroup with CKD. So giving dietary sodium restriction will actually help, is a good way to start with the management of resistant hypertension in CKD. So loop diuretics again can be, especially when hyperkalemia is a risk, we can add on a loop diuretic to decrease the risk of hyperkalemia in these patients. So either a combination with a loop diuretic, or we can also modify the thiazide diuretic to manage the treatment resistance.
aldosterone synthase inhibitor, baxdrostat, can be used? Baxdrostat.
So yes, sir, they can also be used, but the data on the renal CKD subgroup or end-stage CKD is slightly lesser. So we don't have enough data on
Enough
them.
data, sir.
Yeah, so I think we'll have to wait till 2028 till we get the data with respect to the aldosterone synthase inhibitor. So can I just ask Dr. Bhagwat here that if we think that nearly 7 to 8% of the patients with hypertension has got sort of secondary hypertension, largely aldosteronism, what investigation in terms of renin, angiotensin, and aldosterone that you mentioned would you recommend? Because you went through this in great detail. Is there a shift towards what we perhaps should be doing lately? Or is there a different for different groups of patients like men and women? Or actually we are very actually happy with the gold standard?
See, we've been using, hello. So far we've been using plasma renin activity for all this time. So when we did a project to look at evaluating, it was to find the prevalence of primary aldosteronism in patients with hypertension, we had no other option, but we did plasma renin activity. And that assay was very, very cumbersome. We had to procure liquid hydrogens.
Very fiddly.
Yes, we had to snap frozen it. Then tubes were a problem, borosil tubes. Sometimes the tubes cracked, and we had to repeat the sampling again. So it was very, very laborious and this thing. Walkaway system, majority of the labs now, if you see, if you're doing it in-house for research, I will definitely do a plasma renin activity. But many of these assays are now being outsourced to reference laboratories, and they have now moved from PRA to direct renin concentration. Because it is very simple to do, the results will come within an hour, and again, as I told you, they're referenced to an international standard. So comparability between the results is also very, very good.
So you say that perhaps aldosterone is to direct renin concentration is the way to go, and that's exactly how it is. Well, thank you very much. Any questions? While we wait for another question, can I ask Dr. Sharma?
My question to you, Dr. Sharma. So that pseudo-hyperaldosteronism that you are talking about, I mean, if the patient is having hypertension with low potassium, with low aldosterone, so we have seen the classifications and all. So what would be the approach as far as the treatment is concerned? Will there be any difference?
So as I showed, the approach would depend on the age of the patient, presentation of the patient, family history. If there is a family history, young onset, and if there are features of other endocrinopathies like precocious puberty, delayed puberty, or virilization, we would think of congenital adrenal hyperplasia. History suggestive of some, herbal medication or allopathic drug, homeopathic drug, or Ayurvedic drug, you would obviously rule out licorice ingestion. Else, you depending on your suspicion, sometimes these are rare syndromes, and you may not be able to pinpoint till you have genetic workup.
So how do you treat the hypertension? The same way?
If you are thinking of, say, Cushing syndrome, the cortisol resistance, then in addition to the conventional drugs, spironolactone may be effective. But if spironolactone is not effective and you are using amiloride, trimethrin, and this magically works, means there is a possibility of Liddle syndrome, a rare condition.
Thank you, Dr. Sharma. I think what I really wanted to ask you was, there is a huge long list. Most of us are adult physicians. What happens in adults? I mean, common ones, though that is very uncommon anyway, a normal aldosterone level and hypokalemia. The common adult hypertension.
Practicing so many years, I've seen this condition only in congenital adrenal hyperplasia.
Okay.
I've not been able to diagnose these rare syndromes, Liddle syndrome, ENEC syndrome.
So there you are.
Just theoretical.
Thank you very much. So I think there was the first question sir asked. I perhaps want to rephrase it for Kalyani. I think what is the confounding factor is the creatinine of 2.6 in your patient. How does that affect the analysis of the hormones that we actually do in endocrinology? And obviously the potassium is not going to be low with somebody with a creatinine of 2.6. So how do you go about it?
So, sir, again, so in a patient with a value of around 2.6, we could be looking at CKD as the primary cause of hypertension. And we could be looking at renal artery stenosis, which in turn is leading to CKD. So, yes, so the problem comes with, now if we are finding the patient, we are expecting it will be hyperkalemic. If we are finding hypokalemia, that's well and good, we proceed towards aldo testing. But otherwise, CKD is going to modify all the picture. We will find a low renin may not always translate as a low renin causes of hypertension. It could be because of CKD per se. So in that, it is probably we will have to proceed with the algorithm depending on the other clinical features and the other diagnostic testing. So if we do an aldosterone levels and the levels, if we are not able to pass the initial screening test, then we'll have to go with confirmatory tests like an aldosterone suppression. It would be a challenge to do it with, so interpretation of these tests could be a challenge. So I think there are no two.
Can I add?
Yeah. Sir, you can.
Sir, can I add a little comment? Continuing Dr. Jindal's question, with progressive decline in EGFR, there is a decline in renin as well as aldosterone levels. But in primary aldosteronism, we would expect aldosterone to be high for the whatever given EGFR. Inappropriate, right?
So for the literature is saying it's the factor of 8. So you divide that with 8. Renin, concentration. PRC.
May I make a small? Partially that was made by Dr. Sharma sir, and the cause of CKD will also matter. No? If it's a CIN kind of CKD, then obviously the potassium loss will be more and that will confuse you more. The creatinine alone will not give you the answer, and at this creatinine of 2.6, the EGFR will be somewhere around 30 to 40, where I think, as sir was pointing it out, the values which we usually, they will all be high. Renin and aldo should be high at that day. I mean, I don't think it's like a end stage renal disease where the mass of the nephrons are totally very low. I may be corrected, there are nephro experts here, but my suggestion is that. So 2.6 is a dicey number where I think if the potassium is low, I'll be more harping on all my endocrine diagnosis. If the potassium is not, I thought the etiology of CKD matters.
Yeah, basically trying to find the cause for the secondary hypertension is worth it, because you'll then be able to actually change what will happen to the patient over the long term. That's how it is. So that's important, really. So we can perhaps take one last question if...
We have 4-5 minutes time.
Couple of minutes. Yep. Yeah.
hierarchy of anti-hypertension rather than, doing all these elaborate fancy tests and then coming to a this is what we are also saying.
Yeah, this always, lateralizing is always a challenge, and scanning, CT scan also perhaps don't give you the same kind of information that we actually want. We've had a trial for that as well. You wanted to make a comment?
Yes. So when I was going through the current aldosteronism guidelines, so this is a question I had as well, that there is a lot of emphasis put on lateralizing the disease, and through AVS, in spite of, although when their reasoning that they give is that lateralizing disease will give a curative option over long-term MRA in patients who you are expecting hypertension to be more than 20 years. So adverse effect of the drug, long-term need for treatment, and even after all that, cardiovascular mortality is slightly higher than surgical group. But I think this is something that can be simplified. That's my humble opinion.
This month's Journal of Clinical Endocrinology Metabolism, there is an article
you have a young patient with primary aldosteronism, with hypokalemia, with a nodule, you can straight away go through surgery. But if you have a... No, but if you have 67 with multiple medications, in spite of that severe hypokalemia, with a 3 centimeter nodule in one adrenal, would you still subject him to AVS or go through surgery? It's almost 3 centimeter nodule. The size is quite...
Depends on the younger the patient, the more chance of getting to surgery.
Instead of AVS, can you just go through the surgery? Because it's almost a 3 centimeter nodule.
3 centimeter nodule, possibly we should think of surgery.
So I think all good things must come to an end. So thank
I
you
thank
all for this afternoon session. Thank you very much.
For the next session, I would like to invite Dr. Tapos Chandra Das and Dr. Priyander Singh Thakur. Please come to the podium, sir.
Good afternoon, everybody. This session is implementational issue. First topic is critical illness related to adrenal insufficiency. Critical illness is a state of any life-threatening condition that leads to mechanical and pharmacological support to the patient to provide support of the vital organ function to prevent immediate death. Critical illness leading to adrenal insufficiency in the tune of 30%. We learned this topic thoroughly from Dr. Beatrice Annie, who is the additional professor and head of the Department of Endocrinology in Nizam Institute of Medical Science, Hyderabad. Dr. Beatrice Annie.
Thank you. A very good afternoon to all. So over the next few minutes, we will be talking about a very important practical concept, that is critical illness related corticosteroid insufficiency, and what are the implementational issues. So this is how we'll go about it. We'll talk about the definitions as of now and how the concepts have evolved over the years about this definition, and what are the physiological changes during critical care, and what are the diagnostic and treatment consensus, and lastly, what are the implementational issues with these. So I will start. I'll give you 3 case scenarios which I'm sure all of us would have seen in our practice. So this is a first case, a 56-year-old lady who is in acute shock post cholecystectomy. She has a preceding history of fatigue, lethargy for 2 months. She also is hyperpigmented. She has hyponatremia, hyperkalemia. Her ACTH is more than 200. Her serum cortisol is 2 microgram per DL. So this is the first case. Let's have a look at the second case. It's a 58-year-old gentleman who has community-acquired pneumonia, and he's in septic shock, and he's also on high-dose vasopressor therapy, and his ACTH stim test, which was done in the ICU, is showing a cortisol response from 19 to 24 microgram per DL. That is about 5 increase. This is the third case, a 68-year-old lady with bowel perforation, sepsis. She's had multiple surgeries, and she's been in the hospital for a long time. She is now there with encephalopathy and she's having shock on vasopressors. Her day 4 cortisol, that is day 4 of hospitalization, her cortisol levels were 28. But on day 30, her cortisol levels had dropped to 8 and the ACTH was around 20. So with the background of these 3 cases, we'll see what is critical illness related corticosteroid insufficiency. So a few definitions to start with. Critical illness is any condition which is evoked by major surgery, severe medical illnesses or multiple trauma, requires pharmacological or mechanical support of vital organ functions, without which death would ensue. So this is the definition of critical illness, and it is a condition of severe and sustained physical stress for the human body. The stress response is basically a combination of closely interrelated physiological reactions to this stress to maintain and restore the homeostasis in the human body. Now what is critical illness related corticosteroid insufficiency? So this is hypothalamus pituitary adrenal axis insufficiency in the course of acute medical conditions. So this is a definition given by critical care medicine. This is way back in 2008. So this was also known as a relative adrenal insufficiency, but it is more of a functional etiology. We are not really looking at structural causes, and this may develop without structural defects in the HPA axis. So the HPA axis, what happens in critical conditions? So this is the response. There is an acute response, that is a few minutes after the initial damage. Then there is a subacute response, which is a few hours to several days after the initial damage. And there is a chronic phase, which is more than a few weeks after the initial damage. So this is what happens. So initially in the acute condition, so the acute inflammatory phase, there is an increase in the ACTH and there is increase in the cortisol synthesis. So this was what was always carried along. So in critical illness, there is going to be an increase in the ACTH and there is going to be an increase in the cortisol. So this was the concept which was there all along till 2013. I'll tell you the paper now about, I'll tell you about the paper in 2013 which changed this concept. And then we have the chronic inflammatory phase. Now we know that there is this ACTH increase is not prolonged. And in fact, in chronic conditions, we see that the ACTH is actually low. So there is a loss of ACTH mediated stimulation of the adrenal cortex. So this is how the concepts have evolved. Now how does the body maintain the cortisol levels in the face of increasing stress? So there is an increase in the systemic cortisol availability. So I told you, as the stress period progresses, your cortisol levels are high, but the ACTH levels are not so high. So what is causing this high cortisol level? So you see the cortisol metabolism in the kidney and the liver, the 11-beta HSD2, which is going to deactivate the cortisol. So the level of that enzyme comes down, which means there is going to be more active cortisol in the blood. And you have the other enzymes as well, the 5-alpha and beta reductase, which are present in the liver. Again, they also inactivate the cortisol. So those enzyme activities are also going to come down. So there is going to be an increase in the cortisol level. And there is going to be increased conversion of cortisone to cortisol. So activation of cortisol is more in the extraadrenal tissues by increase in the activity of the 11-beta HSD1. So by all these mechanisms, we know that there is going to be an increase in the systemic cortisol availability. And this is also partially mediated by the inflammatory cytokines in stress and shock. So what happens to this glucocorticoid or the cortisol levels which are increased in the blood? Why do we call sepsis or septic shock as a state of glucocorticoid resistance? Because in the peripheral blood cells, they have found that there is actually a decrease in the glucocorticoid receptor alpha expression. And there is an increase in the glucocorticoid receptor alpha expression in the adipose tissue and the skeletal muscles. So there is in fact a differential effect of glucocorticoids during the time of sepsis. This is an adaptive behavior by the body because the innate immune cells are prevented from or protected from the immune suppressing effects of cortisol so that they can mount an immune response. So that is why there is a differential effect. Now, can we say that there is actually there is a generalized tissue resistance? Maybe it's wrong because this is an adaptive phenomenon. There is actually differential tissue resistance to glucocorticoids in sepsis. So why do we give a stress dose of glucocorticoids? We'll talk about it later. So what are the physiological changes? What are the newer insights? So this is the paper in 2013 which changed the idea of this increased ACTH causing increased cortisol. So what happened here was, in this particular study, they have looked at patients in the ICU and they have found how cortisol is metabolized in these patients during critical illness. So if you look at this, the plasma cortisol level in the ICU patients. So as the number of days, so the blue bar is actually the normal controls. We see that the plasma cortisol levels are higher than in the normal controls. But, but look at this. The ACTH levels on the other hand. So the big blue box is the normal level. So if you see the ICU patients, the ACTH level is lower. So there is an ACTH cortisol dissociation in the ICU patients. So what happens to this cortisol kinetics? Again, in these patients, tracer attached cortisol was injected to see how the cortisol is metabolized in these patients. And they found that the plasma cortisol was higher in these patients, and even the tracer attached cortisol, when you injected the tracer attached cortisol, even that was higher than in the controls. And they saw that the rate of appearance of cortisol and the disappearance was lesser, which means the pool of cortisol in the blood is more in these patients who are in the ICU. And they looked at the enzymes which are causing this cortisol metabolism, and they found that the overall 11 beta HSD, which includes both HSD1 and 2, so the overall activity is increased, which is predominantly contributed by the 11 beta HSD1. So that is for the activation. But on the other hand, the 11 beta HSD2, which inactivates the cortisol, though that level was found to be lower in patients who were in the ICU. And 5 alpha reductase activity and 5 beta reductase activity, which are again involved in inactivation of cortisol. Those levels were found to be lesser in these patients in the ICU. So this is contributing, a reduced inactivation of cortisol is contributing to the increased cortisol levels in patients in the ICU. So let's have a relook at the HPA axis in critical illness. So if you look at the acute phase, almost all the anti-pituitary hormones, your growth hormone increases, and then there is an increase in the TSH, increase in the ACTH. That is the acute phase, which is shown by that red triangle there. But as the disease progresses, we see that the anterior pituitary hormones come down. But if you look at the peripheral hormones, initially there is a dip. So there is going to be a decrease in the IGF-1, a decrease in the T3, T4, and then the peripheral hormones kind of stabilize. But the only peripheral hormone which stays high is the cortisol, which is even in the chronic phase, you see higher levels of cortisol. And that is the ACTH cortisol dissociation we're talking about here. Again, in the ICU, you can see that the blue block is the normal. So you see the plasma ACTH, which is lesser in these patients in the ICU, and the plasma cortisol levels and the plasma free cortisol level. Now this is a very important point again, because even if the plasma cortisol levels are normal, not as much increased for sepsis that you would expect, still the free cortisol levels will be higher, because the CBG or the cortisol binding globulin, the levels come down. So there is in fact more free cortisol levels to access to the tissues. And if you look at the cortisol metabolism, again, you know that the 11 beta HSD1 is going to be up titrated and 11 beta HSD2 is going to be reduced, and there is going to be increased activation of the cortisol and decreased inactivation by the liver enzymes like 5 alpha reductase and 5 beta reductase. So this is again the enzymes and the cortisol metabolism. Now let's look at the adrenal steroidogenesis and what happens to that in patients who are in chronic stress. So here you see that the ACTH has to act on the MC2R receptor, which is going to activate the protein kinase A, and then you have the synthesis of cholesterol here, and the cholesterol is taken into the mitochondria through the star, and then you have all the enzymes which are activated for synthesis of cholesterol. And you have two proteins here, the SCARB1, and you have the receptor here, LDLR receptor. So these two again will help in taking up the cholesterol into the cell, which again can be used for synthesis of these steroid hormones. So what does ACTH do? ACTH is going to activate this pKa. It is also going to increase the activation of the SCARB1 and the LDL receptor, so that you have more cholesterol for synthesis of the steroid hormones. And ACTH also regulates its own receptor, that is the MC2R receptor. So what happens in patients in stress? Now let's look at the short ICU stay and the long ICU stay patients. If you look at the MC2R, the expression of the mRNA, we see that it comes down drastically in patients on the long ICU stay, which means that ACTH in chronic stress may not be really responsible for the increase in the cortisol levels. And we see here again the mRNA expression of SCARB1 and LDL receptor, which are important in taking up the cholesterol into the cell. Again, they have come down drastically in patients who are in the long ICU stay group. And that is HMG-CoA reductase, STAR enzyme, cytochrome P11A1, all of them are reduced in patients who are in the long ICU stay group, and all of them have to be modulated by the ACTH. So the ACTH comes down, and all of these phenomenon is going to come down. There's going to be reduced cortisol synthesis. So this is what we know as of now about what is going on in patients in chronic stress. So when there are psychological, physiological stressors, there is going to be activation of the hypothalamus. The CRH gets released. So the question mark next to CRH is, nobody has actually measured the CRH in these conditions. So we do not have any direct evidence to show that the CRH goes up in critical illness, and that is why you are having an increase in the ACTH. ACTH levels, on the other hand, initially there is an increase, but later it comes down. And the adrenal cortex, the ACTH is going to act on the adrenal cortex, and there is going to be increase in the cortisol production initially. But later the cortisol levels are maintained more by a decrease in the cortisol metabolism, and there is increase in the free cortisol because the cortisol binding globulin, the albumin levels, they all come down. So there is going to be increased free cortisol to the tissues. So this is what happens. And of course in the ICU, there are also going to be iatrogenic factors. So these patients can be on opioids for pain relief, which can decrease the ACTH as well as the cortisol. These patients sometimes can receive etomidate, which again affects the cortisol metabolism. These patients could be on ketoconazole. Again, that can affect the cortisol metabolism. So there are a lot of iatrogenic factors as well involved in this mechanism. So the newer insights are that there is HPA axis dissociation with low ACTH and high cortisol. The cortisol metabolism reduction may be a contributing factor, and CBG cleavage increases, and there is an increase in the free cortisol levels, and the cortisol distribution volume is altered. So the plasma cortisol that you measure may not really be truly indicative of critical illness, and inflammatory cytokines and adipokines may stimulate the adrenal cortex, because we know it is not the ACTH after some time. So what else is stimulating it? Probably the cytokines and adipokines, and there may be some interference by iatrogenic factors. So this is the history. So we were using 200 to 400 mg of hydrocortisone per day, and approximate equivalent of about 10 to 20 times the substitution or replacement dose. And this is based on the assumption that this equals the daily amount of cortisol from a person with normal HPA axis would produce. So this is to maintain the high plasma cortisol documented in the earlier studies. Then came this particular study, which was in fact one of the studies which gave us a recommendation how to test for corticosteroid insufficiency. So this was a 3-level prognostic classification in septic shock based on cortisol levels and cortisol response to corticotropin. So they found that the probability of survival was lesser when the basal plasma cortisol was more than 34 microgram per DL. And if you look at the ACTH stim test, again if the delta cortisol, before and after the delta cortisol, the probability of survival was lesser if the delta was less than 9. And they combined both this and found that the probability of survival was highest when the basal plasma cortisol level was less than 34, but the delta was more than 9. And the probability of survival was least when the basal plasma cortisol level was more than 34 and the delta increase after an ACTH stim test was less than 9. So this gave us a cutoff for testing for corticosteroid insufficiency in critical illness. But there comes the implementational issues. First is the diagnostic uncertainty and guidelines variability. So the guidelines, what do they say? The critical care medicine, this is the Society for Critical Care Medicine guideline in 2008, where they showed that the random plasma cortisol less than 10 microgram per DL or if the delta, you do a post-stimulation test, and then if the delta cortisol is less than 9 microgram per DL at 60 minutes, then you can label this patient as having critical illness related corticosteroid insufficiency. But this changed in light of newer evidence. This changed, and now the task force of the newer guideline, 2017 was when they updated it, that makes no recommendation of one test over the other. But all the randomized control trials have failed to show a minimal cortisol level below which there is an increased mortality. And there are certain fallacies of this CST or the corticosteroid ACTH stimulation test in this critical illness. The previous study that had shown about the three point, the basal cortisol and the delta. So in that particular study, there was an increased mortality even in those patients who are not on steroids. And the patients with this delta cortisol who have less than 9 had received etomidate in the ICU. So etomidate, even a single dose, can reduce cortisol production for about 48 hours. So when you test, then your delta may not be so high. And another study called as a Corticus study, the results of this CST did not predict the resolution of shock or mortality. So there's still no strong evidence as such for the ACTH stimulation test in this condition. So is it time to move away from that? But we do have certain conditions where you have to do a stimulation test. That is, in patients without septic shock and borderline cortisol values, you're not very sure what is happening, then performing a stimulation test may be reasonable. And there are certain cutoffs. Serum albumin of less than 2.5 gram per deciliter, the cortisol response should be more than 22 microgram per DL. If the serum albumin level is more than 2.5 gram per deciliter, the cortisol level should be more than 15 microgram per DL. But these are just cutoffs based on smaller studies, and these cutoffs will still need prospective validation in bigger cohorts. And in patients with septic shock, resistant to fluids and vasopressors, you can still give a trial of glucocorticoids regardless of the serum cortisol levels. But here, this cannot be assumed. If the patient responds, it cannot be assumed that this patient has critical illness related corticosteroid insufficiency, because as you know, there could be vasopressor effect of glucocorticoid, and that itself would increase the BP. The next implementational issue would be overlapping clinical features. So you know all of these clinical features listed out here, the neuropsychiatric, the lab findings, diagnostic imaging, the musculoskeletal features, fever, weakness, cardiovascular features like tachycardia, hypotension, gastrointestinal features, all of these are common even for sepsis. So how do you know that this patient has corticosteroid insufficiency? There are certain things that you should look out for. One is the electrolyte abnormalities. The hyponatremia and typical hyperkalemia may not be seen because these patients are going to be on multiple fluids. So electrolyte abnormalities may not be forthcoming here. But if you have unexplained hypoglycemia, mild hypercalcemia, and eosinophilia, which is not explained by anything else, then you have to suspect corticosteroid insufficiency in these patients. The other implementational issues would be testing limitations. Now we do not have ICUs may be present in many centers, but round-the-clock cortisol testing, round-the-clock ACTH testing, so those may not be available. And now what tests to do again is an area of contention, because do you want to do the total cortisol or the free cortisol? Because the free cortisol is actually what is going to give you the picture of what's happening. But unfortunately, we do not have any assays as of now for free cortisol in India. And the free cortisol, even in studies, it takes a long turnaround time. So could you calculate free testosterone with the CBG and with an albumin? There is something called as a Coulin's method by which you can calculate, but again it's not going to be giving you a correct picture, because the CBG dynamics, albumin binding dynamics are going to change in critical illness. And even the CBG measurement, again, we do not have the assay as of now in India. So this is the problem with the testing. And the next implementational issue would be lack of awareness. So how many of the ICUs do we regularly test for this condition? So it is an under-recognized problem, in fact, and because of this, there could be delay in the therapy and there could be practice variation as well. And steroid dosing and tapering. So this is a very important concept again, how much to give, when to give, and how long to give steroids. So this is the recommendation by the Critical Care Medicine Society, which says that corticosteroids should not be used in adult patients with sepsis without associated septic shock. So this comes from the findings of this HYPRESS randomized control trial, where they have treated patients with corticosteroids, and they found that there was no significant difference between the hydrocortisone and the placebo groups for time until septic shock or the mortality at 28 days either. And in fact, in the hydrocortisone versus placebo groups, more patients in the hydrocortisone group had secondary infections, they had weaning failure, and they had muscle weakness and hyperglycemia. Hence, in patients with severe sepsis, not in septic shock, steroids are not recommended. So when do we give steroids? So initiate corticosteroid treatment when using doses of norepinephrine or epinephrine of more than or equal to 0.25 microgram per kg per minute for at least 4 hours, and the requirement keeps increasing, then you'll have to maintain the recommended mean arterial pressure, then you'll have to consider steroids. And in clinical practice, hydrocortisone is also used. Sorry, I'm not able to see the slides. Hydrocortisone is also used in patients in septic shock when there is an increasing need for pressure amines, even in the absence of accompanying adrenal insufficiency. So the recommendations here come from these three very important trials: the adrenal trial, the approaches trial, and the corticus trial. So the adrenal trial, the hydrocortisone treatment used in this study did not improve the 90-day survival of patients with septic shock compared to the placebo group. But the hydrocortisone treated group had a more rapid resolution of shock and less frequent requirement for blood transfusion compared to the placebo treated group. The approaches trial again showed that the 90-day mortality was 6% lower in the group of patients who were given steroids and fludrocortisone. Again, there is an evolving concept of critical illness related mineralocorticoid deficiency. So based on that concept, they have given even fludrocortisone. So in contrast, the number of days without mechanical ventilation was similar in both the groups, but hyperglycemia was more in the treatment group. Then came the corticus trial. The treatment did not improve survival, and hydrocortisone treatment did not significantly affect shock reversal, but shock resolved more rapidly in the glucocorticoid treated group than in the placebo group, but there were more superinfections. So why the difference in outcomes? Because the group of patient studies were different in all the trials. The corticus and adrenal trials were less sick than those in the approaches trial who had higher vasopressor requirement. And in both the adrenal as well as the approaches studies, the hydrocortisone which was used was given in different ways. One was a continuous infusion, the other one was an IV bolus. So in general, what we know from all of these studies is that patients in worse general condition, that is higher vasopressor requirements and greater severity of organ failure, they benefit significantly from corticosteroid treatment. How much to give? Again, we have differences in the guidelines as well. So the Society for Critical Care Medicine says give less than 400 mg per day of hydrocortisone and for more than or equal to 3 days at full dose. And the Surviving Sepsis campaign says give 200 mg per day, give 50 mg IV 6th hourly. But what is the contention here? Is it really a deficiency of cortisol? Why do you have to give stress dose of steroids in this condition? Because we know that there is reduced breakdown of cortisol, there is a decrease in the CBG and albumin, there is an increase in the serum free cortisol. So there is an increased negative feedback in fact, because the free cortisol goes and inhibits the pituitary and the hypothalamus, and there is going to be decrease in the ACTH secretion. And there is tissue specific regulation of the GC receptor. So this is not really generalized resistance. So why do we need to give 10 times the normal cortisol production? So now the idea is give a lower dose. A daily dose of 60 mg of hydrocortisone, 40 in the morning and 20 in the evening likely suffices. And higher doses of hydrocortisone in fact may increase the risk of further suppression of the plasma ACTH. So you may not actually let the axis recover. So this is very similar to somebody who's been receiving glucocorticoids for let's say 3 or 4 months who come to us with secondary adrenal insufficiency. The picture is very similar there in somebody who's chronically ill in the ICU. The ACTH levels are low. So in order for it to increase, to sort of recover, we need to not give too much of steroids and suppress it more. So that is the idea behind this. Now let's go back to the case. I have talked about this 56-year-old lady who looked like she already had previous adrenal insufficiency and which was precipitated by a surgery. And we had this case to this patient who was not responding to stress vasopressors. And we had this case 3, patient who was there in the hospital, prolonged hospital stay. So what would you do in this patient? The case 1 is clear-cut primary adrenal insufficiency, there is a clear benefit of steroids and you should give steroids. And then you have the case 2, where this patient is not responding to vasopressors. So you're not sure whether there is adrenal insufficiency or not, and we have conflicting data. So then we have the case 3. So case 3, prolonged illness, likely developed corticosteroid, critical illness related corticosteroid insufficiency. So we should treat this patient. So we'll start with, in the first case, how do you treat? So this is pre-existing disease, does not really come into the category of critical illness related corticosteroid insufficiency. So in this patient, you treat how you treat like a primary adrenal insufficiency. In a patient with the second category, there was acute septic shock which was not responding. So in this patient, there's no point in going a stimulation test because it is flawed and may not be useful in this condition. So you start hydrocortisone 200 mg IV every 24 hours and assess for the hemodynamic and respiratory response. If it is not present, you stop. And the duration of treatment is about 5 to 7 days. And then we have the third category. So that is the category which we should really look out for in patients who are for corticosteroid insufficiency in critical illness. So this is a prolonged critically ill patient. So this is probably this condition, and you look at you give the hydrocortisone 60 mg in 24 hours. So you can give 40 in the morning and 20 in the evening. And after that, we need to taper the hydrocortisone dose as soon as possible after clinical improvement. But the tapering schemes, we do not have much idea, and we need to follow up these patients. The other is implementational issues, monitoring and adverse effects. So we know that when the patient is on steroids, there can be hyperglycemia, there can be superadded infections, there can be myopathy. So we do not have checklists for that. Every institution should have its own protocol and have own checklist when we are giving patients steroids. And special patient groups like in oncology when they go into sepsis, because oncology they can have multiple reasons why they can have adrenal insufficiency. They could have adrenal metastasis, they could have hemorrhage, they could have infections, they could be on immune checkpoint inhibitors. So the multiple reasons, and most of the studies have excluded oncology patients. So we do not have much data on that. And if the patient is on previous steroid use, patient has exogenous Cushing's. Again, we do not have much data on them on how much steroids to give them. So to conclude, it's important to understand the changes occurring during various phases of critical illness. Though we have made progress, there are many unanswered questions and diagnostic challenges still continue. And we still do not know the utility of the ACTH stimulated free cortisol because this assay is not available universally. And there are no real clear cutoffs for treatment decisions as of now. And we should individualize therapy and do not miss late onset adrenal insufficiency in critical illness. Thank you. So that's the hospital I trained in, and this is the place I work in right now. Thank you.
Thank you, ma'am, for wonderful deliberation.
We will take, you can sit here, ma'am. So we'll take the questions at the end of the session. So now I'd like to invite Professor Shriram Mahadevan for his talk on fertility prospects in adult with CYP21A2 deficiency. Sir is professor and head in Department of Endocrinology and Metabolism at Shri Ramchandra Institute of Higher Education and Research, Chennai. So over to you, please.
Thank you. Thanks to the entire ESI team of Kolkata for this opportunity to talk here. May I have the first session by Dr. Beatrice has set the role at least towards adrenal to discuss. Actually, I wanted to learn more, but the discussion will be after this. Okay. Let me put the points which I wanted to discuss on this aspect: fertility prospects in adults with cytochrome 21A2 defect, which is one of the cytochrome P450 enzymes, very important in the steroidogenesis pathway. So one of the very common congenital steroid deficiency conditions in India, for that matter, one of the commonest inherited conditions of steroid deficiency. We will discuss under the following headings. I was surprised to know only today morning that we are given 30 minutes for this talk rather than the usual 20 minutes. So in one way it is good that we will set the basics again, discuss more. I will discuss the fertility issues after going through the basics of congenital adrenal hyperplasia and few points on pregnancy and couple of social issues and other pragmatic issues which we face when we deal with the patient. This is, I'm sure there are a lot of endocrinologists here, so they will be comfortable with this slide. Otherwise, it will be a nightmare for anybody to look at this. I remember my professor in PGI, he used to say, even if in sleep, if I ask you to get up, you have to recite this whole thing. So, and Dr. Bansali used to write these single letter words for all the metabolites. As you can see here, progesterone is written as P and F for hydrocortisone and B for corticosterone, and delta 4, we used to write that, delta 4, delta 5, etc. So, interestingly, each layer of the adrenal cortex, the glomerulosa, the fasciculata and reticularis in that order, as you can see vertically, goes through a series of enzymatic cascade pathway. Interestingly, it is to note that she also showed, Dr. Beatrice also, that the adrenal can synthesize cholesterol on its own in the cortex. It's not from the serum alone, and if at all it is from the serum, it is from the LDL cholesterol, which in the typical CV risk reduction we always say it is bad, but it is a very important cholesterol for the life-saving hormonal production. So from that you get the life-saving two hormones, which are aldosterone and cortisol, and the last one is the steroid androgen, weak androgen, which is common to both the sexes. All these pathways somewhere or the other have been very nicely studied, both and by knockout models as well as human, in general, the errors, the nature's experiment with humans, where we have one odd case which will be there with some deficiency or the other, and all these are very nicely described, what happens to a particular enzymatic defect and how it affects the patient as well as either life or both other presentation in the regarding sex hormones. The focus for today is the most common CAH, which is 21 hydroxylase deficiency, where due to the enzymatic blockade, the whole pathway, the precursors get diverted towards the on the left of the panel, which is the androgen pathway, and due to this excess androgen, a female fetus gets virilized, and due to the absence of aldosterone and cortisol, the child may go into a shock-like state due to loss of fluid and dyselectrolytemia. This is well known, and there is a, depending on how much of this enzyme defect is there, even 1 to 2% of this enzymatic action will lead to no life-threatening problem in the child. Only androgen excess will be there. That's the interesting part of it. So the complete deficiency will lead to definitely a life-threatening situation in a child. That is why all over the world, wherever they are affording, newborn screening is indicated. And even there is a subset, as you can decipher from this. It is that male baby who will have this salt-losing form of CAH who needs to be identified, because the girl baby, you will have an ambiguity of the genitalia, which itself will be a clinical clue for the neonatologist to pick up. So technically speaking, a newborn screening should actually have no clinical clue at birth. That should be only a screening procedure. So from this we will go to the challenge in the management of CAH, in contrast to the previous discussion on simple straight adrenal insufficiency, is here is a problem which not only reduces or there is a deficiency of life-saving hormones, but there is an excess of the life non-saving kind of a sex hormone. So it is the balance between these two we have to make. If it was as simple as replacing the corticosteroid deficiency in a CAH child according to weight or body surface area, etc., which is what we attempt to do, but what happens is the dose at which we are able to replace corticosteroids is usually lower than the dose at which the androgen gets suppressed. So there is always a mild mismatch between the two, to the extent that if you slightly overtreat a child, the child will appear Cushingoid, the axis will get suppressed, your androgens will go low. but if you like to leave it slightly, this will go this way. So this is going to be always that the monkey and the cat kind of a story, where there will be a balance problem, and that is what leads to all the repercussions, long-term adverse consequences, even in a reasonably well-treated child in the long run. Because of the androgen excess, you can know what can happen to a girl at the pubertal period as well as after puberty. So these are all the long-term consequences which we need to remember. This is the main challenge. And how we go about it, what are all the things which have happened in the last several decades, many of us know. We will recapitulate it now. So going as usual with the burden of this problem, this was the major ICMR study which tried to do the newborn screening program in India, finding out the prevalence of this condition. Otherwise, there is no population study to say, only there will be anecdotal large institutes, big institutes, central institutes, etc. They will have their experience published. We have also published from PGI when I was there. Dr. Bansali made us write that paper of several CAH patients we used to get. But this is one such big study, more than 1,30,000 children screened in India from Delhi, Bombay, Chennai, Hyderabad and Goa. And out of which, interestingly, we are in Chennai, we have this dubious distinction of topping in many things. Here also, both in congenital hypothyroidism and in congenital adrenal hyperplasia, which are the two most important endocrine disorders we screen as newborn screening program. We were highest, to the tune of, in contrast to all Western series, 1 in 2000 was the prevalence. And we have follow-up of, so I had the opportunity of not only getting involved in the paper, but in the study, but following those cohort of children who were diagnosed. They are now in their teens now, with all the, there was only one boy we could identify by the screening. But that fellow also salt losing. So we could anyway picked it up 2 weeks later. That's another thing. All others had actually ambiguity. So it was easily picked up in the other cases. Straight away I have to tell you that even in All India Institute Pediatrics Department, out of these 3 true positive cases, the follow-up was not there. They said that, you know what happens sometimes, the other group of community, they take over these children and they were lost to follow-up. There are such issues in many parts of India. This one, the child was lost literally to the group which they take from this. So such things. In Chennai, luckily we don't have that problem. All these children are under regular follow-up. And this was just to tell you that this we published in our, presented in our local conferences. We had around 87 CA children, out of which we had 74 belong to this focus of 21-hydroxylase. 13 were the other children, which we published only last month of the other. So in contrast, even though CAH is the most common, 21-hydroxylase is the most common, we bump into the other rarer causes also. Interestingly, many times the 11-beta and other conditions are not life-threatening because they have hypertension. There also 17-OHP will be high. Screening will give you false positive. Even in the 3-beta 2 cases which we have also, the 21-hydroxylase, the 17-OHP was high. So sometimes, the assays and other things may not help us. We will, if time permits, discuss more on this. So in the spectrum of 21-hydroxylase deficiency, we should again recollect that salt losing and simple virilizing are classified as classic, and the other milder varieties are non-classic based on the magnitude of the severity of enzyme nitric deficiency. As I said, less than 1 to 5% will be usually only that much activity is there. Almost 0 is the classic variety, less than 1%. Even 1 to 5% there will be only NCCH. And of course other spectrum was there. And this is one condition where the genetics is very intriguing, as well as the genotype-phenotype correlation is now getting delineated even more clearly. And there is a clear association of the correct kind of defects which we have in these conditions versus what kind of disorder they can have. And CMC Vellore has done some extraordinary work for the local population, where we have now out of, this is one peculiar gene where they have a pseudo gene also, and it's an autosomal recessive condition we know. So they have identified 8 hot spots. So at a very low cost we can get, if these 8 spots are defective, then you can go for further detailed analysis rather than going in for the whole genome or exome or all the genes. So as you can see here, the patient can present at neonatal period or early toddler kind of a childhood phase, or even at puberty, or even as late as the case which I am going to show now in the next few minutes how late in India they can present, based on the severity of the enzymatic deficiency, and as exemplified in this slide also. So somebody not having the salt losing crisis in the first few weeks to few months of therapy, of birth, they can have early, the sex hormones will be higher, the androgens, so a female will present with heterosexual precocity and a boy will come with precocious puberty. This is the usual way you pick it up, and please always in India and in South India especially, I have to recollect, re-emphasize myself that consanguinity is very common. Don't go by hormonal values. You can have non-21 hydroxylase also, and consanguinity you won't get. So I learnt few finer points of taking history when we went through some of these big discussions on this is, you should ask which village they come from, or are they from the same area of the state. If they are from adjacent or less than 5 to 10 kilometers area, also there could be a possibility of consanguinity in the past, in the previous generations. So unless they are from totally different parts of the India, it's always there. Consanguinity is very common in our place. So I'll start with the fertility discussion with this case. A 32-year-old male coming to us for the first time. Rather, in the initial years he has probably met some doctor, but no treatment taken. He is married and came to us for primary subfertility issue. Initial events were normal, except that clearly he is saying that he started having sexual hair growth at the age of 5 with even voice change around 10. So that means he had precocious puberty. He was shortest in the class by 14, and there is a clear-cut consanguinity. And another boy who died, his brother. So he was very short, less than 150 centimeters for a male, even by our South Indian standards very low, and no gynecomastia. Interestingly, the testicular volume was 15 ml, which immediately you'll say, this is precocious puberty with 15 ml, but you should sometimes, palpation is important. He had a basilated appearance, nodularity in the testis. So I remember again my professor used to ask, precocious puberty with small testis, big testis, bilateral, symmetrical, all these helps. Here it really helped, because the short stature with precocious puberty, bilaterally testis 15 ml is not simple central precocity, is definitely an abnormality in the testis here. So the baseline hormonal levels showed suppressed gonadotropins, high DHEAs, and high testosterone, 17 hydroxyprogesterone. So luckily our assays are again, in India, when everything clinically correlates, we are happy. But if the value had shown me something differently, only, I don't know how would have approached this. Then today, unfortunately, our threshold for sending our whole genome you send off, we will see what comes with it. That we will come to time, but that won't give you the answer. You have to milk your clinical findings and squeeze your brain more to find out what else can explain this. And his potassium was on the lower side, unexplainably, frankly. Because of this, if it was very low and he had significant hypertension, you will be surprised to know that even in 11 beta also the similar values of 17 OHP can come. This doesn't rule out that. But fortunately in this case he is genetically proven fellow. The ultrasound of the testis showed typical space occupying lesions with microcalcifications in the testis, which are clearly suggestive of testicular adrenal rest tumors. So luckily this man is under our follow-up for quite some time, more than a year now. In contrast to what you will routinely read in books or something, we gave him only dexamethasone. We didn't give hydrocortisone. It's costly for this man. He is an auto driver from near Vellore. Hydrocortisone at his weight and doses will go beyond his capacity to. So sometimes we have to use our logic to not just follow what is written. And anyway, I'm not going to save his height or anything now as an adult. So prednisolone or dexamethasone is one, and in TART especially dexamethasone works better because you need a good suppression of the ACTH. So as you can see, we were very lucky in this case. We had 2 more cases in the last 3 years. Both of them we didn't have this response. I am showing you in presentations. Sometimes you should take with a pinch of salt. What I show is the best of what I have experienced rather than the other failures which might have had. So you can see here his LH FSH actually has nearly normalized now, and we are expecting a semen analysis in the next few weeks when on him hopefully it is slowly recovering. Otherwise, most often what would have happened by now, untreated, simple virilizing CAH for 20, 25 years, 30 years, the tart itself would have suppressed you would have caused a compressive effect on the seminiferous tubules. You would have entered into primary testicular failure, which is what happened in the other cases. So luckily this man is improving. This again shows in males also CAH showing significant fertility issues, and that too as the primary complaint even today. So much of window of opportunity to treat him has been missed from early childhood to puberty to only unless they come for fertility. So going through the literature, you see fertility, especially in females, is a very serious issue in CAH. Even in males, even in females, it can cause even sexual dysfunction also. And there can be even intercourse related physical issues because of vaginal stenosis, number of psychological factors. This luckily the adrenal rest tumors are extremely rare in the ovaries. Otherwise, a milder form of non-classic variety of CAH may be sometimes it will overlap, the features will exactly overlap like PCOS, where there will be slightly severe variety of the hyperandrogenemia will be there, but otherwise it will mimic PCOS, and our 17-HB values also will overlap. There is and after hearing Dr. Beatrice talking, I don't know whether I should do ACTH stimulation and all on everybody, at least for these hormones. I'm sure it is going to help us. Why I'm saying this is the PCOS like phenomena, some clinical clue will be again asking good history of consanguinity, sibling death, lean PCOS, early on the hirsutism and hyperandrogenemia, which is more than the irregular cycles and other things. These clues will, if is there, you should think more of NCCH rather than screening everybody. But ultimately, after talking like this also, we end up doing 17-OHP as part of all our screening today, even in routine PCOS. And as I said before, these people rarely can have even sexual orientation issues, and most often in our setting, the implementation issue was the word they used here. I strongly feel, I think from birth till whatever we are discussing, at every step in our setup, especially in Indian typical setup, follow-up, less affording patients, accessibility to care, test, everything you think of in CAH, there will be an implementational problem. Biology is clear. As doctors, we discuss length and breadth, especially as DM residents, but when it comes to application, a lot of issues are there. And let us revise this for rededicating ourselves to better care. In females, there are a lot of studies from the West, but reassuringly, you can see here only 1/4, roughly around 20 to 25% of patients undergo spontaneous fertility. We have had few occasions to see that. We actually admitted a patient for evaluating for fertility, but interestingly, she had missed her cycles, and when we checked, she was already pregnant. This is interesting and very, it was a happy ending on a couple of patients. But just to tell you that it's not as bad as what we think. Let us not, because most of the mothers, when they bring their CAH girls, talk about these issues first, even though salt losing and other things sometimes become secondary in our setup. So normalizing the menstrual functions, following them up correctly, optimizing the steroid therapy, both the corticosteroid and mineralocorticoid, appropriate surgical. This is where we have a problem, especially in Tamil Nadu after all this sexual restructuring surgeries, vaginoplasty may be done, but all these they are now saying that except in a life-threatening situation or anything to do with the genital area, you have to wait till they become adults. This has become the rule now. These are all issues which are slowly coming up in a legal manner. A lot of our pediatric surgeons are hesitating even for straightforward surgery. So I have a couple of times we have told them to go to a state where these rules are not there and get it done and come back. So I think Andhra, Telangana and all, it's not there, I suppose. So such issues are newer ones, not medical but legal. Then comes in males also, as I showed, tart as the most common cause of, otherwise in a male usually NCCH doesn't cause a problem generally. There is no word called hypergonadism, so luckily they are doing well in their sexual functions also. TART requires early identification. I have happened to see a couple of papers in our IJEM also, nicely done ultrasound monitoring. So we should include ultrasound at least yearly or once in 2 years in all our boys who are following up for CAH to look at this, so that you can keep the steroid doses slightly stiffer to prevent that. That is so more of if you want to really have their fertility preserved, start early. Disease starts early. Our treatment and regular follow-up also should be more accurate. Then comes whenever they plan pregnancy, another issue is because this being a genetic disorder, in addition to the success of the spontaneous pregnancy, fertility and the outcome, whether the child will be affected, etc., is always a question asked, and as doctors we have to counsel them in greater detail on this, for which a big class should be taken actually on the possibility of how this is. So autosomal recessive is easy to understand, but the carrying frequency is different, and if you see standard books on genetics which write on topics like this, it is not as simple as 1/4 and 50% which we think of. It is actually 1 in 60. So the child, the probability that a patient with classic CAH will have a child with classic CAH, if you don't know the status of the partner, is somewhere around 1 in 120, which is not zero. I mean, which is not like if she is a sufferer and the other fellow is normal, doesn't mean they will not have. Still, the baseline frequency of this abnormality in the population itself is quite high. Similarly, somebody with NCCAH, whether the partner's status is known or not, they may have a child with even classic CAH. These are all the issues. So the most of the CAH, if you see the genetic reports, it will be a compound heterozygote. That means they are all carrying some mutation in the chromosome 6, the 21 hydroxylase, which is not causing serious issue in them, but which can definitely get reorganized during meiosis, the crossover, and all various combinations will give you this frequency of the affected child. So the pre-pregnancy counseling should include this discussion on the possibility. So the testing of both the partners, at least hormonal, if not genetic, should be done. The problem I am facing, I am sure a lot of our seniors are here, they will also agree, is that if you send off this genetic test, be ready for a confusing report. Variant of unknown significance, we don't know. All this will come. American College of Medical Genetics will tell something. Whether to really tell this fellow you have a problem or not will be in doubt now. So I think we should sparingly, judiciously, whatever that word is, but more restrictedly we should use the genetics in patients with when we deal with this. We should be very careful is what I feel, because sometimes now slowly they will get into legal things now. So the pre-pregnancy counseling on genetics I have already mentioned, and of course optimizing the glucocorticoid therapy to keep the 17-OHP on the 2 to 10 range nanogram per ml and the progesterone level less than 0.6 nanogram per ml. These are all suggested, but based on your assay sensitivity and other things we need to. Of course, in bigger setups where we are fortunate to work in all the tertiary and quaternary kind of setups, you have our reproductive medicine specialist who take over once they are not having any spontaneous ovulation or documented ovulation with this optimization of adrenal therapy. So then comes, and of course there IVF and other things beyond the scope of an average endocrinologist to go into this. So this is a guidance which we use in most of our children. Do not suppress. In younger children, if you suppress below 2, growth will also be affected. At this age of post-pubertal period and fertility period, the more you suppress, axis will get suppressed and spontaneous ovulation will become an issue. So the rough guidance is based on this. The follicular phase progesterone around 0.6 and 17-OHP 4 to 12 is reasonable. Then comes the more interesting issue of somebody who is known CAH. She comes pregnant and she carries a child now, where you don't know whether the child is now another problem. Male or female cannot be checked, and if you cannot do genetics, you should have done implantation. If you have done the implantational genetics, the sex of the child should be known. So personally, I have used on at least some 13-14 patients this 20 microgram per kg in the hope of preventing virilization of a possibility of a female fetus. And there was a time when I was studying DM, the algorithm will say you have to do the sex of the child and see whether if it is a female, you continue or else. Now that's absolutely wrong. Now you have to say genetics. Now you get the report in 2 weeks. So you do the genetics by CVS. Within 2 weeks you get the report. Child is affected. Continue. If not, you stop. This is the general logic we follow. However, there will be a big controversy here whether we should really give dexamethasone, the neurocognitive cochlear issue, etc., can be discussed. Of course, the metabolic problem the mother will face in the era of increased incidence of GDM, obesity, and other things. So we need to keep all these things in mind when we give. But in general, fortunately, most of our patients where we gave, none of them had a virilized female. And antenatal issues with dexamethasone, I am not going further because that will be a rare situation when the topic is only focusing on fertility. And in the era of genetics, I think that will be more relevant. So I have had occasions where prospectively a child diagnosed with CAH, we counsel the parents to undergo genetic testing because it will be useful for the future. And our colleague pediatrician, our colleague pediatric surgeon, they said genetics la no use. No, what is the use? Anyway, your child will going to have the problem. Our own colleagues are sometimes against many things which will sometimes help also. So lot of awareness, education on these issues among our colleagues is first important. Then only we will go for public health education and all. And the mother, you have to monitor for, as I said, hypertension, GDM, weight, and of course serial close monitoring of the ultrasound of the fetus. There is an occasion where we use initially dexamethasone, then if the mother is having CAH, we switch to hydrocortisone or prednisolone because that will be metabolized by the placenta and it will prevent fetal exposure to steroids. And stress management during labor according to usual protocol of increasing these. This is one occasion I think Beatrice will agree, we have to give full dose, no? We need not think about regularizing the dose, reducing the dose. Postpartum, it will quickly come to, after the 4 to 6 weeks, it will come down to the normal requirement, pre-pregnancy requirement, and there is no excuse for not breastfeeding, etc. I don't think these are all issues we need to be worrying, both thyroxine, this and many other agents, including even carbimazole when the child is there. So, few thoughts is what I said. So, should we do genetics in all this? Especially, we are not doing eugenics, euthanics here. When we know that the child will, the percentage of the problem the child will face, should we do in everybody? We had this, just to share one experience, the first child was affected, the mother was counseled, when you go for the second child, you need to do genetics, otherwise you will not know whether the baby will be affected, etc. All these routine counseling by 2 of our genetic people, etc. were done, but still she came to us pregnant, and she was planned for chorionic villus sampling, which till the day she underwent the CVS, she was not revealing that, then she said after doing and the genetics was sent, she said, anyway, even if affected, I will have the child, anyway I will treat, anyway you are there to treat in town. So that was, through a trust, we arranged the CVS, at a low cost, etc. Oh, in spite of 30 minutes, I am exceeding, sorry. So there are a lot of, I said, the legal issues which I sent, so we should counsel them in low cost setting, we should be very clear, genetics, how much is going to help, rather than hopping on this thing. So we had one more IIT Hyderabad PhD student who worked with us, where we did this ethnography was a new term I learnt, where they did a detailed interview, not like the questionnaire based graded interview. This is like talking their experience, and they will share in their own words, they will write in the literature. I am thankful to our IJM editors who agreed to publish such a non-conventional paper in our IJM, where as you can see here, CAH is one sensitive topic where culture, background, leave alone economics, everything matters. It's not just science and that memorizing that chart and giving steroids. So lot of issues are there, more than what I am describing here. So in summary, last 30 seconds, 21 hydroxylase deficiency carrier state is, then the polymorphisms are very common all over the world, especially in the regions where the communities have consanguinity even existing today, typical exemplified by South India by the prevalence also. And NCCH is not as rare. In fact, you will be seeing 1 or 2, we will be missing only. A day should come when we can be very confident of our genetics that will help us confirm this. And needless to say to this audience that CAH is one condition where early diagnosis, maybe by newborn screening or at least the clinical diagnosis, if made, the lot of counseling education will go in a long way to prevent all the long-term consequences, because it's a lifelong therapy. Adequate steroid and adequate dosing till the growth and puberty is completed is absolutely important. Then only this whole topic of fertility and other things will be relatively easier to go through. Thank you very much for your kind attention, and I'll be happy to take your questions.
Now the session is open for Q&A.
I have few questions to actually Beatrice. Oh, sorry.
No, you can. Thank you, sir. Thank you, Dr. Beatrice. Sir, you very nicely talked about consanguinity, history not being there. So, if we find a homozygous mutation in setting of an autosomal recessive disease, does that always give away a possibility of consanguinity being there, despite parents not agreeing to it? Because we recently found a GHRH receptor mutation, which is an autosomal recessive disorder, and the child came up with a homozygous mutation. As you said, when we inquired, the parents denied consanguinity.
Did you do the genetic testing of the parents?
They actually didn't agree for it.
Yes.
But
last night, I'm sorry that I cannot share the whole thing. Last night the same thing was discussed in our room when we were chatting on 2-3 CAH mothers, I mean the mother of the CAH babies whom I happened to see, they refused for genetic testing. I will tell as parliamentarily as possible, because the child was born to not the official husband.
Okay, but as you said, when we went back with the history, they belong to a very close area. They came from Tikamgarh area in near Bhopal, and they were from the very adjoining villages. So a homozygous mutation, does that tell us that they must have a common ancestor?
Absolutely, fully correct.
Yeah. Sir, one more question, if you may allow. In your protocol of antenatal dexamethasone treatment, you would do a CVS, and then based on the genetics, if the child is affected, you would continue treatment, regardless of whether the baby is male or female, because in our country we cannot do a sex.
I'll tell you what I did in 2-3 patients. Even though it was not, you cannot reveal to the parents, again it's in a common forum, but unofficially I will know. So I knew in 3 patients that it was a boy, and I stopped actually, but I didn't. They will know. They will do the karyotyping also. The CVS is not just for checking the gene. They will know there is a male or female. Only thing is they won't give an official report. And because we didn't want to expose the patient, so unofficially I did, and we stopped it on 3 boys. That is.
And sir, how do you go about it? They say that
in an affected boy. Sorry. Yeah, so fortunately they were of that community or that level of education that when you stop, sometimes they are happy rather than asking more on why you are stopping. Unless they have gone through ChatGPT and they ask me more, I was at an advantage.
Thank you, sir.
Thanks, Alpesh. That was really interesting. Beatrice, see, the issue is sorry, sir.
I attended a session by Dr. Maria New, who is an authority on CH, and she herself is ex-Kinji Jew, and that CH is very common in
very common.
Her opinion was that if you go by biochemical testing, you will be missing 30% of cases. So always go for genetic testing if it is available. So that goes against your...
We are all transitioning towards that properly.
Second, ma'am, yes, can you elaborate when to suspect water outflow syndrome and how to manage?
Sorry, I didn't.
Bilateral adrenal hemorrhage in septic shock and how to manage?
That is, again, they are going to present with, hypotension, which is not going to respond to vasopressors. This will not be very different from critical illness related corticosteroid insufficiency. They are going to present with shock, but here it will be more of an imaging finding. So when you have suspicion, when you have certain infections, when you have patients on anticoagulants or whatever other reasons where you could have adrenal hemorrhage, you should actually do an ultrasound or bigger imaging and find out if there is any adrenal hemorrhage.
Rampant use of CT scans for various reasons in our sick patients, no? They pick up all this speck of hemorrhage, unilateral, bilateral. We are having a problem now with 2-3 pages. But we err on the safer side, thinking, after listening to Beatrice, I'm getting confused now. We said you anyway give hydrocort, because we don't know whether the other side had, and we cannot repeat the imaging.
So
now,
that
I want to ask another 2 questions. Is that DHEAS and all has no role in this?
They have not studied, sir.
And in the Anane study, that's a famous one, during my MD days, it was talked in a big way. Why did they use fludrocortisone? This was our doubt. Because hydrocortisone, when given at 50 milligram 6th hourly, more than 150 milligram dose usually has mineralocorticoid, is what we teach.
Mineralocorticoid effect, yes. That was because of the concept. They said there could be mineralocorticoid insufficiency also, and then they had given a trial, in fact, and they found that there was some improvement.
Sorry, sir? Yeah. Like Sirki,
yes.
you had Sirki.
Yes. Sirmi, yes.
Incidentally picked up and the patient is stable, about to be discharged, and on that day they call us for our own opinion is different. But when the patient is sick, obviously I have to err on this side. And with all the fallacies, checking one cortisol randomly, all problems.
That is actually the issue that we wanted to highlight here. So it is not just one random cortisol which is going to tell you whether this patient has it or not. And in fact, when they have prolonged illness, there is a higher likelihood of them developing this corticosteroid insufficiency. So it is just not one value, but we need to follow up and also clinically correlate.
Less than 10, could you hear me?
Yes,
yeah.
I can.
Yeah, if it's less than 10, then we'll go for, if the patient is on chronic illness, then we'll just start off with 40 to 60 milligram. This is the message we'll carry home.
So firstly, the clinical features are which is most important.
Yeah.
If somebody has septic shock, and
No, let's
say
I'm not talking about septic shock. Septic shock
Okay.
will give for 50 milligrams XL. I'm only talking about the critical illness related.
Yes, according to guidelines, yes. If you have a random cortisol of less than 10, yes, you can err on the side of over treating and then assess the hemodynamic response and see if there is any improvement in the clinical condition of the patient. Otherwise, that's what they say. You need to have set clinical points on which you are going to monitor this patient and then figure out whether this steroid is actually working or not. If there is no improvement, let's say 3 to 4 days.
Yeah, so say the patient is admitted for 1 month and then we are seeing that there is not very well, the patient is unwell, not having proper improvement in overall features, the general condition. So in that case, we'll
yes, if the random cortisol is less, especially in that condition, because
Yeah.
it's a prolonged illness,
Yeah.
and yes, the ACTH will be suppressed, and your random cortisol, if it's less than 10, there you should err on the side of overtreatment and give.
And then we'll gradually taper it off.
Yes, but you should assess the response for about 3 to 5 days. When you see that there is no much improvement,
Yeah.
clinical improvement, there is
Then
no
we-
point in continuing because you will add to the complications.
Okay, thank you.
One small point to be added, because the usual situation where we get confused is in the same place, the abuse of steroids in our peripheries and all is so common that everybody who has a lower cortisol value, we are more worried about whether they took some steroids. So that's the problem. So in a very abrupt we won't stop. Yes.
In ARDS, it is recommended. Just like lung infections coming. Okay. Okay. Yes. Yes. So if you have a clear clinical history, yes. Otherwise, it's very difficult to differentiate.
you suspect an ovarian adrenal breast tumor and how you diagnose? You are usually imaging not diagnose these conditions.
I have not seen a patient of ovarian, but testis is very easy. Ultrasound will pick up. This also imaging should do. On clue is when she has 7, we expect LHFSS to be suppressed. But if it is high, then I should know why a CAH lady will have LHFSS. So definitely the ovary is there. I think you should do a good imaging.
Shriram, I got to her also. I have a patient who is confirmed case of Addison's disease. This is out of this different. Patient put on hydrocortisone and fludrocortisone. She goes to repeated hypokalemia. 3 times admitted with a potassium of very low. Reduce the dose of fludrocortisone even to half tablet, still she goes. How do we manage? Only with hydrocortisone? That's what we did, and she is stable, because we say if you don't give fludrocortisone in a classic patient of Addison's disease, it should not be done. But if we give, the patient goes to hypokalemia.
See, fludrocortisone is a very long-acting preparation. So in fact, in those type of patients, you can give twice a week, thrice a week. That's also fine. So we have had one APS. You name the complications, everything she had. So that is how we learned all this fine tunings of that.
Sir, I had a patient recently. She, 1982, she got All India Institute Delhi. She operated for Cushing. That time full-blown whatever features, they couldn't, I don't know what imaging they did at that time, maybe CT scan. She did bilateral adrenalectomy done. She's now, after 40 years, she's only on prednisolone once a day. She's doing very well. Prednisolone 5 milligram regularly, but every 3-4 years she's following. 40 years now she's doing very well without bilateral adrenalectomy patients.
A lot of Addison's patients
don't
are
know
on
where
prednisolone, they are not on fludrocortisone. They are doing well for a long time. We don't want to change it because they are stable, they are all right, 30 years, 35 years. Why should we change it suddenly? Although the teaching is we should give hydrocortisone as on today with fludrocortisone. That is the
minimum adrenal rest, something was there, it is functioning, I don't know.
No, in fact, see, what happens is you are giving fludrocortisone, the short half-life. There are periods where there is no action, and that's the reason the problems start. Better to give prednisolone, especially the persons who can't afford, they actually do very well.
One way to explain it would be the receptor polymorphism, sir. There will be some genetic polymorphism in the receptor, and the sensitivity may be different in different patients. That is also one of the actually reasons which is cited for how they respond differently in patients when we give hydrocortisone even in critical illness.
Even the other patients of CAH, when you give hydrocortisone itself, even 3 doses, the SATH may not be full suppressed and still the testosterone is high. And if we start increasing, they develop Cushing sort of a patient. A small dose of prednisolone in the night along with hydrocortisone during daytime, I found in some of my patients they are better controlled. They are much better, even 17 OHP is better, everything is better.
Basal bolus. Basal bolus kind.
Actually, we started that because I remember Dr. Richard Hawkes telling that. We used it in 2-3 of our patients, but their height started coming down. They were not growing and we had to stop it. At least 3 patients, I remember, were not getting controlled. We started this, we stopped it after say 6 or 9 months because they started becoming short. They were not very small dose, 1/4 of 5 mg. In fact, we used to tell our pharmacy to make that 1 milligrams also. So they used to give those powders to them and they were not growing.
There is one author from the Imperial College of London.
Dr. Karim.
Karim Mira.
Karim Mira.
His work is on, why give hydrocortisone, which is costly, give smaller, the equivalent doses of prednisol. Because hydrocortisone you have to give 3 times a day, the patient may not take it well. So 3/4 tablet, even in UK they don't have, they have only 5 milligrams. So they break it into half to half, give 3/4 in the morning, quarter. That works like a chronocortimary. You don't need to use this extended release and modified release hydrocortisone. Can give
Syrup
prednisol.
is available. Yeah, here.
Low cost timed release.
Oh, is it? Huh? Okay. Then we can make it still lesser.
If there is no questions, I conclude the session. Thank you for the speaker.
Thank you, sir, for this interactive session. Now we will have final quiz in this hall. and rest can go to other halls also.
Check, 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 check. Hello, check. Hello, check, 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 check. Hello, check. Hello, check, check. Hello, check. Hello, check 1, 2. Hello, check. Hello, check. Check 1. Hello, check, check, check. Hello, check. Hello, check, check, check. Hello, check. Hello, check, check 1. Hello, check. Hello, check, check 1, 2. Hello, check, check 1. Hello. Hello, check. Hello, check, check, check. 1, 2. Hello, check. Hello, hello, check 1. Hello, check, check 2. Hello, check, check 1. Hello, check, check 2. Hello, check 1, 2. Hello, check. Hello, check.
Please come here. We'll get all of them together first. Second team, next team बुला लो. नहीं नहीं यहाँ पे तीन teams थोड़ा साइड कर दो. Just keep some gap between the. Just separate the three chairs. These sofa है ना, separate कर दो.
Could you please close the doors?
Which year did you win? 2017. Two-member team. या जाओ ऊपर आ जाओ तुम भी आ जाओ So now can we have the introductions please?
I am Dr. Lavina Patnaik from UCMS Delhi.
Dr. Ankitesh Kumar from UCMS Delhi.
Dr. Simran Thakkar from Indraprastha Apollo Delhi.
Okay.
Dr. Benjamin from PGIMR Chandigarh. Dr. Vivek Jha from PGIMR Chandigarh.
Dr. Karthik Nalam from PGI Chandigarh.
Archana Rao from KM. Anuj from KM. Aditya from KM.
Triple A with capital A, your professor.
Dr. Amok from KIMS Bhubaneswar.
We'll go this way. 1, 2, 3. That will be team 4.
Dr. Manjunath from Jipmer.
Dr. Anita from Jipmer.
Okay, Mukesh from Jipmer.
1, 2, 3. That will be 4. You'll be 5. You.
Dr. Ajit Jagtap from Sahyadri, Pune.
Dr. Jagrati from Kokilabin, Mumbai.
Dr. Maitri Doshi from TNMC, Mumbai.
Dr. Sneha from Osmania.
Sai Subramanian from Usmania.
Mahin from Usmania.
Dr. Amok from KIMS Bhubaneswar. Dr. Shinam from KIMS Bhubaneswar. Dr. Shamli from SCB Cuttack.
Telugu Titans. Balaya fans.
Dr. Sandeep from Andhra Medical College.
Dr. Sivaram Krishna from AMC, sir. Bhargav from Andhra Medical College.
Dr. Milan, Goa Medical College.
Dr. Arundhati Das from IPGMR, Kolkata.
Dr. Fahad from Goa Medical College.
Fine. So you got all the 90. So basically what we are going to have here is we will have 4 rounds. So this will not be, don't blame me for this quiz being very tough. It is not very tough. And there are also not a lot of core. I am not torturing you up by putting up a lot of visual questions and all of this. This will be some amount of subject and some amount of core endocrine, some amount of some entertaining topics which are usually not touched upon in our day-to-day studies. And we'll have one round. We'll have the first round is the general round. The second, third are surprises, and the fourth one will be what is called as a frenemy round, where we'll have slips. Somebody please make those slips.
Slips.
Slips, 9 slips with 1, 2, 3, 4, 5, 6, 7, 8, 9 written on them.
Excuse me.
Here what's going to happen is, each person will come up and pick a slip. The person who gets slip 1 gets to choose first. He will choose one particular team which he doesn't like, and he'll give them a topic. We have a list of 9 topics. He'll give one topic, allot one topic to the team. So this is your way of ensuring that your opponent does not win. After one, the person who gets the team will get to pick a team which has not yet been picked and a topic which has not yet been picked. That way it goes on. If you are really unlucky, you will be the one who is picked first. If you are lucky, you will get a very easy question. It's all an entire game of chance. And all the questions, direct questions and both past questions will have 10 points. This is on a system which is known as infinite bounds. That means team 1 gets the first question. They answer it, the next question goes to team 2. Team 2 doesn't answer the next question, goes all around, and if team 7 answers the next question, team 8 will get the question after that. Suppose if a question has gone all around the place, suppose team 2 gets a direct question, nobody answers it, then the next question also will go to team 2. Because since no team has answered this question, it is again going to bounce back to team 2. There will be part points and that will be at the discretion of the quiz master. Okay, and no prompting from your friends. So shall we start? First one to team 1, and this is again from Williams. Don't tell me that I've started with an atypical question. This is from Williams. The general one. Which sweetener sugar used extensively in meal replacement, powders and some drinks increases nephrolithiasis? Naya hai? Display? Display naya hai? Screen. Display.
Anyways, I'll repeat the question. Which sweetener or sugar used extensively in meal replacement powders and some drinks increases nephrolithiasis, and what is the rationale?
You have 10 seconds for this. If you read the often not read topic of renal stones in Williams, you'll get it. Even when we were students, we never read that. Finished?
I think sucralose.
Next.
Team 2.
Team 3. Team 4. Team 5. Team 6. Team 7.
Stevia.
Team 8. Team 9. Audience. Look at the question carefully. What did I say? I never said artificial sweetener. I said which sweetener sugar. Can anybody answer about the rationale for that anyway? Okay, forget about the sweetener. Do you have any clue as to the rationale? How does it work? Team 1. We'll pass it on again to team 1. 2. 3. You said something? Use the mic.
Use the mic.
Decreasing absorption of oxalate from intestine.
3. You have to be quick. 4.
How?
Huh? No, what is the rationale for that? I'll give 5 points to team 4. The answer is fructose, increased uric acid leading to uric acid and mixed ones. I told you very clearly, sweetener or sugar. If you actually look at labels of many of the popular meal replacement powders, you will see that fructose is a part. And that is why with most of these nutritive supplements, blood glucose levels go up because fructose is converted to glucose. Question to team 5, because 4 has answered partly, 5 marks to team 4, which is Jipmer. Jipmer team, and we have a direct question to team 5. This is an AI-based face model, which was first published in 2020. This face model is used to identify which disorder. You don't have to go through a large number of cumbersome tests. Look at their face and diagnose the disorder, is what the imputed mechanism was. Very common disorder which we see very commonly in medical colleges.
Turner's.
Plus 10 to team Usmania. It's CH, congenital adrenal hyperplasia. Usmania. 10 marks. Direct question to team 7. 7 is? Good. Define a resistant prolactinoma. I'll be a bit lenient with this. There are 3 criteria for this. You have to tell me 3. Depending on that, I'll tell you how many marks you will get.
If there is a less than 25% reduction in the size of the tumor after 3 months of carbocolin therapy in optimum doses.
You'll have to be a bit more specific.
2 milligram per week. With that dose, if there is a less than 25% decrease in the size of the tumor after 3 months of therapy.
Team 7, the next team. I'll do one thing. I'll split it between team 6 and team 7 and team 8. There is some controversy. There's been an initial recommendation and that has been modified. Now it is up to 2 mg per week, but some of the newer guidelines are recommending 3.5 to 3.7. The currently accepted one is 3.5. 50%. Initially it was 25%. Later that has been adjusted to 50%. And 3 to 6 months of an adequate. Adequate in the sense the maximum tolerated dose. It is not 3 months, it is 3 to 6 months. So you are partly right. Your team?
7.
That was team 8.
Team 7. 5, team 8, 5. Direct question to team 9. Which new once daily non-peptide GLP-1 agonist has been submitted for approval to US FDA for weight loss? And what is the approximate weight loss in phase 3 trials? That is your question, right? Huh. Mike.
Phase 3 trials have showed an average weight loss of
Approximate weight loss of how much? Team 1?
15%.
Team 2? Mike? You should be louder.
12 to 14%.
Okay, I'll do one thing. I will give 5 points to team 9, 5 points to team 3. Team 9 and this is 3, right?
3.
12 to 13% mean weight loss and it's orforglipron. Next direct question to team 4. What is the mode of transmission of familial male limited precocious puberty? Exact mode, I want the exact definition. And the gene involved is?
X-linked dominant, sir.
And the gene involved is?
LH receptor.
LHCGR.
Team 5?
LHCG receptor.
Team 6? Team 7, I want an exact answer. You give your mic to them. Mic.
Please speak into the mic.
Give them the mic.
The mode of inheritance is autosomal dominant and the receptor is LHCG receptor.
Team 8? Team 9? Team 1?
Sir, X-linked dominant with variable penetrance.
Team 3? It was a direct question to?
Autosomal.
4.
What's your final answer about mode of transmission?
Autosomal dominant gain of function in LHCG.
Audience, exact answer about the mode of transmission.
Can we have some mics for the audience, please?
Dominant negative.
Who answered LHCGR? Team 5 answered LHCGR. Plus 4 to team 5. Autosomal dominant plus 2 points to Usmania. Exact mode of mechanism. Autosomal dominant with male limited expression. You are all talking about X-linked. It was not X-linked. It is autosomal dominant male limited. Because LHCGR mutation does not affect the female. The exact mechanism even in OMIM is autosomal dominant male limited. So direct question to this team, the team after Usmania, because Usmania got two. Among these conditions, which is these 4 medicines, which is the odd one out? For one particular reason, this is an odd one out. And in which condition are they used? Condition or conditions are they used, and which of the following is an odd one out? The rest all share a particular characteristic. The 4th one doesn't share that. Some characteristic, some distinction, something. Please close the door.
Please close the door.
Either come in or close the door. Another 5 seconds.
Sir, all the 4 are used in CH. Green subfont is a, all rest of the 3 are modified release preparations, and Green subfont is a antagonist.
Team 8.
Sir, all of 4 of them are used in CAH, but F mode we are not sure.
Team 9.
Equivalent.
Why do you say so?
Sir? So all of the three. Sir, all of the four are used in CH. Sir, the first three is pituitary directed and the...
No.
Oh.
Team 1. She's right. She's given you a clue. 4 is the odd one out. Why? Why is the answer? It's a very simple answer. Some distinction the three of them share, which has not yet been conferred on 4. Team 2. Team 3. Team 4. 5. 6. Audience.
Anyone?
I said all three have a distinction which has not yet been confirmed on 4. It should be very obvious. 4 has not
See,
yet
is
got that.
it is not still approved?
Yes, that is the answer. It is not FDA approved yet.
Yes.
But now, not now. So +2 to you and +5 to this team. Direct 7. Direct question to team 1. Initially they were approved for adrenal insufficiency. Now all of them have been approved for CH also. Why are neonates uniquely susceptible to iodine-induced hypothyroidism after exposure to antiseptics or maternal contrast media? Classically antiseptics, because when I was an MD Ped student, we used to use a huge amount of povidone iodine in this. So why are they susceptible? We faced this problem during our MD days.
Sir, they don't have iodine escape.
+10 to team 1. Fully developed escape from Wolff-Chaikoff effect. So they have a prolonged period of hypothyroidism. You have to be careful with iodine. My neonatology professor always used to tell us, wash your hands, don't touch them with povidone. Direct question to team 2. Which substance, commonly added to infant formula in China in 2008 due to its high nitrogen content, led to a sudden increase of a hitherto unknown complication in infants? This substance is a known constituent of plastics, especially crockery. It used to be used very extensively a few years ago. Even in fact, Tupperware was entirely built on this particular substance. So what is this particular substance? I'm sure all of you have heard of its name. And why was it added to infant formula? The clue is in the increased nitrogen content. So what did the increased nitrogen content because of that particular contaminant do? Which helped the companies which made infant formula. This is again from Williams. Pass to team 3.
Urea.
Team 4.
Benzoids.
Urea does help things grow, but not children. Team 4.
Melamine.
And why was it added? That is the easier part. Melamine is the tougher part. You don't have an answer? +5 to Jipmer. 5. Pass. Team 5. Why was it added? Team 6. Not sweetener. Team 7. Team 8.
Protein content, to increase protein content.
That is right. +5. It spuriously showed that the infant formula had more protein content. So +5 to Jipmer, +5 to team 8. Telugu Titans. We'll go to the second round. That again, the direct question goes to team 9 in this. Like I said, this was a surprise round, right? This is what is called as a myths round. We'll be dealing with common myths. Nowadays, everybody in this room, I think, is sick of social media, Instagram, and all the myths which are shown on social media and Instagram, right? So we'll have a brief introduction and exploration of all these common myths which are bombarding us every day. The first question to Team 9. One of the commonest myths in sports and well-being, this is one of the commonest ones, which owes its origin to the Tokyo Olympics. Just before the Olympics, one company marketed something that was known as manpoke. A particular device which was called manpoke. The Japanese characters, look at the kanji characters, especially the 1, 2, 3, 4. The first one, the Japanese characters resembled a person doing something, and the literal translation of manpoke means something, which resembles the first character. And this has evolved into the current myth, and it has now become commonly prevalent everywhere. You can't spend a day without hearing about this. What is that? Which is the biggest headache in medicine. Biggest, not just in endocrinology, medicine, fitness, well-being. The stupidest concept which has come around. Do you have a pointer on this?
Do you have a pointer?
Arey God, it works, sorry. We'll scrap it. Did anybody get it? Did anybody get it? That was one of the best ones in the quiz. So how does the pointer work? Doesn't work, right? This doesn't work? You don't have a pointer? Laser pointer nahi hai? यहाँ पे यहाँ से करो. Look at this. You should have looked at this. Pedometer. Manpoke was a pedometer. That literally meant 10,000 steps. And then everybody started using it after the Tokyo Olympics, and we had this concept of 10. There is no rule that which says that 10,000 steps are necessary for you. It can be 7,000 for some people, it can be 13,000 for some people. But is it not the commonest myth told to us on social media? So the next question again goes to Team 9. This was first mentioned in 1970s. This is again widely used in gyms. First mentioned in 1970s by Fox and Haskell in a conference proceeding. This was not based on rigorous research like our Grulich pile charts. Rather, it was a rough overage from collated small studies, and there has been no formal peer-reviewed validation. But it was catchy and easy to remember, and it has been adopted by the American Heart Association on all people everywhere, including gyms. What? Cardiologists swear by this. What myth?
Direct question to team.
Red wine.
Which one?
Wine.
Not
Moderate
wine. Gyms don't give you red wine.
Don't give wine.
Team 1. Then everybody would be going to a gym. The common complaint in a gym is nobody comes. Team 1. Team 2.
Omega fatty acids.
Team 3. Team 4. That is not a myth. That has a basis.
Whey protein.
Team 5. We need a more precise answer. You are in the ballpark, it's like calling a lion an animal. We need a more specific answer. That's something with, it's not a supplement, it's something to do with calibration or some particular measure of something.
Heart rate should go above 100 for some particular time.
Team 6. More precise answer and use the mic.
Heart rate should go on.
We'll give +10 to Usmania. This is the myth. Maximum heart rate is 220 minus age. There is no basis for this. I'm sure you are told this again, right? That again doesn't have a basis. Question to Team 7. During the Industrial Revolution in the 19th century, labor rights activists popularized this slogan. Look at the number of blanks. This again has significant importance. Something, space, and again 5 dashes. 1 dash, space, 5 dashes. dash, dash, dash. This led to which common myth? It's a very easy answer.
8, 8 and 8.
Of what?
8 hours of work, 8 hours of recreation and 8 hours of rest.
8 hours of?
Rest.
Team 8?
8 hours of work, 8 hours of recreation, 8 hours of rest.
Team 9? That was what they said.
You repeated what the
Team 9?
8 hours of sleep.
That is right. We'll give 7 to them, 7 to team 7 and 3 marks to team 9. 8 hours of sleep. Again, you heard this myth, right? Everybody says 8 hours of sleep. In fact, a large number of RCTs have shown that some people, if they sleep for 8 hours, they'll actually end up with more CVD stress. Some people require 7 to 6. Some people will require even up to 9 hours of sleep. Varies from person to person. There is no single size fits all. The genesis for that is this, 8 hours of sleep. Direct question to team 1, 9. Direct question to team 1. The earliest formal scientific call, this is again one of the biggest myths in endocrinology and the most irritating myth for any practicing endocrinologist. The earliest formal scientific call was by E.B. Astwood, who published on dash foods and compounds in endocrinology. Later it was taken up by health enthusiasts and turned into a revolution. What? I'm sure after you listen to the answer, you'll agree that this is the single biggest myth in endocrinology. Team 1? Shall I pass it on?
Educated guess.
Keto.
Team 2? Team 3?
Increasing sweet intake leads to diabetes.
Team 4? The biggest myth, you are missing it out. Team 5? Or it's probably because you also believe this myth. Team
Whey
5?
protein.
Team 6? Team 7? Team 8?
Low carb, high protein food.
Team 9? Huh? Audience? You're not reading. Dash foods and compounds. Is that the commonest myth? What does every patient with hypothyroidism ask you? Cabbage and cauliflower. Is it not the commonest myth? There are people who have stopped eating cabbage and cauliflower and even potato for decades together, right? So again, a direct question to team 1. This myth originated from Ayurveda and folk medicine, reinforced by small observational reports in the early 20th century. Scientifically, this particular substance contains soluble fiber and 5-hydroxyisoleucine, which modestly reduce glucose and HbA1c. However, effects are limited and it cannot cure diabetes, but it has become the gold standard treatment for diabetes. So what is this particular substance?
It has become a gold standard in Ayurveda, sir.
No, it has become gold standard for everybody. If they use this, they won't need us.
Bitter gourd, Karela.
No.
Soluble fiber and 4-hydroxyisoleucine in Karela.
The second question. Team 2. Karela is anti-homeopathy. Homeopathy is like cures, like. This is a different thing cures like. That is Karela theory. Team 3. Methi fenugreek. Plus 10 to team 3. Methi is much more popular than coriander for thyroid and methi for diabetes. Direct to team 4. This phrase originated as a public health slogan in the 2010s to highlight the risks of sedentary lifestyle. Scientific evidence partially endorses its role in the increased risk of diabetes and CVD, but not to the extent to which it is touted. What is this slogan? I'm sure you have heard this everywhere, including conferences. Do you want a clue, or does anybody know the answer? You want a clue? You know the answer? No answer? Shall I pass it on?
The new smoking.
Hmm?
Sitting is new smoking.
Can you be louder?
Sitting is the new smoking.
That is the answer. Sitting is the new smoking. +10 to Team Jipmer. 4. Round 3, we will have the controversies round. Direct question to Team 5. In early 2024, if you have been reading the Endocrine Society newsletter, you will have the answer because I put it in the quiz last month. I wanted to know how many people have actually read the newsletter. In early 2024, tennis world number 1 Yannick Sinner twice tested positive for trace amounts of clostebol. His team attributed this to contamination from an over-the-counter spray. What was the outcome and why did this case become controversial? No, what did he actually explain? I'll put it easier. He gave them an explanation, which I'm sure even a 5-year-old won't believe, but the sports agencies and ATA believed it. So what was the explanation he gave and what was the punishment he got for testing positive for this banned clostebol? If you watch tennis, you must have noticed that Sinner was in a huge amount of controversy and he made a comeback later. You don't have to be very specific, but it's a very funny explanation.
The spray was used for allergic rhinitis.
For Anish Dhira, pass it on. And what was the outcome? Like what happened to this man? Mohan. नहीं नहीं अनिश मोहन को बोल देता हूँ. You just. Anish का भी. Next. No, you have to be louder. No, it was doping. But what was the punishment given to him and what was his explanation? Was he punished? Was he not punished? And what was the very fanciful explanation he gave people? Team 7? To answer this question, you should have read this report because that is a crazy explanation. Team 8.
Yeah, knee pain, elbow pain.
Team 9. It's a lot more funnier than that.
Travel all over the body after.
And nobody is giving me an answer about was he punished or was he not and what was the punishment given to him.
Not punished.
9. What punishment and what was the explanation?
So not punished.
Explanation. Team 1.
So somebody else was using it in his
Wife, bed
I mean, you have to give in a very elaborate manner. It's not all that simple. Team 1. You should have read the news report. Otherwise, you won't get it.
Sir, antiperspirant spray.
No, not so simple. And punishment? What? Just guess something. No answer. Team 2?
He was using it for ED.
For?
ED.
Uh-huh.
Erectile dysfunction.
No, not that funny. That would have been a more sensible explanation. And what was, did he get a punishment for that? Or you think he's already being punished enough? Next, Team 3.
Came from his massage therapist's hand. He was cleared by jury first, and then after 6 months, Bada banned him for 3 months just in time before the game.
We'll give +10, he's close enough. And that's, the explanation is even more elaborate. We'll give +10 to Team 3, it was an excellent answer. He said that his fitness trainer purchased a spray over the counter which was given to the player's physiotherapist, Giacomo Naldi, to treat a minor cut on the physio's finger. He regularly massaged Sinner during the Indian Wells tournament without wearing gloves. This is part 1. The part 2 is even funnier. And because Skinner had various skin lesions on his body due to psoriaform dermatitis, the spray must have passed from his hands to Sinner and caused the inadvertent contamination. This is a bigger story than what we used to tell our HODs when we were students.
This is literally kuch bhi.
Anything. And the funny part was, Vada accepted this. But a really good answer. Like I said, you have to read this. If you you will not get such an elaborate explanation by guessing. You need to read the article. Question to team 4. At the 1976 Montreal Olympics, Princess Anne was uniquely exempted from one mandatory test to which all the other athletes are generally subjected. What was the test? She was participating in dressage, which was an equestrian event. Everybody else, because she was the daughter of the ruling head of state of Canada, because Montreal was in Canada and that is still a British protectorate. She was exempted from one test, which every athlete has to go through in Olympics. She is the only person in history who's never gone through the test in modern Olympics.
Dope test, sir.
Not dope test. Something more basic. A rough guess also will give you the answer. Team 2.
If our participants
Pass.
are aware
Pass.
what Princess Anne actually participates in the Olympics.
She won a silver medal in equestrian. Silver, she won a gold. Her daughter won a silver.
Weight or genital examination?
Can you be specific?
Genital examination.
Okay, I'll give it to team 6 because they were in the ballpark figure. They generally have a sex determination. Everybody has a sex determination by karyotyping or bar body. She was the only one exempt from that. Prior to karyotyping becoming widely available, they were actually subjected to strip search. So the genitalia part was right, but by 70s, you would actually come to karyotyping and bar body examination. So plus 10 to Usmania. 10. Question to team 7. Which hormone is nicknamed as the forbidden gold medal hormone? Not testosterone. Team 7, team 8.
Growth hormone.
Plus 10 to team 8. It is growth hormone.
Please be a bit louder into your mics.
All of you. You'll have to speak louder. Direct question to team 9. Again, focus very carefully on this. Which drug commonly used in endocrinology? I'm not saying it's an endocrine hormone or anything. Drug commonly used in endocrinology for a variety of conditions is banned in sports for use in shooting. Why? Which drug and why? All of us use it.
Hint, try to understand what's being used while shooting.
I'm not saying it's a hormone or an endocrine substance. It's a drug used in endocrinology.
You need to take aim.
And why in shooting? The clues are there. Pass? Time's out.
Hydrocortisone.
I said it's not a hormone. You had a clue there. Team 1, you pass on to team 2. You have an answer or not?
Tropicamide for
Team 2? Why? That is right.
Correct.
That is the correct answer. Beta blockers to reduce tremors and improve accuracy. Plus 10, that's again a very good answer from team 3. Direct to team 4. A very interesting answer. Question. Devoted fans of this particular sport released high levels of cortisol when watching this sport, even on TV due to identity fusion. This is a team sport where players play in particular positions. There are so many players, each of them plays in one particular position. Players in X position also experience a sustained rise in cortisol, which has contributed negatively to their performance. There is another set of player or players who plays in another position in the same sport in the team, who have short bursts of cortisol, which improves their performance greatly. So what is this sport? What position do these players X who have a negative effect of cortisol on their performance play in, and what position do these players who have short brief bursts of cortisol, which improves their performance play in? Give me the sport, position X, position Y.
Rugby, sir.
Next team.
Kho-Kho.
Use the mic.
football.
And positions, X and Y.
X is the striker and Y is the goalkeeper.
Plus 10.
I mean, this was very logical. Identity fusion. It's pretty much spelt it out there.
And the correct question for West Bengal, right? Team 6. Football. Strikers have a sustained rise of cortisol, which negatively impacts their shooting capability. Goalkeepers have very small bursts of cortisol rise only when the ball comes to the goal, so it helps them play better. Direct question to Team 7. In 2003 Cricket World Cup, leg spinner Shane Warne was sent home after testing positive for a banned substance. Which drug was it, and why did he claim to have taken it, and what was the outcome? This I'm sure everybody has read. We lived through this. No answer? Telugu Titans?
Team 8.
Cannabis.
I will ask you later how you came to that answer.
Team 9. Cannabis was Wasim Akram, 94, West Indies. Team 9.
Cocaine.
Team 1. It's a lot more easier than that. Again, it's not a hormone.
Sildenafil.
No. He didn't really need it. Team 2.
Alcohol.
Alcohol is still not a banned drug. Team 3. What is the answer?
Please
not anabolic steroids. Team 4. Team 4. No. You don't have an answer?
LSD.
No, not quite.
Amphetamines.
Team 6. It was a direct to Team 8, right? Direct to you.
Glue.
What?
Glue sniffing.
Not glue sniffing. Audience? Lasix, diuretics. The answer was diuretics. Hydrochlorothiazide, he took hydrochlorothiazide and amiloride to improve his appearance, but it's actually used to mask doping. Anabolic steroids will not be detected if you use any of the diuretics, and that's why he was suspended from cricket for 12 months. If you'll see the World Cup, 2003 World Cup, he didn't actually play in the World Cup. They did win it, we lost in the finals, but they had a tough time because of absence of one. He returned back in 2004 and continued his career successfully. So direct question to Team 7 again. Former UK Prime Minister Theresa May was initially diagnosed with an endocrine condition, but later reclassified as having a rarer form of the same disease after genetic testing. Which condition?
It did come up in the newspapers.
Team 8.
Adrenal insufficiency.
9.
Does she look like she had adrenal insufficiency?
Team 9.
Pheochromocytoma.
Team
Sir,
1.
type 1 diabetes.
And reclassified as?
Mitochondrial diabetes.
Team 2.
Modi.
I'll give +7 to Team 1, +3 to Team 2. It was not mitochondrial, it was Modi, and it was a toss-up between type 1 versus type 2, but she was on insulin. +10 to Team 7 and 3. Direct question to Team 3. So, I'm sure all of you have seen the film Munich, and you know about the Munich Olympics. In addition to the Black September and the Wrath of God incident, Munich Olympics are also famous for what landmark step? That is important to us as endocrinologists. Anybody wants a clue? Any objection to giving a clue? They did something in the Munich Olympics which had not been done till then, which is of huge importance to us. You tell. That is a direct question to Team 3.
They allowed transgenders to play.
Team 4. Team 5. Team 6. You will have to be louder.
Used growth hormone for the first time.
Team 6 has to speak louder. Team 7? Team 8?
Israel athletes were killed actually.
That is already mentioned there, the other thing. That was
Black
the
September.
Black September incident, right? Zwad El-Zweiter. 9?
Doping test.
Plus 10 to Team 9. That was the first Olympics to introduce anti-doping measures and tests. Direct question to Team 1. Which actor admitted to using testosterone gel and growth hormone in 2013 documentary The Truth About Testosterone, sparking debate about low testosterone clinics?
Arnold Schwarzenegger.
Team 2? Team 3? Team 4? Take a guess, educated guess. It's a very
Alex,
easy
can you
answer.
ensure that the mics are loud?
Team 5? Team 6?
Dwayne Johnson.
Team 7? 2013. Team 7? You'll have to be louder. No.
Sylvester Stallone.
Plus 10 to Telugu Titans. It's Sylvester. You said Schwarzenegger. The next option was Stallone. During Rocky. Now we'll stop with this third round and we'll go to the frenemy round, the last round. I think time is running out. Can we have the chits, please? Can somebody from Team 1 come and pick up a chit?
Someone with a lucky or an unlucky hand, whichever way that goes.
Just give me a paper. Huh?
Sir?
Yeah, shall we have the scores now? Bolo. Aajao.
So team 1 is at 17, team 2 is at 3, team 3 at 25, team 4 is at 20, team 5 is yet to open account, team 6 32, team 7 17, team 8 is at 30, and team 9 is at 20.
Wide open.
Okay.
So Team 1 has got Team 4. Take it. You can target Team 4 with a question. Team 2.
Someone from you.
Take paper or pen. छोड़ो बस पेन नीचे. Team 2 का क्या है? Team 8. Keep the chits with you. Team 3 come and pick up a chit. Huh? Yeah?
You haven't got the chit? Discrepancy in scores? Which, okay.
What is the discrepancy?
Team 3K.
Team 4, have you picked up your slip? Go and pick it up quickly. Do it quickly.
3 has got the number?
3. What is your number? Did you pick it up?
No.
1 minute. Let 3 pick it up. Then 4.
The number is?
Number is?
9.
Team 4?
4 is 5.
5. You keep the slips with you. Team 5?
5 is? 5 is? 3.
6.
2.
7. 9. 7 gets 9. 8. 7 gets 6.
8. 8 gets? 1. 9 gets?
9 gets?
7.
Can you read out? You got team? You?
8.
Your
got
team?
9. 4, 5, 6, 7, 8, 9.
And you'll have to shut off the display, please, while we are going through the rounds. You'll have to shut it off when I tell you to shut it off, and open it up when I tell you to open it up. And pay attention here, not over the phone. So we have 8 topics. We've got 1 adrenal, 2 pituitary, 2 questions on pituitary, 1 on testis, 1 on thyroid, 1 on parathyroid, 1 miscellaneous, 1 ovary, and 1 pancreas. So team 1, you will get to choose a topic for team 4. Yours is 4, right? So what topic do you want to give them? Which gland do you want to hit them with? Huh? Ovary. Okay. Just wait. Abhi nahi. You've been actually very kind to them. Now, Abhi bol. What are the 3 components of Perold syndrome?
Team 4.
Premature ovarian insufficiency, deafness,
You said,
mitochondrial inheritance.
could you please repeat it once again then, 3 components?
Deafness, POI and POI, deafness and sensory neural deafness and mitochondrial inheritance.
Mitochondrial?
Inheritance.
Inheritance.
I'll do one thing. This round also I'm going to pass it on because we want to have a level playing field. We'll give 7 marks to team 4. Then pass it on. What is the third component? They've got 2 of them right. I won't tell you which 2. What is the third component?
Nystagmus, sir.
You'll have to be more specific. 8. Titans.
Short stature.
9.
Coloboma.
I'll paraphrase it. Team 6 said nystagmus, right? I'll just put it, the third component is, I'll not say specific, it has to be wider. You're only picking on one aspect of some particular disorder. There is a whole group of one particular organ which is affected by this particular Perold syndrome. So that goes on to 7. I am going on to 7. I'm not coming to you. 7. No answer? Team 8. Team 9. We'll have to be very quick because we are running out of 1, 2,
Thalmoplegia.
3, 4. I said don't be specific. I said be general.
Broad strokes. Third
Very
component.
broad.
Not stroke, by the way.
5.
Cerebral ataxia.
Audience? CNS complication. If you had just said CNS, you would have got the answer. Because there are multiple
POI
components.
and neurological components.
Neurological. So, plus 7 to team 4. Your switch off kar do.
Switch off.
Band kar do. So now ovary is out. Which is your team?
Team 8.
So you have an option of giving them between adrenal, pituitary, testis, thyroid, parathyroid, miscellaneous and pancreas.
Miscellaneous.
Miscellaneous. That is team 8. Team 8, please. Which is the richest plant-based source of calcium? And don't say milk because cows are vegetarian.
Mike.
Team 9. Team 1. Irradiated mushrooms are a rich source of vitamin D, not calcium. Team 1. Team 2.
Ragi.
Team 3.
Millets.
Team 4. Team 5? Team 4 said mustard. Team 5? Huh?
Pistachio.
Pistachio. Team 7? Usmania Pleston. Yeah, they didn't answer it right. It's Pleston to Usmania. It's actually sesame seeds. They have the largest, by far the richest source of plant source of calcium. 950 mg per 100 gram. The direct question, next question.
Please close the display.
Team 9.
Please close the display.
Display. So now your options are adrenal, pituitary, testis, thyroid, parathyroid and pancreas. Testis. Team 9 is going to get testis question. So question to team 9. Aap karo. What is the definition of oligospermia as per WHO 2010 criteria? Straightforward, easy.
Oligospermia.
So it is defined as sperm count less than 1.5 millions per ml.
Team 1.
Less than 10 million pari jaake.
Team 2.
16 million.
Team 3.
Less than 15 million per ml.
Plus 10 to team 3. It's not 1.5, it is 15 million per ml.
15 million. 15 million.
So, team 4, which team? Now testis is also out. Team 4, who is your mark?
5.
Team 5, what do you want to give them? You got adrenal, pituitary, thyroid, parathyroid and pancreas.
Pancreas, sir.
Close कर दो. Team 5, अभी open कर दीजिए. Among the islet cells of pancreas, which is the least numerous type?
Delta.
This answer I am not going to pass on because you have only few options. So this answer will not be passed. I thought everybody would get it easily. Audience will ask the audience. Which one? Not, definitely not beta.
Definitely not beta.
Beta is the most numerous.
Least numerous.
Least numerous.
Audience only.
Audience only. We said delta is not the answer, beta is not the answer. So what are your options left? We have some audience prizes also. So at least for the prizes. We don't have an epsilon there. We have, yeah, but not the least numerous. Who said PP cells? Somebody said PP cells here.
I heard it from here first, somewhere here.
It is PP.
Who blurted it out? You can get a 5-star.
Yeah, 5-star वहाँ पे दे दो.
RX, one audience prize. There.
Last one. 2 दे दो. ज़्यादा है ना?
Post quiz hypoglycemia.
नहीं कुछ ना कुछ patient बना देंगे ना.
That gentleman.
So no points to anybody here.
5th. From the left.
5. Whom are you going to target? Pancreas is out now. Who is your mark?
3.
3. So you got adrenal, pituitary, thyroid, parathyroid.
Thyroid.
Thyroid to team 3. बंद कर दो. Team 3, I'll be very lenient and broad here. Open कर दीजिए. Generally in our periodic table, what we read about is I-127. What are all the other isotopes which are used in endocrinology?
Please speak into the mic. Mic, please.
I-123, I-124 and I-131. I-131 is therapeutic, I-123 is the diagnostic, and I-124 PET CT has recently been come for diagnostic scans only, more specific than I-1.